Hello everyone, this is Vivian from ADNA. I'm the Secretary of the Australian Dermatology Nurses Association. I've been asked to talk to you about a few things with the upcoming conference in Adelaide next year. We did have one already in Adelaide this year in May. We successfully had a really good event organised largely by the South Australian State Representative and also by the ADNA Committee. There was a lot of input. There was a vast number of speakers there. We had someone from the Nursing and Midwifery Board and APRA. We had representatives from different nursing fields talking, especially experts. And I'll just go through a couple of things of what to expect, because to understand what happens at a conference, you really need to know what happened this time. So it gives you some idea, especially for the new people. So I have made some notes, so please forgive me. So to understand what it's like, it starts on a Friday. It's not mandatory, nothing's mandatory, but we start on the Friday because a lot of people get to the area earlier and they wanted to be able to earn extra CPD points. And so each year we've been having a CPR organised so that people can keep up to date with that skill. It meets nursing requirements and it's with a local expert from the area. And in this case, it was from the St John's Ambulance Service. Then one of the best things that happens is the welcome drinks night on a Friday. It sounds flippant, but actually it's one of the most fun times because it is warm, it's casual, you get to meet new people, you get to catch up with old friends, you get to network, you get to also be a tourist for one night, shopping and walking through the town and absorbing the atmosphere with the locals. I didn't understand it at first when I first joined ADNA. I didn't know that I could go. And perhaps we have not been getting that message across to you, that it's actually for everybody. And ADNA pays for the drinks. We sponsor the drinks. It's, you know, for a couple of hours. And it's just there just to get together. So I hope you can all come to that. On the Saturday, that's mixed with experts presenting in skin, dermatology, nursing and leadership. We have dermatologists, we have had psychologists, we've had experts from every field that you could relate to skin, because dermatology includes psychodermatology, as people have been learning in the graduate certificate in dermatology that ADNA also promotes through the Australian College of Nursing. So what else do we do? It's there for you to be able to have, take notes, to reflect, to add to your learning, and to collect, obviously, CPD points so that you can continue to work as a nurse in Australia. It lets you have time in the breaks to chat to friends and to sponsors, to expand on the questions you've had that you didn't get answered back at your workplace because of time limitations. Everyone is there to learn, and it's an atmosphere that's very positive and enriching. Another thing I wanted to let you know about is the ADNA Sponsor Awards. So ADNA has some awards, and the sponsors have also generously donated awards. And these are presented on the Saturday afternoon and at the nighttime dinner. The requirements are changing for these awards, most of them, particularly the ADNA ones. We're making it clearer. We're making it so that people are motivated to apply for the award. It ends up being up to you. There are different things, have a look at them. They'll be there in the next couple of months so that you're ready in time for the conference. We're changing them so that you can increase your learning. You can add to other nurses' learning It gives you opportunities for your efforts to be published at the conference and also on the website. So we'll be adding to nursing knowledge. And that has been ADNA's aim. And it's been our focus recently to really add to the nursing knowledge. And there are many experts in dermatology nursing, and we need to see what you know. We're aiming to also meet the NMBA standards, which are provided for nurses. And that means that we share our skills and encourage and educate others, as well as increasing patient care. So keep an eye open for that. Next, the Sunday morning. It's full of information. It's shorter. It's ready for everybody to be able to then go and catch their flights home again to their respective states. And it's still jam-packed. Make sure you take notes. It's difficult to remember things when they're quite close together like that, but we still have our break times and we still have extra time to talk to each other and eat goodies, collect bags of goodies, and the sponsors bring things along for us to be able to take home. So maybe you need to check in your luggage when you go home again. And also, one other thing, we're hoping to run workshops. We have had challenges doing this in the past, so room availability this time. So watch for information on the website as the conference begins to be promoted. And thanks again for listening, and please enjoy this Education Day that Shelley has worked so hard to put on for all of us. And I will talk to you later. Bye-bye.
Thanks, Viv. So one day I walked in a conference room and I didn't know anyone, but I sat down in there and I listened and I took down some notes. And during the trade exhibition, I've met a few people, now a lot of people, and started networking. This was my first experience in a state education day. And it was really nice. And now I have been part of ADNA ever since. And now I'm your New South Wales representative. So we try to be inclusive. Every year after every education day, we send you a survey asking for your feedback. And we try to organize a program and have a list of speakers and different topics that you would want to hear for the day. So hopefully you will enjoy today's presentations and our lineup of speakers and presentations. Now we're a little bit behind time, so without further ado, I will introduce our first speaker. Dr. Belinda Lai is a dermatology clinical research fellow at St. George Dermatology and Skin Cancer Center, and a Master of Philosophy student at the University of Sydney. Belinda is interested in dermatology and pathology. Please all welcome, talking all about alopecia, Dr. Belinda Lai.
Good morning, everyone. I've got the pleasure to kick off today's events. I hope everyone's remembered to vote for their local government council elections as well. But first off, we're going to talk about everything about hair and hair loss. So we'll just go through a little bit about the anatomy and the physiology of the hair growth cycle, and then we'll go through to the fun part where we've got all the hair loss conditions. So what is the point of hair? So firstly, it gives us tactile sensation, allows us to feel, give us feeling. Secondly, it's really important insulation. It's important to prevent from hair loss, from heat loss rather. Next, it's really, really important for protection, especially from the UV solar radiation. And last but not least, it's really important in our perception of beauty and attractiveness. And generally, it's a common societal thought that if you've got, really nice, healthy hair, it's associated with beauty. And as we can see here in this L'Oreal ad of Blake Lively with her long, luscious locks. We can't forget about the psychology of hair. It really impacts our psychological perception of ourselves, and it can greatly impact our mental health. And for example, when we see someone with a decreased amount of what is deemed to be normal amounts of hair, for example, if someone's going through hair loss during chemotherapy, we can associate that with impaired health or being unhealthy. And for example, in the second picture, when we have someone that's experiencing maybe male pattern hair loss, we can associate that with age as well. And on the opposite side of the spectrum, when we have what we perceive to be excess amount of hair, such as a lady with hirsutism, it can be perceived as unattractive. And the fourth picture here is somebody that has hypertrichosis. And it's estimated that people spend about $3.5 billion a year on trying to treat hair loss and hair care products. So just briefly going through the anatomy of the hair follicle, if we look at the hair shaft, there's 3 concentric layers. The middle layer is the medulla. It's very glycogen rich. And then the layer around that is probably the more important layer, the cortex. And that has a lot of filaments in the helical structure of keratin. And that's what gives the hair actual tensile strength and elasticity. The next layer is the cuticle, which is about 10 layers. And you can see it's got like a fish scale shape or pattern, or like a roof tile pattern. And that's what reflects light and gives the hair the shine and the feeling of good health. Last but not least, we've got the hair bulb, which is at the bottom here. You can see that there's the dermal papilla and that there's blood vessels feeding into the hair follicle, giving it nutrients. There's also fibroblast cells there. And then you've got the matrix. There's a lot of rapidly dividing cells here that gradually migrate up, and they eventually die, and then the keratin gets trapped into the hair shaft. And that's what makes up predominantly the hair shaft. So our hair grows in a cycle. The first cycle is the anagen phase. So this is the growth phase, and this is where you've got your hair follicle and all the cells actively dividing. It's a mitotic stage, and about 85 to 90% of the scalp hair is in this stage at any point in time. This stage can last a long time. It can last 2 to 6 years. And then after that, the hair follicle goes into a catagen stage, which is like a degenerative stage. You can see that the hair bulb itself has involuted. It's a lot smaller. The diameter is a lot less. And this stage lasts about 3 to 6 weeks. Your hair at different places of the body will have different lengths in terms of how long the duration of their anagen and the catagen cycles. And then last but not least, we've got the telogen stage, which is the resting phase. It's very quiet. You can see it's still really small. And about 1% of your scalp hair will be in this stage. And then after that, you've got the estrogen phase, which is where your hair is actively shedding. I just want to touch on the nutritional effects of hair and hair growth. You can get most of these from a well-balanced, varied diet. But you've got your B complex vitamins. They're really important in hair growth. Your water is really important to maintain the moisture in your hair. Your antioxidant A is also important. Silica is really important for the strength of your hair, and selenium is also important for scalp health. And you've got your omega fatty acids, which is also important as an anti-inflammatory effect. So just some quick, fast facts about your hair follicle. We've got about 100,000 scalp hair follicles, and it's a little bit more in blondes and a little bit less in redheads. African Americans and Asian people usually have a lower density in scalp follicles. The lifetime cycle that I just mentioned is about 10 to 20 times. And normal hair shedding rate is about losing about 100 to 200 hairs a day. Could be up to 50 to 200. Your hair shaft grows on an average of 1 centimeter a month. And those with dark hair have a predominance of eumelanin, and blonde hair have a predominance of pheomelanin. So now we get to the more exciting part, alopecia. So alopecia means hair loss, and it comes from the Greek word alopecia, which means baldness. And when you have the shedding of hair, it's called effluvium. And when that becomes an actual condition, then it's called alopecia. And alopecia is usually categorized into two subsets. We've got non-scarring alopecia. So non-scarring alopecia means that there's no actual damage to the hair follicle. There's no inflammation around the hair follicle. The hair follicle is generally intact. And if there is non-scarring alopecia, usually there is a chance to revert back to normal. However, if you have scarring alopecia, there's active inflammation around the hair follicle. It's getting damaged. It can atrophy. And the alopecia is generally permanent and it's not reversible. So today we'll start the talk with non-scarring alopecia. So I find it a little bit more interesting to go through these conditions through cases. So let's say that we have a 60-year-old female and she presents quite worried that her part is gradually widening. It's a very gradual process, and she's noticed that her ponytail is slowly getting thinner. She remembers that her mother had a similar problem, very anxious about it, and it's starting to impact her social life as well. And as you can see here, the part is quite wide, and if you use your imagination, it's meant to be a Christmas tree pattern. So this is an example of pattern hair loss. It's also known as androgenic alopecia, androgenetic alopecia, but I believe pattern hair loss is the term that's commonly used now. And you can get it in, there's a male type and there is a female type. So we believe that there is a genetic predisposition to this condition. Usually there can also be an androgenic effect, and it's from the actions of androgens on the actual hair follicle. This condition usually affects men a lot more than women. And it's basically due to the testosterone being converted to DHT by an enzyme called 5-alpha reductase. And this acts on the hair follicles to inhibit it. So for men, it usually occurs a little bit earlier, could happen anytime after puberty. For women, pattern hair loss can occur a little bit later in life. There's actually a way to classify pattern hair loss. And for male, we use the Hamilton classification, where we grade it from 1 to 4. And you can see that the hair loss is generally it starts at the anterior and it recedes back. It usually affects the vertex and the crown, but you still have hair remaining in the occiput area. Whereas for females, it's generally the part that is affected first, and then you get a Christmas tree pattern where the hair loss is a little bit more prominent at the front than the back. And you classify the pattern hair loss in women through the Ludwig classification, where they grade it from 1 to 3. So how do we diagnose this condition? Usually a really good history is key. There's no really other invasive tests that are required. And you can also have a closer look at the hair through trichoscopy. And you can see that there's if you can look closely, there's a lot of different diameters in the hair shaft. That's usually a clue. You can also see that there is a peripilar sign through that yellow arrow there. And that's the brown color that you can get surrounding the hair shaft. And depending on your differential diagnosis, you'll be doing hormone studies. Generally, if anyone has a hair problem, you'd be doing like a ferritin level, a testosterone, a thyroid function level as well. So managing pattern hair loss, I feel like a really important part of it is counseling. There's actually no cure for pattern hair loss. So it's really important to manage the patient's expectations. The goal of treatment is to prevent further hair loss. And, and if you're lucky, maybe we can get some extra hair growth as well. So it's really important to note that don't believe in those expensive treatments that might not work and is unproven. Some non-pharmacological therapies would include just general hair care. So they'll be using, a fine tooth comb that won't break the thinner hairs, using a towel that doesn't produce as much friction when you're drying your hair. Additionally, there's some hairstyling tips that we can offer as well. For example, adding layers to the top of your hair or adding a bit more volume through curls. And camouflage. Camouflage is also quite useful too. As you can see, there's an alopecia masking lotion that can provide a bit of a tint to cover the balding areas. Or you can even get a spray that you spray onto your hair, and it creates a little bit more thickness and volume. And then, of course, there's pharmacological treatment and surgery. So these treatments generally differ between men and women, but usually first line is a topical minoxidil 2 to 5% lotion. A lower dose is generally used in female pattern baldness. We also have your androgens that block the androgenic effect, so such as oral finasteride, oral dutasteride. And for women, there's spironolactone as well. It can also inhibit the androgen production in the ovaries, and cryptorone acetate as well. And this will obviously depend on the gender of your patient, whether they're childbearing age. And there's some pictures there of those products. So that was that case. So now we move on to the next case, which is we've got a 28-year-old female. She presents noticing a small bald patch on her scalp, and this occurred around about 6 months ago. Recently, the larger patch has suddenly appeared, and there's also some loss behind her ears. She's had some recent stresses at work, and she remembers her mother had a similar problem, and there's a strong family history of autoimmune conditions such as diabetes. So this is a case of alopecia areata, and the hair loss here is generally quite ovalized in circular patches. And this affects young people more, young adults and children. And around 10 to 20% do have a family condition for alopecia areata. And this is proposed to be an autoimmune disease that involves T cells. And this condition can affect the whole of the scalp, also known as alopecia totalis, or if it also affects your eyebrows and your eyelashes and the rest of your body hair, it's called alopecia universalis. And the hair follicle is actually a really interesting site. It's called a site of immune privilege. So it's one of those sites where if you put a foreign tissue in there, that tends to survive a little bit longer than other places in the body. And they hypothesized that to be there's a decrease in immune system action there. There's decreased MHC complexes, there's immunoinhibitory signals. But we think that in alopecia areata, the opposite occurs, and there's more inflammatory infiltrate around the hair follicle, as you can see here, with all the cytokines drifting around and attacking the hair follicle. So there's a lot of clinical manifestations for alopecia areata. So in A, you can see the patchy hair loss in a more circular spherical shape. In the next picture, you can see it's a little bit more extensive. And in C, I don't know if you can see, but there's like hairs that look like an exclamation point. And then D, you've got total scalp hair loss. With E, this is another common pattern of how hair is lost. It's called an ophiasis pattern, where you get a band-like hair loss around the occiput region. In F, you can see that sometimes your grey hairs remain, but other pigmented hair is lost during this condition. And in alopecia areata, it can also affect your nails too. You get pitting. So again, alopecia areata, the management is quite difficult because sometimes the condition can resolve back on its own, and then you can go into remission again. So it's a long course. It's a big journey, but there is no cure so far, again. However, we do have a few weapons in our toolbox to use. So there's topical, intralesional, and systemic corticosteroids. Again, we've got topical minoxidil as well. We actually don't really know how that works, but it seems to be effective. Topical irritants, as well, DPCP you can use. You can use other systemic cyclosporin or other steroid-sparing agents like methotrexate, which is what we use for psoriasis as well. Topical orophotochemotherapy, and some new and upcoming things are the systemic JAK-STAT pathway inhibitors. So the JAK-STAT inhibitors are drugs that look promising for alopecia areata. Tofacitinib is one of the examples. They were using this to treat psoriasis, and they noticed that it also helped on a patient that had alopecia areata, and their hair started to come back. So there's a lot of clinical trials on these JAK-STAT inhibitors, but the problem is you seem to go into relapse after you stop using them. So it looks like you have to use them for a very, very long time. There's also platelet-rich plasma, PRP, that's being used as well. So what happens is you get the patient's blood sample, you might have to centrifuge it once or twice and get all the plasma that's platelet-rich. And the idea is that in that plasma, there's a lot of growth factors there that will help support the hair follicle to go back into its normal hair growth cycle. So that was alopecia areata. And now we will move on to the next case. Next, we've got a 42-year-old female, and she presents saying that she's got a really dramatic and abrupt drop in her hair volume that started about 2 weeks ago. And 3 months before this, she tells you that she actually fell ill with COVID. And a pool test was strongly positive. We'll get back to that a little later. And if you look at her hair volume, there's no scaling, there's no erythema, and the trichoscopy was pretty normal. So this is an example of telogen effluvium. And this happens when you've got increased shedding of your telogen hairs from the resting scalp follicles. And it's usually because of some stress. You've got a rapid shift of the hair from anagen into catagen and telogen stages. And then it results in a increased daily hair loss. And it usually affects female more than males, because postpartum can also be a trigger for telogen effluvium. And a gentle hair pull test might be useful in certain cases. But what you do is just gently pull in the hair, and if more than 2 come out, it's deemed to be positive. And you can also look at the hair in more detail and determining the ratio of the anagen and the telogen hairs as well. So going back to the triggers of telogen effluvium, so nutritional deficiency can be a trigger, rapid weight loss or protein deprivation as well. Physical stresses such as febrile illness like the COVID that patient got, major surgery and trauma, even psychological stress, intoxication and drugs. And generally, you will get, there's nothing that you need to do for this condition. You generally will get a complete regrowth of the hair. Okay, so moving on to the next case. We have a 12-year-old female who comes in with hair loss for the past 6 months after some family conflict. And the mother noticed that the patient was quite nervous and had uncontrollable urge to manipulate the scalp. And when we looked at the hair, we could see that there's diffuse thinning and there's short, jagged and broken hairs, all at different lengths. And there was a negative tensile test. So this is an example of trichotillomania. And what happens is there's a self-induced pulling of your hair, plucking or breaking your hair. And this is usually associated with a psychological stress or a personality disorder. And it's also listed in the DSM-5 under obsessive, compulsive and related disorders. So what happens is you get also patchy or maybe even full alopecia of the scalp. Your eyebrows and eyelashes can be affected if the patient's plucking them as well. And they're usually bizarre, like really bizarre shapes, different lengths of hair. And you've also got the actual breakage of the hair as well. There's no specific treatment for this. Obviously, we've got some psychotherapy modalities such as hypnosis, behavioral modification therapy, insight-oriented psychotherapy. So it will require some liaison with some psychologists or psychiatrists. There has been some proposed pharmacological therapy, such as N-acetylcysteine, clomipramine, your SSRIs as well. Okay, so moving on to the next case. We have a 25-year-old male. He's had flu-like symptoms for the past few weeks. He's also got hypertension, tachycardia, and within 3 days, he developed some weight loss, peripheral neuropathy, and feeling really tired. You can see he's got diffuse hair loss here, diffuse alopecia, no active inflammation. The follicular ostia is preserved. And you've got a positive pool test, and you can see anagen hair. And he also tells you that he is a chemistry student working on thallium. So this is a case of anagen effluvium. This is what happens, what can happen if you get exposed to radiation therapy to the head, or chemotherapy with alkylating agents, or intoxications like that case here who had intoxications from thallium. Can also happen with protein malnutrition. And this is a really rapid onset, extensive loss of hair, and it can happen like within 3 weeks after chemotherapy. And it occurs because there's actual damage to the mitotic and the metabolic activity of the hair follicle. Generally, hair can regrow after the discontinuation of chemotherapy. But however, currently they are using cooling caps and scalp tourniquets like this lady here, who's wearing that when she gets a chemotherapy treatment, and actually lowers the scalp temperature to around about 24 degrees. And the idea is to reduce the blood flow to the scalp area, so you reduce the chemotherapy drug exposure to the hair follicles in that area. Okay, so we've just talked about a bit about alopecia non-scarring, but now we're going to move on to scarring alopecia. And again, this is where we've got actual damage and destruction to the hair follicle. There's inflammation. It's also known as cicatricial alopecia, and it can also be atrophy of the hair follicle and scarring as well. So I hope you're not getting tired of the cases, but we have another one again. So we have a 30-year-old female, and she again presents with patchy hair loss on her head. This started around about 1 year ago. It's itchy, it's slightly painful. There's a red scaling rash on her scalp, and it occurred about a month after she dyed her hair. Has been treated with antifungal and other treatments unknown to her, but they didn't really work. And the lesions have worsened, and also new lesions have appeared as well. And you can see a little bit of the scaling on her scalp there too, with some erythema as well, and maybe a bit of hypopigmentation. So this is one example of the many causes of cicatricial or scarring alopecia. So cicatricial or scarring alopecia can be caused by a lot of different things. So it can be caused by an inflammatory process. It can be caused by infection, such as carrion or herpes zoster, even like trauma to the area, like a surgical scar, or even primary metastatic neoplasm to the area can cause cicatricial alopecia. And again, as I mentioned before, this scarring is irreversible. And this is another picture showing scarring alopecia in someone with discoid lupus erythematosus, which is what that patient had. So discoid lupus erythematosus is actually an autoimmune connective tissue disorder, and it can be part of the systemic lupus erythematosus spectrum. And these lesions usually occur like that patient on the scalp, can also occur on the face and the ears, and can involve their hair follicles as well. And a really important part of this condition is sun protection. And management for this condition is mainly aimed at reducing the activity of this disease. We also have another condition called central centrifugal cicatricial alopecia, another form of scarring alopecia. And this condition occurs in Black women, mainly over the age of 30. And you can see that there's a lot of hair loss at the crown that eventually gets wider and wider, as you can see in this stage 1, stage 3, and stage 5. And they don't really know why this happens. Maybe there's an anatomical difference in their hair follicle, but very caustic hair care products can worsen this condition. And some patients experience some burning, itching, scaling, and flaking as well. And treatment for this is a really long-term antibiotic and a potent topical steroid as well. So we've got another form of scarring alopecia, which is dissecting cellulitis of the scalp. Again, this more commonly occurs in Black men. There is really, really deep inflammatory nodules down to the subcutis, and they can all coalesce and become quite boggy, can even form fistulas. And a secondary infection of Staphylococcus aureus is quite common. Lots of treatments, surgical approaches as well if we need to drain anything, isotretinoin, intralesional corticosteroids, and oral antibiotics as well. And it's also important to tell the patient of general hair care advice, such as using antiseptic washes, avoiding oil-based hair products as well. And it's important to treat this quite early. Acne keloidalis is another form of scarring alopecia, and this occurs in Black men, but it can occur in women and Caucasians as well. It's also known as a mechanical folliculitis from haircuts, and it usually occurs in the occiput at the nape of the scalp, at the nape. However, it can also occur anteriorly as well with a papular or pustular eruption. And treatment for this usually is a potent topical steroid, and again, a long-acting oral antibiotic. You can also use laser-based hair removal as well. And we've got the last condition here. So there is also a condition called traction alopecia. And what happens here is at the beginning, it might be a non-scarring condition where there could be potential for regeneration, but then later it can go into a scarring form of alopecia where there's destruction of the hair follicle and hair cannot grow back. It's common in African American women, and they usually present in their 30s and their 40s. And there's a lot of markedly reduced number of terminal hairs, and concurrent folliculitis is also possible. So to manage this, it's really important to make sure to cut long hair so there's less traction, make sure I have looser hairstyles, and avoid really caustic hair products or chemicals and heat. So we covered most of the things of scarring alopecia. There's some other conditions as well, but that brings to the end of my talk. Thank you very much.
Any questions? We'll just pass on the microphone to you. Just wait on a second.
Oh.
Only because I don't know any caustic hair products. Can you name some? Just
I think something like really damaging, like hydrogen peroxide and things like that. Yeah. Yeah. Ask your hairdresser as well. Yes. I believe if you target early, there is a chance, but as it is a form of scarring alopecia, yeah. Yes. Yes, the poisoning. Yeah, thallium poisoning.
that's directly
From the chemical. Yeah, yeah. So yeah, toxic substances, yeah, chemotherapy as well. It's very rare though. If you're a chemical student working on that substance, there's a risk. Thank you.
All right, thanks, Belinda. Our next speaker has been working at St. Vincent's Hospital and the Skin Hospital, where she has been conducting a mostly skin clinic. Her research interests include HIV research and has helped set up the Pacific Dermatology Training Center in 2019 in Suva, Fiji. Presenting Rosacea, the Basics and Beyond, our keynote speaker, Associate Professor Margot Whitfield.
Thank you very much, Shelley, for being so amazingly organised about this meeting and being extraordinarily adaptable. My great respects to her, and it's lovely to see so many people. It's really exciting to have an in-person meeting again. So I'm going to be talking about rosacea. So I was asked to talk about whatever I wanted, and I thought about what I would talk about. I could talk about HIV or Fiji or scabies, and I decided it was time to go back to rosacea. And I've looked today at the sponsors, and 3 of the sponsors here have an awful lot of products regarding rosacea, which is coincidence. I have no conflicts, but Propera and Pierre Fabre and Galderma have all been particularly influential in developing products associated with rosacea. I'm sure you'll hear about them later. So acne, perhaps, Shelley, I realise why they're not using the screen. The screen's only got a really small thing, so you can't read it. So acne perhaps has received sufficient share of attention to necessitate some apology for writing on the subject. And it's 150 years later, we're still apologising for talking on this subject. So how do we classify rosacea? It's the most extraordinarily diverse disease. So we've got our 3 classifications, our rosacea, our flushing. We're all familiar with people who've got the red face. So we've got our erythematotelangiectatic, papulopustular, phymatous, or ocular. So, but there's sort of like not one real driving overarching cause of rosacea, which hasn't been described. I happen to have some theories, but they will take me forever to talk about, so I'm not going to do that now. However, they include genetic. So there's genetic and tendency factors, like you've got a tendency to eczema, you've got a tendency to rosacea, you'll inherit some certain genes that mean you're predisposed to having an inflammatory process, environmental, vascular, inflammatory factors, and skin damage associated with ultraviolet damage. It's probably working by immune effects on the skin, but also we all know that if you're really sun damaged, you get broken blood vessels, you get erythema of the skin, which is not actually rosacea, but it is does have a tendency to make you get the telangiectatic vessels. So this is what came out. I saw this when I was going and reviewing stuff, and it came out in November. And this is a screen, which I'm not going to talk about, but it means different people are now trying to join all the different inflammatory pathways together to try and understand what happens combining ocular and cutaneous rosacea. So we just quietly ignore that. So I'm talking about the clinical diagnosis and treatment of rosacea. So we think of pre-rosacea, erythematotelangiectatic and pustular, but flushing and the pre-rosacea phases are the ones that are persistent throughout the diagnosis of rosacea. Whichever stage of rosacea you're likely to have the background of flushing, which is fundamental to it. And when we think about what are the causes of flushing, the causes of flushing are the ones, oh, that's great, alcohol. I can now look down here as well. Alcohol, hot, spicy foods, environmental factors, stress, hot drinks, temperature change, and others. And if we think about why we flush, we can either think of what on earth is flushing all about? So how is it mediated? It's actually mediated, the technical pathway is that flushing is mediated by the sympathetic nervous system, which causes vasodilation of the vessels. All right. Sometimes it's reduction in vasoconstriction, but mostly in rosacea, it's active vasodilation of the vessels. So we get that as part of the fight and flight response for a lot of people, and that fight or flight response may be triggered by stressful events. But the other major reason that we have to be able to flush is to cool the brain. So it seems to be that different races have different ways that they cool the brain, and the brain's only copes with a very, very small margin of temperature change. And so it means that the skin gets extremely hot when you flush, and it allows the ambient air to cool down the skin. And that cooled down blood, which is on your cheeks, can then track through the vessels that go from the face directly into the brain to help cool down the brain. So its fundamental thing is about importance for temperature control. And so I like to think that in fight and flight, people's blood goes to the muscles and goes to their heart and speeds all of that up. But for the people who are not going to escape, they make their brain more efficient, which it is when it's cooler. So they think their way out of the problem. So how's it mediated? This is the most fantastic picture that I found in a journal article of somebody with Horner syndrome, where the sympathetic nervous system had been injured, because the sympathetic nervous system goes from the hypothalamus, which is here, then it goes down to the neck, and then it comes out and then goes up through, comes down to the spine, and then comes up through the neck up to the head, to go to both the skin and also to, well, mostly just to the skin and skin and scalp hair. So you can see that this man has had he had a carotid artery dissection, I think, and that damaged the sympathetic pathway up to that portion of his head. So he's unable to flush in that area. So they've made him go for a run around the block, and the whole of his skin was able to flush, except for the area where the sympathetic nervous tract had been blocked. So that's one of the pathways that we do for some of the treatments of our rosacea and why they work. So what is it again? We just think erythematotelangiectatic. So when you think about, I'm just going to put my time, make sure my time is back on. Sorry. Back on. Perfect. So erythematous and telangiectatic reflects the fact that if you flush, your cheeks go red. And if your cheeks flush a lot, then I like to think that it's just the capillaries that are there, just they get a little bit wider and they lose their ability to vasoconstrict. And certainly when we see people, when we use some of the products designed to reduce flushing, they're unable to get rid of the telangiectatic vessels, which don't have that capacity to vasoconstrict anymore. And so you'll get persistent redness. So the classic areas are the chin, the cheeks, the forehead, and in some people, the ears. So you can see this lady has got a mixture of things. So I know her, and she has a, oh, does that work? So she has, you can see she's got telangiectasia all here. So she does flush, but she's also very sun damaged. The best people to see as far as seeing what telangiectasia you get from the sun are the farmers. So if you ever see a really, really sun damaged farmer, it's fantastic if they've been wearing a hat all their life, because they've got these unbelievably clear scalps from wearing a hat their whole life. And you can see where their hat border stops and where the telangiectasia and the redness and the sun damage begins. So sun damage is certainly important for this. Another lady with who has been flushing for much longer, and again you can see the bright redness on her cheeks. She was very self-conscious about her redness. That seems to be that for temperature control, it seems as though Caucasians, we think of rosacea as being a Caucasian disease, and it's probably because Caucasians are more likely, I think that they evolved over the lifetime of us becoming humans, to be able to adapt to different temperature. So they have to be able to cope in hot temperatures and in cold temperatures. And so a quick thing of vasodilation was a good way of controlling the temperature of the brain. Whereas areas where people are more humid temperatures, which is where the darker skinned people came from, more equatorial originally, the black skinned or the maybe Asian's too complicated skin. That's a whole different thing. But the black skin, they sweat. So they don't use flushing as their primarily the way to cool their brain, but their scalp sweats. So they use air to cool the scalp, probably because most of their flushing was going to be due to heat, due to exercise. So again, this gentleman, it was one of my patients, and you can see he's got his erythema, he's had a skin cancer on his nose. But when you look next, you see that when you get up really close, he actually had micropustules on that cheek as well. And when you think about what a pustule is really a mixture of neutrophils and a little bit of junk in a pustule, and that can be triggered by stuff. So it means that that's what the inflammation's about. So it's being triggered for chemotaxis factors. So neutrophil chemotaxis factor is going to bring the neutrophils in to make the little small pustules. And the pustules often we find come on some years after the background redness is concerned. Certainly the skin changes at different temperatures and different proteins are made at different temperatures. So that may end up being part of that whole process as well. So sometimes the pustules get bigger. So this, this fabulous woman, she had really terrible pustular rosacea. It was absolutely destroying her life and her acceptability within the community. So she had a job and everyone thought that she was just, you know, she has this terrible rosacea. So she ended up being put on antibiotics. She ended up having some IPL or light-based therapies in the longer term, and she's now on isotretinoin, and she now has pretty normal skin, but still with some little bit background redness, but she's a much happier person. So, back, let's see. So the nose is phymatous change, which is angioproliferation and lymphoproliferative changes. And there's different reasons for different kinds of triggers for that, but it's in some ways it's another form of inflammation, but it does seem as though autonomic triggering is probably being able to produce that pathway in some people. So that's mild, got mild on the left. You can see that there's some little pustules on it. Most people with rhinophyma have pustules as well. And we're increasingly recognize that, particularly I think on the nose in the areas of rhinophyma, that the pustules of that are really very, very sensitive to topical ivermectin or topical anti-Demodex therapies. And certainly terrible rosacea can be treated surgically with shave destruction. So you can actually be quite brutal because they've got oil glands that go down all the way. So all their appendages go down really deep in the skin. So when people shave off the lumps and bumps, they actually have an amazing cosmetic result that you just wouldn't think that you could possibly get. You also, there are forms of, they're not commonly known, but there is a form of scrotal rosacea, which gives you erythema of the scrotum. And sometimes that's probably what a male disease of burning, I forget what they call it, something like burning balls syndrome, or I can't remember what it is, but that's what is described when you go, there's not that much in the medical literature about it, but if you go on the social media network, I forget what it's called, something like that. You know, anyway, so this is really, so if you think about that, the same vasodilation pathways are active in sympathetic nervous system, which also applies to the genital area, and scalp rosacea. Scalp rosacea is classically on the bald-headed areas. So it means in that area, that's also largely the areas where if we flush, it will extend up onto the forehead. So ocular rosacea. Ocular rosacea can exist with classic rosacea or it can exist without, but often they're the people who do have a tendency to flush, even if there's not dramatic changes that you can see on the skin. So they get pustules and conjunctival pustules. There's an increased incidence of styes in rosacea, and often people who get bad rosacea when they're older will describe having styes or quite a lot of problems with styes when they're young. So bacterial lipases and Demodex are being increasingly recognised as being part of that. But I think a lot of that's to do with inflammation and reaction against the things that live on the skin. My particular obsession is about Staph epidermidis, which is a commensal bacteria on the skin. And it used to be thought to be not very pathogenic, but certainly if Staph epidermidis gets out of the skin and into the body, it can involve heart valves, you can get kidney abscesses, brain abscesses, kidney disease. So there's lots of different things that Staph epidermidis will do, but it's actually under quite good control in the skin. It's extremely good at activating immune responses in the skin. So when we think about what's the cause of rosacea, so what are the different things that it could be? So we've got, is it inflammatory? There was a guy called Gallo who did a whole lot of work on things called cathelicidins. This is actually an old thing that I made when I was thinking about it sometime earlier. But all of these things have all kept going as being, these are the contributing factors for rosacea. So inflammatory, there's vascular, which is about the flushing in the autonomic nervous system and about why you flush in the central face. Neurologic, which is about the sympathetic nervous system as well. This is about the vessels and about heat. One of the interesting things that I think that patients often get told that they can't have tea and coffee, so they get given a whole lot of things that they can't have. And in fact, Dr. Wilkin gave some fabulous talks in his day about, he compared people, how much they flushed on their skin. He had temperature probes on their skin and found that hot water and hot coffee made people flush the same, and hot coffee and cold water made people flush differently. So it's actually the heat, not the caffeine, which is what makes people flush. Actinic is sun damage and the contribution to sun damage and telangiectasia. Infectious is about, there's always been a thought of maybe there's something going on in these pustules as to whether they're infectious. And this guy Marx spent a lifetime trying to find what is the infectious organism, and did an awful lot of work and couldn't find a organism, but he did find there was a lot of commensal staph on the skin. I actually contacted him when I was going through a particularly neurotic phase and wrote to him in England asking him if he could tell me what the things were that they found. He said they just found an awful lot of commensal staph as the bacteria in the skin. And Frank Powell was the first person who thought that Demodex may be a contributing role to rosacea. And there's been a lot of work being done since that time about the potential roles for Demodex. So is it infectious or not? That was Dr. Marx back in 1969. And Margaret Stewart, who was one of the old CEOs at the Skin and Cancer Foundation, I said to her, maybe, I was seeing it in my HIV, I said, maybe it's got something to do with infection. And she said, oh no, it couldn't possibly be, because this Dr. Marx, he did all this work and found out that there was no infectious organism. But he was actually looking for whether there's some discrete bacteria that's separate. But he did found Staph epidermidis in a lot of those. So, so we did, with a medical student, Nishmi Gunasingham, we decided that we were going to look at this thing. We didn't have much facility, so we decided we were going to look at what was in the pustules of rosacea and what was in the surrounding skin, because we didn't have much facility. So we did swabs of pustules and swabs of the surrounding skin. And so we just looked to see whether the same things were being found inside the pustules and in the skin around the outside. So it was a very, very primitive kind of research really, but it was kind of fun. So what we did, we compared the bacteria on the skin and we compared them with age and sex match controls. So what we looked to see was who had, so it was all in clinics. So these were all people with small pustules. And we found that of our rosacea patients, sorry, of these 15 patients, we had no people just when we compared them with their plain skin, we didn't find any difference between people with rosacea and people without rosacea. When we compared whether we grew a pure growth of bacteria, we found that in the eyelid margins, the number of pure growths that we got from the eyelid margins was 4 out of the 15 had eyelid margins that grew a pure growth of Staph epi, and none of the control subjects had that. So we kind of wondered whether that's what was going on. And then the same thing we did with the pustules, and we found that 11 of the 15 had a pure growth of Staph epi in the pustules, and where's my numbers? My pure growth of Staph, for this pure growth of Staph epi in the rosacea patients, 9 out of the 15 had a pure growth on the skin, on the pustules, and none of them found it had a pure growth on the surrounding skin. So it looked like there was something going on. Whether the Staph epi is just an organism that just beats everything up around like a hammer and just knocks it around, or whether Staph epi has a role in that, has just yet to be worked out. Nobody believed us though. So to me, it meant it made me start to think about staph epi for a long time about what it could do. And we found that it was much more likely to be found, staph epi was much more likely to be found in the pustules and in the surrounding skin, highly significant. So I think that one of the reasons of the pustules may be that the immune system in this inflammatory process is being triggered by some of the commensal organisms on the skin, which includes Demodex as well as staph epi. So what is Demodex? Demodex is this fabulous thing, and this is a recent paper looking at Demodex, and it was done by some eye ophthalmologists who had slit lamps, and they pulled out a couple of hairs and then looked at them under the microscope and looked to see what they saw, and those are little Demodex. So they're really kind of weird things. They've got a head, no anus, and they go head in and bum out into the hair follicles. And there's different types that go into eyelashes than the ones that go into the vellus hairs of the face, but they like sebaceous glands, and that's what they eat. And you can tell a big fat Demodex because it's this big round thing, and the little skinny Demodexes are the ones that haven't had their big feed yet. But these ones have had a big feed of somebody's sebaceous gland material. And they found that they studied 82 people, 82 individuals, 41 with rosacea, 41 without. And they found that there was a very highly significant difference in people who had a Demodex isolated from the hair that they pulled out. So, I mean, it was quite a simple sort of study of just looking at two random hairs on the lids, and that's what Demodex can look like there. So we just need to have a phenotypic approach to rosacea. So what are the things that we need to do? One of the major things that the patients complain about is the inflammation and the irritability of their skin. So they've got extremely irritable skin. Their skin barrier function is different. So the kinds of things that we need to do are think about what are the skin products that we should be advising them on. We've also got some medical oral therapy, topical therapies, oral therapies, light-based, blah, blah, blah. Got all different types of things we can do. However, we need to avoid the flushing triggers. So we need to avoid, for the people who get really terrible flushing, we need to be thinking about whether there's a cause for their severe flushing, if it's very severe, like carcinoid syndrome. So, but we need to be asking, are they on any medications that could be causing them to be flushing? So some of them are ones that are medical, like hydralazine, minoxidil causes people to flush a little. Hydroxyurea is an old drug that also makes people flush, but also some ordinary products, some of which are kind of good in many cases on the skin. One of which is a patient of mine came to see me who'd been given Viagra, daily Cialis, as a way of controlling something to do with his hypertension. And he came in, he had these nodules of rosacea, and I said, what's happened to you? I said, what's changed? And he said, I said, what new stuff? He said, I take Cialis every day. And Cialis is designed for erectile dysfunction. So it gives people erections, and at the same time, it makes their fascias flush. So that's a good one to ask. Probably daily Cialis in somebody who's a big flusher is an average thing to do. Turmeric as well can have a cause of inflammation, can cause vasodilation. Some of the antihypertensives, particularly minoxidil, hydralazine, and hydroxyurea, sorry, I said those already. So we reduce the irritability of the skin. So we need to be getting them to have simple things, simple sunscreen, simple cleansers, simple sunscreens, and moisturizers. I think these people, because of the poor barrier function, if products are kept relatively simple, then that's good. Some of the things that have been shown to be helpful in reducing inflammation and reducing irritability are things like micellar water. There's data on like nicotinamide. Tea tree oil is used for Demodex, I'm not going basically into those because I knew that there was going to be some presentations on those products later today. I'm happy to talk at morning tea about these ones. And Pierre Fabre and Propera have got a big range of things designed for for rosacea. When Propera's acne products came out, I realized that a lot of them had mild antibacterial, had all the things that I wanted, and I started using the acne ones on my rosacea patients and said, you need to do something for rosacea, whether or not that had any influence, but I realized that there was a number of similarities in the products. So we reduce inflammation. We use medical products to reduce inflammation. So what do we do? I'm just going to check my timing. Oh, where's my timer gone? Okay. So azelaic acid is an anti-inflammatory. It's same as Finacea and Asclear are the brands that you might know. Topical metronidazole gel, whether it's Metro Gel or Rosex, are the ones that we've used. Topical ivermectin is Solantra, and Solantra has got maybe 0.75% ivermectin in it. So it's very good. One of the things that oral ivermectin is actually not so good for trying to settle because these are commensals in people that are prone to develop, to have Demodex as a problem, they're the people that it's going to come back. So we don't find that a single dose of ivermectin is that great in rosacea, whereas it is in other disorders. I think because they are intrinsically there and it's not designed to wipe them out forever. Topical metronidazole foam, that's actually meant to be topical minomycin foam, which they use in the States, which is anti-inflammatory. The doxycycline and minocycline have two different actions. One is an antibiotic action and the other one is an anti-inflammatory action. Probably it'll end up being that the same there'll be some kind of sets of, proteins that get messed up by these drugs, and it messes them up in bacteria, and probably has some effect on the chemotaxis factor or something like that, which is related to inflammation. So that's one of the reasons why metronidazole works, and probably one of the reasons why minocycline and doxycycline are so efficient. And in the States, they use a topical benzoate as an anti-Demodex. But these ones, again, with crotomyton, which is also an anti-scab, also used for scabies as a way of killing the mites. Again, it's about just reducing stuff which is a normal thing that happens on the skin. So our oral therapies, we've got lots of different oral therapies. Doxycycline, minocycline, which have got antibiotic, but primarily anti-inflammatory. So this anti-inflammatory is really weird. So there are some blistering disorders that you may come across, like bullous pemphigoid. And in bullous pemphigoid, we use these same drugs, doxycycline and minocycline, not because they're antibiotics, but because they're anti-inflammatory and they interrupt the inflammation pathway. Beta blockers help to reduce the flushing, and alpha-2 agonists, so you get alpha receptors and beta receptors on these sympathetic nerves, and it depends on which type of nerve is in different places in the body, because there are different types of nerve endings which are more in the face and less in the chest, and same thing with the genital region, and hydroxychloroquine. So there is some data about hydroxychloroquine being an anti-inflammatory, that for some people, particularly those who've got a really strong autoimmune component, which a lot of people with rosacea do. So there's higher incidence of psoriasis, in particular in people with rosacea. So alpha-2 agonists are drugs like oxymetazoline, but I just took that, but my original things that we have in Australia is bromidine, which is otherwise known as Mevazo. And it's fantastic. It stops the blood vessels from dilating. So when they use the cream on their face, it means that for a day, for 12 hours, they won't be able to flush. It does mean it's a bit of a Cinderella kind of thing. And it worked when we started using it a lot. It was just fantastic. But we realized that probably these people get some kind of rebound from it. So I kind of use it as my special occasion thing. So for people, I get them to test it out and see whether it works. And so if they're going to be doing something like going to a wedding or, just doing something on the weekend and they want to use it, then it's actually really good for me as a sort of a special occasion, not an everyday thing, because they do rebound the next day. And their perception after they've been all, non-dilating for a day about what they looked like before is pretty difficult for them to kind of gauge. So that's bromidine. The photos in bromidine that you can get on YouTube of watching people's face go pale as a result of that topically applied to their skin once a day. It's pretty amazing. So light therapies. So when we think about that, so there's two things. One is the flushing and the bit, so it's like a menopausal flush. So some of the drugs that we use are the same that we use for menopausal flushing. There's one thing, and the other is the background for the IPL for getting rid of the redness. And so IPL, pulse dye, Botox, if you think Botox is blocking the sympathetic nervous system. So it can work. It's a little bit patchy. And so some people have a good effect, but it doesn't seem to last as long as it does in other sites for hyperhidrosis. So there's been, you know, I said there's some work that there's increased incidence of psoriasis. These people have got that inflammation gene. And so some things like there was definitely a whole lot of cases of secukinumab, which is Cosentyx, which is not approved for rosacea, but they had psoriasis and their rosacea all settled down. They'd have to have pretty terrible rosacea to do that, like a rosacea fulminans, which is just kind of like exploding rosacea. Topical anti-flushing agents, bromidine, oxymetazoline, that's the one that's in the States, and they're alpha-2 agonists. So pulse dye, this is a picture of what a pulse dye laser will do. Again, it's just targeting the background vessels and the light's being absorbed by those red vessels and damaging them so that the background redness gets best. So you have to kind of pick what's my problem with my rosacea. Is doxycycline going to help this? No, it's not working down that pathway. So, so this is another photograph from a recent article of somebody who had a fabulous result to an IPL. IPLs are a good way of doing some background redness and not very destructive. Timer, fabulous. All right, I'm nearly at the end. So ocular rosacea treatments, they simple washes. So if the eye hospital, if you can't find it, they've got you look up blepharitis and they've got inflammation. Blepharitis means inflamed eyelids. They've got a fabulous thing. If you look up Eye Hospital Sydney and blepharitis, and there's this really nice printout. And amazingly, they suggest you put 1 drop of Johnson's baby shampoo in a glass of water and use that as a bathe. It's probably that, and the soap makes us go, however, probably this tiny drop of soap is able to do something to do with the lipases that are they're involved in rosacea with the sebaceous glands of the eyelashes. Oral doxycycline and topical cyclosporin. Neurogenic rosacea is just catastrophic rosacea. It's kind of like rosacea on speed with multiple flushing. And it ends up being that their problem is pain. The flushing is so bad that they feel pain in their skin, not just discomfort. And we often have to use sort of pain analgesic kind of things like amitriptyline and pregabalin, which affect nerves but not specifically target general pain. And so that's my talk. So thank you. Now, because we're all running a bit late, I'm happy to say that I will be staying around at morning tea if there's any questions. So thank you. And
thank you, Margot. All questions, including from the virtual audience, will be addressed during our morning trade exhibition period. Now let's go on to our next speaker. Our next speaker is an Australian-trained specialist dermatologist and specialist in Mohs micrographic surgery, a member of the Royal College of Surgeons in Edinburgh, and an award-winning Harvard-trained PhD researcher. She specializes in Mohs surgery, skin cancer surgery, skin checks, surgical and non-surgical management of skin cancers and sun damage, risk reduction. Her unique skill set allows her to provide a bespoke, evidence-based, compassionate, and collaborative approach to your cancer care. Please welcome Dr. Nave O'Sullivan.
Hello, good morning. I hope everyone can hear me with the mic. Correct, good. Thank you very much to Vivian and also to Shell for the opportunity for all of ADNA to come and present to you today. I'm going to be talking to you about Mohs micrographic surgery. I can see some familiar faces in the audience, so hello. And for these, this is our old hat to some of the nurses I've worked with previously. Okay, so This is just a little bit about me. As you'll tell, I've got a funny accent, so I've lived all over the world. I trained in Wales, and my medical school was in Cardiff back in 2002. I did my research in America, and then I did some surgical training in Edinburgh, and then in London, and also back in Scotland. And I trained as a dermatologist in Perth, Western Australia, where I saw a lorry load of skin cancer and really fueled my passion for what I do now. I currently work at the Melanoma Institute Australia with Leslie, who's here today, also on Sydney Day Hospital on Macquarie Street, around the corner, Hunters Hill Private, and St. Luke's in Potts Point. So the overview of today is, what is Mohs micrographic surgery? Who does it? How does it differ from standard surgery, that when you go to the GP or to the general surgeon, to the plastic surgeon, to the dermatologist to have things cut out? How is this any different? What is the process? What should patients expect? And also, we'll just briefly cover some complications. So Mohs is a highly specialized technique at removing skin cancers. It's the most precise and detail-orientated way to do it, with the highest cure rates. Why is it called Mohs? A lot of the patients ask me this. It was named after the inventor, Dr. Frederick Mohs, and it's actually been invented back in the 30s whilst he was a medical student. It's been refined over the years and is now the gold standard, but still a lot of people haven't heard about it. Nearly 100% of the surgical margin is evaluated microscopically. So that means that we're looking at the entire undersurface of the cancer rather than just taking a couple of slices through it and hoping that they're representative. The surgeon is also the pathologist. So as part of my training, which I did at the world-renowned Skin Hospital, I was trained to look at the cancer under the microscope to decide whether or not there was any cancer left or if there are roots that we had to track. I'm also trained to do the reconstruction, and so that can be a simple side-to-side closure or can be complex flaps and grafts. So why do we need to do this? Well, a lot of types of skin cancer have extensions and they're like tentacles. And I explained to my patient, it's like an octopus. And it's not a kind of cartoon octopus. This is an octopus in motion, and it might be in the surf or swimming. We can't predict which direction the tentacles are going to go in. So if we're just taking a guess and taking out a circle or an ellipse in standard surgery, we might miss these tentacles. And that's demonstrated here. So the red little kind of columns or cylinders, that would be what one would take out if you were doing standard surgery. And as you can see, if you were just to take some slices through there, you could easily miss, especially looking at the one on the right, you could miss these tentacles that are all going out to one side. Each cancer is different, each patient is different, and scarring can really compromise this. So the tentacles need to be tracked, and that's my job as a Mohs surgeon, to track them down under the microscope on the day for the patient. So with standard surgical excision, we only actually look at 1% or less of the surgical margin. So only not assessing the whole undersurface. And I'll just play this video. Here we are, good. So this is what would usually be taken out. Some representative slices would be taken. And it may look as though it's all clear. The black would be the tumor, the white would be clear. And the bottom bit is what's left behind in the patient. And as you can see here, you can easily have a result that appears to be negative, but there's been tentacles left behind. This can make people think that they had a clear result and then it came back, but actually, in fact, it's possible that it was never actually completely removed because those tentacles just weren't captured. The next is a video, which I think is coming up. Again. Here we are. And this is from the American College of Mohs Surgery, who validates all of our training. And hopefully the sound's off. But essentially, a lot of my patients ask me, why have I got these skin cancers? Why have I got them and why have they come up? It's all sun damage. Unfortunately, in some cases, there are rare genetic syndromes, but the warmth of the sun feels good on our skin. But what it does is it causes DNA damage beneath the surface, which causes the cells to overgrow and to multiply rapidly. Another way of thinking about the octopus is an iceberg. And what we see on the surface may not represent what we see beneath. So something may look very small and may end up being very large. Over time, with life expectancy increasing, we're all living longer, we're getting more and more of these skin cancers, and they're popping up earlier because of sun exposure in our youth. Even a single burn or a single trip to the solarium is enough to increase our risk of getting one of these in our lifetime. And unfortunately, we don't just get one, they tend to come in more of a pattern like a chronic disease. And in these facial sites, they're the most commonly seen. So this is just the process. What we do, we bring the patient in. It's under local anesthetic. It's a day case. They can have their breakfast, which is fantastic. You can probably see on here, there's a little mark. We map out the smallest possible margin around what we can see. Local anesthetic is put in. And then the smallest, kind of most conservative margin is cut around the cancer, and that's taken out. We score the skin so that we can map it almost like a clock face, so that when we go back, we can know where to find the cancer. The dressing's put over the top, and the patient goes and relaxes. They can go and watch Netflix or read, do their knitting. It takes about an hour, and that tissue is made into slides by one of our Mohs technicians. Then it's my job to look underneath the microscope and check for the cancer. And as you can see up here, this is the normal structure of the skin, where at the bottom we've got the fat cells, and then here we've got the dermis, epidermis at the top, and this here is basal cell carcinoma. So that's one of the most common types of cancer that I treat. That was just present in one area. I was allowed to go right back into the area because we've mapped it like a clock. In we go, and it's all completely clear. So that's really excellent. The patient's now ready to go on and have a reconstruction. In certain areas, like for example, like little concavities like in beside the eye, and if the defect's small and only needs to be small, these things can heal by secondary intention, just healing naturally by themselves, either with Medihoney or simple wound care, Vaseline, for example. Sometimes it's a side-to-side closure, which is always much longer than the patient will anticipate. And it's very important that I tell them about that preoperatively, because in order to get a nice scar that hides in the smile lines, we need to make it longer. And that you just saw there is a bilobe flap, which is a very, very common standard flap that we do on the nose to reconstruct nasal defects. And it looks a little bit like a clover leaf. The idea is that you're bringing skin from an area where you've got extra down to cover the hole where the cancer was. I think we can just skip on now. Into the next slide. And back here. Not just for BCCs, but also for SCCs, when we compare it to standard surgery, and that's done by either dermatologists, GPs, plastic surgeons, general surgeons. There's so many of us that have to help with skin cancer in Australia. We can see here that the recurrence rates are so much better with Mohs versus standard excision. So this is wide local excision, and this is for squamous cell carcinoma. And this is where you take a safety margin that is essentially, it's an educated evidence-based guess around it. So the local recurrence rate with the standard surgery is 21%, versus with Mohs only 8% for these high-risk cancers. And similarly, the death rate, only 3% from using Mohs surgery versus 16% using standard surgery. And that's in anyone's hands. So that's very interesting and very compelling evidence. So who performs it? You have to have done a fellowship to do it. So it's only dermatologic surgeons in Australia who do it. There's not very many of us in the country. And we've received specialist training and done at least 500 cases, but it's usually closer to about 1,000 with all the extra hours. We're fellowship trained to remove the cancer, to check it under the microscope, to reassure the patient that it's all clear, and then also to do the reconstruction, be it simple or complex. Indications. So it's really good for any cancer on, especially the head and the neck, basal cell and squamous cell carcinoma. Your first shot at clearing a cancer is the best shot that you've got. So if you're going back for a redo and something's been left behind by somebody else, it makes it harder, it's more scarred, and the recurrence and the cure rate goes down from 99% to 94%. So it's a really good thing to use straight off the bat because it will give you the smallest scar and the highest cure rate. It's really good when things are very difficult to see, if there's a diffuse clinical border and they're not crisply defined. You really can't tell where it starts and finishes, either just using the naked eye or using a dermatoscope. It really helps because you can track it out. You just mark out the minimum that you can see, and then you let the microscope help you to follow those routes. It's also good for really aggressive subtypes. And although sometimes people say it's just a BCC, and in Australia, because we have such a high burden of skin cancer, unfortunately, that's become something that people think nothing's just a BCC. And often, even if something only appears on the surface on the biopsy, we found that the evidence shows that about 40 to 60% when we're going then and looking deeper and doing Mohs actually have multiple different types of BCCs within the tissue underneath the surface when I'm analyzing it. And it's not uncommon for me to find a second cancer living just beside that other cancer. And that can be discovered on the same day as well. And we talk about the H zone of the face, which isn't, as you can see, strictly an H, but in all of these areas marked out in the blue, of course, the goal is that we don't want to take as little tissue as possible. We can't take a football field around an area near the eye or the nose or the lip, because we're going to distort the anatomy and the scars are going to be very obvious. We want it to be as small as possible with the highest cure rate, and that's why these areas are so precious and to be treated with respect. Also genitals and hands and feet, so fingernails, toenails, and the lower leg is another area. And a lot of you in nursing will have had a lot of experience with leg ulcers, slow healing, and I know there's a wound care talk later on. It can be very, very challenging lower leg sites. If we're able to map out the cancer, take it out, get it out in one shot, and bring it together without the need for flaps and grafts and all the potential complications that can come with that, that's a real win for a patient and can get them back on their feet, back mobile and back to their life as soon as possible. We treat other cancers as well as the basal cells and the squamous cells. There's some really rare cancers that are quite nasty, like for example, dermatofibroma sarcoma protuberans, which is like a mouthful, and it's a very kind of rare tumor, but extends like much more widely than anyone could imagine. It can look like a penny piece on the body, but it can end up being many centimeters large. And if you're in the Mohs business and you see these, and some of our audience members will have experienced these in their career, it can be an all-day event. It can be a very big job, but it's also very satisfying because using Mohs, our recurrence rates are as low as 3%. Versus 39% with standard surgery. And we can usually just close them in a line scar, which is good because often, like there was a recent case, a young girl in her 20s, you want to be able to give somebody the smallest, most elegant scar that you can for a serious cancer, but know that you've got it all taken away. There are other things called MAC, microcystic adnexal carcinoma, which is another aggressive facial cancer, usually facial. There's sebaceous carcinoma, extramammary Paget's disease, so not the Paget's disease that we know of on the breast, but elsewhere, often around the genitals. It's very good for that too. And in America, it's gaining an awful lot of traction and is being used for melanoma in situ, which is very new, it's very exciting. And there are some Australian surgeons beginning to do it, and the cure rates are looking very high, but that's probably going to be in the future. Advantages, we've talked about tissue preservation, we've talked about the smallest scars possible and the highest cure rates. So here's a patient and they present, they've got a little scabbed area right beside the eye within the H zone that we talked about, that's an area of concern. If you look closely, you can see that there's some scars here from previous surgery, and there's also a little erosion here as well, probably one of Margot's pustules potentially beneath the eye. So moving on to the next slide, using the Mohs technique and having mapped this out, this was a huge defect. And as I said, the surgery is unpredictable. You tell the patients this is an all-day event, and in rare occasions, it might span over 2 days. So 9 hours, 5 stages, and 33 sections later, we were able to tell this gentleman that he was all clear and the cancer had gone. And then he was to move on to reconstruction. This is another lady, very subtle. The lesion of concern is on her nose. We like everything to be biopsied before obviously it comes to us, so we know what we're dealing with in the first instance or have an idea. It's this really subtle red area on the nose here, if you can see. And using the Mohs surgery, marking out just what we could see, this was the extent of her defect. And fortunately, this was able to be closed in a very simple way. And we didn't have to take a huge margin around the rest of it. And she was very happy with her scar, healing nicely there, as you can see on the right. It's very good for recurrent BCCs, and similar to the one that I showed you before, here we see this other like very, very large and an unpredictable shape. You'll notice that the edges are quite jagged, and that's because we're going back to that clock phase and we're just tracking those tentacles. And that accounts for the funny shape that maybe looks a little bit, I suppose, ragged almost to the eye, because the normal tissue is being left behind and only the cancerous tissue is being taken out. And that was closed really nicely with a line scar and settled really well with a bit of a cheek advancement. So moving the cheek out almost in a medial facelift style. We can see here in this patient, there's not much that you can see, but you can notice that the lower eyelid has been pulled down. and that's because of tightness here in the cheek. And this is called ectropion. And this is a primary microcystic adnexal carcinoma. And these are huge. So some of the American Mohs surgeons refer to them as the Big Mac. And again, it's another long day surgery. But these are very, they can be very aggressive tumors. They've got to be treated with the utmost respect. And of course, one could never have guessed that they would be this big. With regards to repairs, there are everything from multi-stage, so very complex repairs, to the simple side to side. And this is an example of a two-stage reconstruction where cheek has been borrowed, a finger of skin has been borrowed from the smile line here and lifted up to cover a defect on the nose. And this will then be divided. This little tissue bridge gets divided 3 weeks later and heals up really, really nicely with just 2 little scars there. That's something we quite commonly do and is at the more complex end of our reconstructions in the same bracket as the forehead flap, which was first described in 600 BC in the Indian Sushruta, first manual of plastic surgery, where the skin from the forehead is used to reconstruct the nose, which is pretty amazing because criminals used to have their noses sliced off as a punishment. And this was developed in 600 BC, very interestingly, as a nasal reconstructive strategy. Other repairs can be combinations, and this is a combination of a Mercedes-Benz tripolar advancement. So we've brought, the skin's been recruited and brought in towards the middle with a skin graft that you can see in the middle with those little fenestrations. And again here, skin has been rotated up round to this large upper lip defect and it's placed in with no distortion of the lip. So when we're looking near lips, we're looking near the nasal rim, we're looking near the eyelid. That's called the free margin. And we want to really respect that and make sure that we keep the anatomy in the right place. And there he is again from the front. He'll be a bit swollen with the local anesthetic. This is the one I described before, where we're borrowing skin from the forehead to reconstruct the nose. And again, this tissue bridge is divided, but usually about anywhere between 2 to 3 weeks, the forehead flap. And then the nursing girls here with experience in Mohs surgery will tell you these are the hardest work, I'm afraid. They're a wonderful result. They're beautiful cosmetic results, but they are hardest work. They tend to bleed a bit in the first 24 to 48 hours, but that's normal. And they do require lengthy dressing changes. So be warned and have your coffee. Make sure you have your morning tea before you see these patients for both on my side and on yours. Here's another larger reconstruction. And here's another very, very dramatic defect where, again, you know, looked very little on the surface, ended up being very large and ends up healing beautifully. This is a patient who came with a large fungating lesion to one of my colleagues on the upper eyelid, which was very, very aggressive cancer again, and obviously ended up being very extensive going down to the skull. But after reconstruction, heals really, really, really beautifully. But all of this is a journey, and it's not just a surgical journey, often with multiple stages. It's an emotional journey for the patients. There is a large psychological impact, and it's so critical that we give the patients, like both the doctors, the nurses, the whole team involved, a lot of support. And I get psychologists involved as well to help my patients with this, because it's a lot to go through. If we think about the distress when we have a pimple as a teenager, you know, when you've had half of your face changed around, you know, it changes your life, and you need a lot of support with that. But here she is, you know, looking fantastic down the line. Another lower eyelid where it's very important, and this is moving the skin from below the eyelid up to reconstruct the eyelid, so you can see there. And again, this and then that's the final picture. So that's upon healing. This gentleman's able to see, sights preserved. You know, nothing looks perfect. There's no such thing as invisible mending, and that's a very important thing to tell the patients. Sometimes they say, will there be a scar, doc? And I say, definitely. There are certainties in life, death, taxes, and scars after surgery. We cannot avoid them. I wish I had a magic wand. We don't have one yet. So what do I tell them? As I've said, I've covered some of this already. It's an all-day event. It may take, you know, hours, but mostly it's 2 or 3 stages, about 30% or less. It can be done in one, but the idea that of going back into theatre to keep taking the extra stages, that's very short surgery. That's only actually back in theatre for 5 to 10 minutes to take the little part of the clock face that still has the tentacle. And then the patient's relaxing between times and they can eat and drink throughout the day. And an important part from a nursing standpoint as well, as part of the same with the doctors, is we encourage the patients, because sometimes they say, oh no, I've got to go back in again, we're not clear. And we say, that's exactly why you're here. That's why we're here, we're tracking it down. So don't worry, this is why you signed up for this. This is why you're in the right place, because the alternative would be, it would be taken out, sewn up, and a week down the line, you get a phone call saying, actually, we've got to go back. So it's a better way. It's local anesthetic. We can give Valium, we can give alprazolam, we can give clonidine to some of our patients to help to relax them prior to the procedure. And if they have very extensive reconstructions, like the larger ones that you can see, they can be done on a separate day, and the patient can be, or later on in the same day, and the patient can have local sedation and be put to sleep, especially when working around the eye and the larger defects. Obviously, it's quite distressing for certain patients. Oh, they can't drive home, that goes without saying, and I like them to stay with somebody as well. What are the complications? Recurrence, contour abnormality, dyspigmentation, infection, bleeding, hematoma, and dehiscence. And we're just going to go through some of these. But an important thing is, I say to the patients, as I said before, there's no such thing as invisible mending. There's always a scar. Scars take 12 to 18 months to finally settle down. Everybody scars differently. Some people keloid, some people take longer to heal. Some people have got diabetes or immunosuppressed. So they're A, more likely to have skin cancer, and they're B, more likely to have unpredictable scarring. There are factors, surgical factors that impact upon that, and also there are patient factors. If someone goes back to F45 the day after their surgery, the scar's probably not going to be as good. They're probably more likely to bleed and have complications. And similarly, if people are picking and scratching at their wounds, infection rates and things go up. So here, I'm just showing you here, this is an example. This isn't Mohs surgery, this is just another example, but just to demonstrate, obviously signs of infection you'll all be really well aware of. Spreading redness, I tell the patients to watch out for spreading redness, increasing pain after the surgery, any pus, muck or yuck coming out of any wound that's opened up, or even if it's still sealed, it's important that that's swabbed. This is a little area here of dehiscence on a pre-tibial wound here on the lower leg. And again, you know, it's clean, there's a nice clean base, and you've got a wound care expert nurse talking to you later, so I won't do her job because I'm not as good. But this just shows a little bit of dehiscence. This can be opening up. And this is all just about really good wound care, saltwater bathing, reassurance with the patient as well, keeping it clean, making sure there's no infection there, and regular dressing care and reassurance. And that tends to heal up well. I can send all my patients for nerve damage. That can just be temporary, can be bruising, or can be permanent. And so things can take days, weeks, months, years to repair. But sometimes it never feels right. Even if you have something as simple as an arthroscopy for your knee, that little area where they went in with the camera, it may always feel numb and strange when you're shaving a leg. So I tell the patients, you know, don't be surprised if the area feels numb. If it feels strange, that's normal. So strange but not sore, and it probably will recover over time, and it's unpredictable. Sometimes those little nerves that are in the surface of the skin around the cancer, they're cut as part of taking away the cancer. So they're all kind of collateral damage. But if things change down the line, if wounds break down, if things suddenly start feeling strange, like ants crawling beneath the skin, or strange feelings are described, we worry about recurrence, and we talk to the patients about that. Here are just some other pictures. So these are just some pictures of facial palsies, which you can get as simply as just a bit of nerve bruising. Having injected the local anesthetic, the nerve goes to sleep, and it can look like someone's had a stroke and give you a fright, but actually it's really just a bit of a temporary effect of the local anesthetic. When you're operating in certain danger areas of the face, around where the facial nerve comes out of the parotid, you do tell patients that they may have a permanent facial droop, and that may be a consequence of an aggressive cancer that's been left behind. These are some pictures just showing a hematoma, so a blood clot beneath a skin graft, and also a failing skin graft on the right. And then here are some other pictures, just showing here's a Mohs defect on the left. And then in the middle picture, you can see that it's all come together. It's quite a complex repair with two defects, one below the other, and the skin moved up to fix it. There's some skin necrosis that you can see up at the top along the epidermal wound edge. And that's likely because there's a hematoma, and you can see that bulging just down at the bottom here. The cheek is very vascular. The face has 5 times the blood supply it actually needs to function, which is brilliant. It means we heal fast, but it means we bleed. So if people have, expanding like kind of lumps after surgery, usually early, it happened early, they may have overexerted themselves, they may have been straining, having had plenty of Panadeine fort. If they ring up and they say they've got a bulge or a swelling in their face and they're worried, we take it seriously and we bring them in, have a look. And that heals really nicely. And this is just examples of keloid and hypertrophic scarring. So here we've got a hypertrophic scar at the wrist from some wrist surgery. They just look a little bit raised, a little bit red. They tend to settle down nicely with massage, silicone dressings, etc. And all scars are important to sun protect. And up here we have keloids. So these scars here have overgrown the footprint of the original surgery. And sometimes these can either be from not from any surgery, but they may be from something as simple as a cut, a scratch, an acne scar in the past. And some people have a propensity for these. And if you do, intralesional steroids can be helpful. And there are a number of other ways to manage them. This lady here, I'll wrap up because I know we're running behind and we've got a morning tea on the way round. You must be hungry. But this is a lady here on the nose, and this lady's had a skin graft repair on the nose. And we can see, there is no such thing as invisible mending. She's got a pretty good result. It's early in the day, but there is a change in color and everyone's consented for that. The color's different and you can see there's a bit of a contour defect. So there's a little bit of a dip. They fill out gradually with time. We can use autologous fat, for example, or fillers, although they have to be topped up if required. And for color change, camouflage, makeup, anything from camouflage makeup up to laser resurfacing can really help with these. But in the early instance, prevention is the key. Getting the flap right in the first place or the graft right in the first place is really good. Really good aftercare is important. Meticulous sun protection and block with 50+. If this skin gets burnt, it's like newborn baby skin. It burns quicker and the color changes, and that's very difficult to deal with surgically. So take home points. Look, we're all different. Every nurse is different, every doctor's different, every patient's different, and every scar is different. But every scar takes 12 to 18 months to finally settle down. Patient support is something that is universally so important, and the psychological impact of having a facial operation cannot be underestimated. So it's just, I think kindness is one of the most important kind of virtues, and compassion, and being accessible. So being there when the patients are worried or concerned and giving them enough information so that they know this is normal, this is okay, you're going to pull through that. And that is it. Thank you very much for your attention. And I'm happy to answer any questions in the break with the morning tea.
Thank you, Dr. O'Sullivan. Our next speaker is none other than our own ADNA New South Wales representative, Shelley Enriquez. She's a dermatology nurse in Sydney, Australia. She has been an active member of ADNA since 2019. With over 10 years of experience as a clinician, Shelley has a combined cosmetic, dermatology, and peri-op nursing background. She has worked with different cosmetic doctors, dermatologists, and plastic surgeons in Sydney. She has also spent her time sharing her knowledge and skills as a clinical facilitator and lecturer to nursing students. Shelley has a special interest in overall skin health, including educating patients about the proper use of skincare to manage their dermatological conditions. She has been featured in the local aesthetic magazines. Shelley has also presented at local and international conferences, including the most recent International Congress of Dermatology in 2021. She has been one of the main organizers of New South Wales Education Days and national conferences of Australian Dermatology Nurses Associations. Please welcome Shelley.
Thank you, Andrew. So we're gonna have the science of skincare panel discussion. I've got a few chairs here, so I'm gonna call a little bit of a help here. Please welcome on stage Baz Hammer from Prepara, Tony from Pierre Fabre, Luigi from La Roche-Posay and CeraVe, Min from Ego Pharmaceuticals,
And Amy from Bioderma. Can we please have a few microphones as well, please? So thank you for joining us today. Can you please introduce yourselves? Just what's your role and
Okay. Hi, everyone. I'm Min. I'm from Ego Pharmaceuticals. I look after the South and ACT area. I've been with Ego for 21 years now. So the company is Australian made and owned, and it's a family business. Everything's done in Melbourne. It's nice to be here, and thank you very much.
thanks, Min. We're just missing Tony from Pierre Fabre. Are they outside? Probably. Could some Inga, do you mind asking Tony? I think he's outside at the trade table. Thank you. Amy?
Hi everyone. My name's is this on? Hi everyone. My name's Amy. I'm the medical manager for Australia and New Zealand for Bioderma. So I work for NAUS, and there are 3 brands within the NAUS portfolio, but Bioderma is the one that we have here in Australia. So I'm representing Bioderma today, and I'm very excited to be here, and I'd love to chat to you all. So if you have time, come and see us.
Thank you. Luigi?
Morning, everyone. My name is Luigi from La Roche-Posay and CeraVe. Good to see some familiar faces in the crowd today. And please don't forget to collect your gift bags later on today. And yeah, hopefully I can have a chat with you all today. Cheers.
And we have Tony from Pierre Fabre.
Hi everyone, my name is Tony. I'm from PFOB.
And Baz from
I am
Propera.
Baz from Propera. I started Propera in 2010, which is a range of skin care for dermatology and supplements and sunscreens.
Right. Thank you, everyone. Okay, so it's going to be a chill presentation today. We're just going to discuss a little bit about skincare. So I have a patient who came into me, and normally what I do is before I assess everything, I would like to take photos of my patients. So I do have the Observe, which is a diagnostic tool. So I took a photo. This is just the normal light. And let's help this patient, okay? So on your tables, you've got true and false paper in there. So we're just gonna ask a few questions about this patient. So with this photo, we can change the, there's a light settings on my machine, and we can highlight the redness of the skin. So whenever a patient comes to you and there's underlying redness, it can be either rosacea, psoriasis, or eczema. It all depends on the skin type. So let's answer a few questions. True or false? I have eczema. The only way to keep my face from drying out is to use thick creams. Okay, you've got your true or false on your tables. Can you please raise your answers? True or false? Come on, everyone. Okay. Majority of the answers are false. Okay. So the answer is false. Amy, can you please tell us why it is false?
Yeah, so a lot of patients that have eczema prefer emollients that have a thicker texture, but it's not necessary to have an emollient that has a thick texture, especially for some patients like children, for example, that have eczema. It can be really difficult for parents to apply a thick emollient twice daily to a toddler that's wriggling around or crying or, you know, not enjoying the situation. So what's more important than texture is ingredients. So what patients want to look for are products that have ceramides, 1, 3, and 6, ingredients like niacinamide. And then they also, if possible, want to look for products that have added ingredients like sucroesters, which prevent the proliferation of S. aureus, the bacteria on the skin. So helping to reduce that bacteria proliferation will also help to prevent flare-ups. And creams that have those ingredients often come in a range of different textures. So it's really about whatever will keep the patient more compliant to using the emollient.
Thank you, Amy. Now, I want to highlight the true texture of the skin. So as you can see on this photo, we can see the shine and some oiliness around the T-zone as well for these patients. Now, this patient would ask, true or false, moisturizers make our skin oilier. Now, what's the answer? True or false? Come on. True or false, moisturizers make our skin oilier? False. Okay, Min, can you please tell us why it is false?
I guess it's false because oversebaceous glands, active oversebaceous glands, actually produces the oil. So it's not necessarily your moisturizers that actually adds extra oils to your skin. Moisturizers that can be non-comedogenic and oil-free. So they're probably the better choices for oily skin. So it doesn't actually cause further production of oils in the skin. So it just depends on what moisturizer you're using and finding the right one to hydrate the skin by locking in skin's own moisture. Yep. Thank you.
Thank you. Now the next photo, we can see there is an underlying hyperpigmentation on the patient. Now let's talk about hyperpigmentation. True or false, freckles and sunspots can fade. What is your answer? True or false? Ooh. Are we hesitant to raise our answers? The answer is true. And why is that, Baz?
Hyperpigmentation is a complex skin condition. It can fade, but it's very hard and a very slow process. And most of the people fed up. That is part of the story. The gold standard treatment for like in dermatology is the hydroquinone, normally 4%. The dermatologists that's the level that they use normally. And at over the counter, they are in Australia up to 2%. It's considered a listed medicine, so it's not a prescription. Hydroquinone has issues with stability. So especially when you reach 4% is what dermatologists want. You need to compound it fresh. And within a month, significant part of it will oxidize and the product will become yellow look, which is a sign of oxidation. There is tendency to move on from hydroquinone if we can. I believe at skincare level, which also relevant to dermatology nurses, we need a combination of ingredients and we need to have a strategy. We need also to educate patients that this is a slow process that will take time. I think a retinoid is relevant, and we have in Australia retinol and retinaldehyde are very relevant. They are non-prescription compared to tretinoin and retinoic acid that's available to dermatologists. Retinaldehyde is 11 times faster than retinol. It's a retinoid, and it's precursor or direct precursor of retinoic acid. So it can be very relevant to give good results. Having said that, not on its own, I believe also having some lactic acid to exfoliate the skin so the skin can get better results from other actives. High percentage of vitamin C, particularly L-ascorbic acid, and anhydrous L-ascorbic acid, vitamin C, can be very relevant. Niacinamide, also relevant. Licorice root extracts are also very relevant, as well as strict sun protection. So this is the macro picture of the-
Yes, thank you, Baz. That's a good point. Sun protection, because prevention is always better than cure. Let's talk about sun protection. There are different SPF levels, and it's really important that we have an ARTG listed sunscreen. Tony, can you please elaborate on that?
So it's very important that you wear sunscreen on a daily basis. It should be the last step of your skincare routine. So in terms of SPF, the most common ones we see in Australia would be 30 and 50 or 50 plus. That's the highest you can find in Australia. Overseas in Singapore, or they've got SPF 100 or 80, but the highest in Australia is 50 plus. So the difference between 50 plus and 30 is actually quite, it sounds like there's 20, but it's actually quite subtle. So 30 is about 96.7% protection and 50 plus is about 98. So the SPF measures basically how well your skin is protected from getting, burned. And like I said, it's very important that you wear a sunscreen on a daily basis to get into this habit, regardless of if it's a cloudy day or if it's winter, and just touch up throughout the day, because we produce oil, we sweat, and the face mask we wear on a daily basis, this can all remove the SPF we put initially in the morning. And also it's very important to use physical protections as well, umbrella, clothing, sunglasses, if you can, but I know it's very hard. So yeah, and for TGA, actually for sunscreen in Australia, it's actually registered as a medicine. It's very important that TGA basically checks the safety and also quality.
Thank you, Tony. Now, this is the overall skin complexion of the patient. And then normally, like, the patients would use all your skin cares, all your ingredients from A, B, C's. And vitamin A, that's the number one thing that most consumers and patients would know. Now, true or false, retinol makes my face red. I should stop using it forever. True or false? I think we all agree it is false. Luigi, can you please tell us why?
Thanks, Shirley. This is, funnily enough, something I've been hearing a lot from a lot of my dermatologists and my pharmacists that I've been seeing, especially during the lockdown when everyone was doing like 7 or 10-step skincare routines. Now, it's important to remember that everyone's skin is different, and that if something works for one of your friends or one of your family members, it's not going to act the same way on your skin. Even throughout the year, as the seasons change, our skin changes as well. Now, it's important with active ingredients like retinol. If you are using it at a lower concentration and starting off every other day or even every third day, and again, just important to counsel your patients that nothing is going to work overnight. A lot of these patients, they are using a higher concentration because they think it's going to happen a lot quicker for them as well. So again, tell them to start slow at a lower concentration and gradually build up the tolerance to the ingredient itself. And as Tony was saying, use a sunscreen as well, very important, to help prevent any adverse events like erythema, redness, or irritation.
Thank you, Luigi. Now, I think the final question will be, is having a good skin routine really helpful? Yes, we all agree it is true. Okay, Tony, why is it helpful?
It's gonna help, and we want to make sure that our skin is well hydrated and is protected as well. Yeah. So it's very important that you get into a good habit. Otherwise, you probably have to pray to have good genes, but otherwise, you just have to, the most simple routine would be to wash your face properly, wear a moisturizer and sunscreen.
Thank you. Me?
It is very important, especially if you want to stay young and have nice plump skin. We can get dehydrated skin. Any type of skin can get dehydrated skin, particularly oily skin as well. So having good moisturizers, and not all moisturizers are the same. So choosing one that's right for you can be difficult. So you try as many as you can until you find the right one that you can actually be happy with and compliant with. And moisturizing, sun protection is always the first key. Cleansing is good as well. So again, we wear makeup, we have daily grime, pollution in the air, that sort of thing. So cleaning is also important, but moisturizing is probably my number one suggestion with a sunscreen as well.
Thank you. Amy?
Yeah, I'll just build on what's already been said and say that it's especially important for people that have skin conditions that they're trying to manage. And then also it's incredibly important to choose the right skin routine. So there's a difference between choosing the wrong cleanser and the wrong moisturizer and choosing the right one, and it's pretty big. So making informed decisions about what's right for your skin. So for example, if you've got sensitive skin, using something like a micellar water, that's going to get rid of the dirt and grime and all that kind of stuff without affecting the skin's microbiome or damaging the skin barrier. So yeah, just making an informed choice about what's right for your skin too.
Thank you. Luigi?
More of the same for me. Again, just appeal to the vanity. If you ask anyone, do you want to look old? Answer is always going to be no. And the best way to do that is just finding the right product for you and something that you're happy to use every day, especially a sunscreen, because that's the number one thing that you can do to help slow down the signs of aging on your face. And if you're happy to find one that, it's really lightweight and you're happy to use every day, that's the one you should go for.
Thank you, Baz.
Yeah, I can't agree more. I would like to add repairing the skin barrier every day is very important. Working also on the integrity of the microbiome, getting the balance right between good bacteria, bad bacteria, and the diversity of bacteria on the skin as well as in the gut, because the gut, the skin, the brain are connected. I would like to also to add the role of supplements, because they talked about the skin care part of it. I believe nicotinamide is relevant topically as well as orally. Zinc also is relevant topically and orally. Vitamin D is relevant also, as well as probiotics, prebiotics, postbiotics to look after the microbiome in the gut as well as the skin. So that is like also makes like an integrated solution for skin health. Thank you.
Thank you. Yeah, so I agree, like having a good skin routine is really, really helpful. As you are aware, there are a lot of brands out there and it's more of what works for your skin. And I want to show you a photo of my patient. That's it. Okay, so the first photo, which is on the left, that was the first photo that I showed you. And after 3 months of really good skin routine and skin treatments as well, you can see the improvements in her skin. And that's only like the natural daylight photo. There is nothing involved in the lighting in there. And underneath, of course, it's a slow progress, but it is still a progress. So thank you very much. Now we're going to go on for a break and enjoy the trade exhibition. You can speak to the reps if you have more questions about skincare and other stuff.
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
Check, check, check.
We are developing and identifying the drugs of the future.
I just want to let everyone know at the back of the attendees' ID cards, there is a QR code. So exhibitors can scan this one to get your profile. Yeah.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. The UCD transformed itself from a diversified conglomerate into a focused biopharmaceutical company.
Scientists with different backgrounds can really speak together the common language, and everybody contributing their expertise.
Listen to the patients to make sure that we understand what are their needs. You have to be able to make sure that we get that medicine to the right patients.
What we do here represents hope to patients.
People are our most important assets and play a key role in any successful future.
The world is changing because of the connectivities, because of the ability to network with academics, patients, physicians, providers, payers. It's really all integrating it together to provide the solution for the future.
海外の医療の先進国で実習をして
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
We are developing and identifying the drugs of the future.
BRAM
is actually a strategic industrialization and production site within UCB.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. The UCB transformed itself from a diversified conglomerate into a focused biopharmaceutical company.
Scientists with different backgrounds can really speak together the common language, and everybody contributing their expertise.
We listen to the patients to make sure that we understand what are their needs. You have to be able to make sure that we get that medicine to the right patients.
What we do here represents hope to patients.
People are our most important assets and play a key role in any successful future.
The world is changing because of the connectivities, because of the ability to network with academics, patients, physicians, providers, payers. It's really all integrating it together to provide the solution for the future.
海外の医療の先進国で実習をして抱いています。
Jeder kann sich selbst Herausforderungen und Ziele setzen, aber wenn man das dann tatsächlich schafft, was man sich vorgenommen hat, dann ist das mit Sicherheit eine gute Basis für ein Erfolgserlebnis, das einen dann wieder weiter einige Zeit lang tragen kann.
We are motivated every single day by patients, counting on us to make their lives easier and more comfortable.
No matter how difficult the times may be, I'm living proof that there's always going to be a chance to make it better.
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
We are developing and identifying the drugs of the future.
BRAM is actually a strategic industrialization and production site within UCB.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. The UCB transformed itself from a diversified conglomerate into a focused biopharmaceutical company.
Scientists with different backgrounds can really speak together the common language, and everybody contributing their expertise.
We listen to the patients to make sure that we understand what are their needs. You have to be able to make sure that we get that medicine to the right patients.
What we do here represents hope to patients.
People are our most important assets and play a key role in any successful future.
The world is changing because of the connectivities, because of the ability to network with academics, patients, physicians, providers, payers. It's really all integrating it together to provide the solution for the future.
海外の医療の先進国で実習をして抱いています。
Jeder kann sich selbst Herausforderungen und Ziele setzen, aber wenn man das dann tatsächlich schafft, was man sich vorgenommen hat, dann ist das mit Sicherheit eine gute Basis für ein Erfolgserlebnis, das einen dann wieder weiter einige Zeit lang tragen kann.
We are motivated every single day by patients, counting on us to make their lives easier and more comfortable.
No matter how difficult the times may be, I'm living proof that there's always going to be a chance to make it better.
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
We are developing and identifying the drugs of the future.
BRAN is actually a strategic industrialization and production site within UCB.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. The UCB transformed itself from a diversified conglomerate into a focused biopharmaceutical company.
Scientists with different backgrounds can really speak together the common language, and everybody contributing their expertise.
We listen to the patients to make sure that we understand what are their needs. You have to be able to make sure that we get that medicine to the right patients.
What we do here represents hope to patients.
People are our most important assets and play a key role in any successful future.
The world is changing because of the connectivities, because of the ability to network with academics, patients, physicians, providers, payers. It's really all integrating it together to provide the solution for the future.
海外の医療の先進国で実習をして抱いています。
Jeder kann sich selbst Herausforderungen und Ziele setzen, aber wenn man das dann tatsächlich schafft, was man sich vorgenommen hat, dann ist das mit Sicherheit eine gute Basis für ein Erfolgserlebnis, das einen dann wieder weiter einige Zeit lang tragen kann.
We are motivated every single day by patients, counting on us to make their lives easier and more comfortable.
No matter how difficult the times may be, I'm living proof that there's always going to be a chance to make it better.
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
We are developing and identifying the drugs of the future.
BRAN is actually a strategic industrialization and production site within UCB.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. The UCD transformed itself from a diversified conglomerate into a focused biopharmaceutical company.
Scientists with different backgrounds can really speak together the common language, and everybody contributing their expertise.
We listen to the patients to make sure that we understand what are their needs. You have to be able to make sure that we get that medicine to the right patients.
What we do here represents hope to patients.
People are our most important assets and play a key role in any successful future.
The world is changing because of the connectivities, because of the ability to network with academics, patients, physicians, providers, payers. It's really all integrating it together to provide the solution for the future.
海外の医療の先進国で実習をして抱いています。
Jeder kann sich selbst Herausforderungen und Ziele setzen, aber wenn man das dann tatsächlich schafft, was man sich vorgenommen hat, dann ist das mit Sicherheit eine gute Basis für ein Erfolgserlebnis, das einen dann wieder weiter einige Zeit lang tragen kann.
We are motivated every single day by patients, counting on us to make their lives easier and more comfortable.
No matter how difficult the times may be, I'm living proof that there's always going to be a chance to make it better.
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
We are developing and identifying the drugs of the future.
BRAN is actually a strategic industrialization and production site within UCB.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. The UCD transformed itself from a diversified conglomerate into a focused biopharmaceutical company.
Scientists with different backgrounds can really speak together the common language, and everybody contributing their expertise.
We listen to the patients to make sure that we understand what are their needs. You have to be able to make sure that we get that medicine to the right patients.
What we do here represents hope to patients.
People are our most important assets and play a key role in any successful future.
The world is changing because of the connectivities, because of the ability to network with academics, patients, physicians, providers, payers. It's really all integrating it together to provide the solution for the future.
海外の医療の先進国で実習をして抱いています。
Jeder kann sich selbst Herausforderungen und Ziele setzen, aber wenn man das dann tatsächlich schafft, was man sich vorgenommen hat, dann ist das mit Sicherheit eine gute Basis für ein Erfolgserlebnis, das einen dann wieder weiter einige Zeit lang tragen kann.
We are motivated every single day by patients, counting on us to make their lives easier and more comfortable.
No matter how difficult the times may be, I'm living proof that there's always going to be a chance to make it better.
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
We are developing and identifying the drugs of the future.
BRAM is actually a strategic industrialization and production site within UCB.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. The UCD transformed itself from a diversified conglomerate into a focused biopharmaceutical company.
Scientists with different backgrounds can really speak together the common language, and everybody contributing their expertise.
We listen to the patients to make sure that we understand what are their needs. You have to be able to make sure that we get that medicine to the right patients.
What we do here represents hope to patients.
People are our most important assets and play a key role in any successful future.
The world is changing because of the connectivities, because of the ability to network with academics, patients, physicians, providers, payers. It's really all integrating it together to provide the solution for the future.
海外の医療の先進国で実習をして抱いています。
Jeder kann sich selbst Herausforderungen und Ziele setzen, aber wenn man das dann tatsächlich schafft, was man sich vorgenommen hat, dann ist das mit Sicherheit eine gute Basis für ein Erfolgserlebnis, das einen dann wieder weiter einige Zeit lang tragen kann.
We are motivated every single day by patients, counting on us to make their lives easier and more comfortable.
No matter how difficult the times may be, I'm living proof that there's always going to be a chance to make it better.
Science is at the core of UCB.
UCB has always been a highly innovative scientific organization.
For me, innovation grows as part of being able to connect.
We are very open to talk with academics. We are very open to talk with other companies. And this is basically what gives new ideas, gives us access to technology that we need to drive our pipeline forward.
When you do science, it's really important to share your information with other groups, both internally and externally.
We are developing and identifying the drugs of the future.
BRAN is actually a strategic industrialization and production site within UCB.
We're coming from all over the world. We all have different backgrounds, different ideas. And coming together, we can talk and discuss about these ideas, and we're actually going to come out with a better solution.
Biotech was actually invented in the UK. That's what makes the UK such a fertile ground for really running research. You see.
Could we please start taking our seats so we can move on to our next presentation?
All right, we are going to go ahead with our next presentation. You. Could you please invite everyone to go back to their seats? We're gonna restart again. All right. Just letting everyone know, we are actually live. So this is a hybrid event. So we have face-to-face over here, and everyone is tuning in their home. So we have the Zoom link. So you can invite your friends who are unable to make it today as well. We also have our colleagues from Pacific Dermatology in Fiji who are actually watching us today as well. Speaking of Pacific Dermatology, our next presenter is the Dermatology Research Fellow at the Skin Hospital. She graduated with a Bachelor of Medicine and a Bachelor of Surgery, Bachelor of Sciences, and Master of International Public Health. She has contributed as a tutor and mentor at various universities across Australia. Her research interests include vulval dermatosis. Her special interests lie in the international public health and currently working with Pacific Dermatology, an Australian not-for-profit organization which support the education of skin specialist doctors in the Pacific Island. Please welcome Dr. Janice Young.
Oh, thanks, Shelley, for that lovely introduction, and thank you for having me here today. So I know it says dermatology a revolving specialty, and certainly dermatology is. And in particular, dermatology in the Pacific is an example to demonstrate this idea. And so today I'll be speaking about dermatology in the Pacific. So when we think about the Pacific, what comes to mind? And I think especially in this time when we've been in lockdown for so long, I think about crystal blue waters, sandy beaches, just under the sun with sunscreen, of course. So that's what I think about. But who exactly lives in the Pacific? And of course, we've got Australia here and New Zealand, and we're what we consider very well-developed countries. But here on the green, you've got Samoa, Solomon Islands, Kiribati, Tuvalu, as well as Vanuatu. And these are the countries that you consider what you call the least developed, and the remaining blue countries in blue are developing countries. So a country's economy is typically measured by what we call GDP, the gross domestic product. Now, many of the world's poorest today live in countries with very low economic growth. And so if you have a look at the list, if you go all the way down, Tuvalu, which is a country in the Pacific, is rated 150 out of 150. And understandably, these countries have many barriers, and that includes having a small population, remote locations, transportation costs, as well as poor infrastructure. And keep in mind, majority of the people who live in these countries are extremely young, so it's under 14 years of age. So why am I mentioning this? Well, poverty is a cause and a consequence of poor health. In a recent health status report in 2016, dermatology was ranked the 5th most common cause of morbidity in Fiji. And for this reason, it's a major public health problem. Dermatology remains a neglected health priority in both Fiji and the wider Pacific. So if you have a look, you have 550 specialists for the population of Australia, and they cover 25 million. If you have a look at Fiji, they have a population of just under 1 million, and at the time, they only had one specialist Fiji. So if you put it in ratio, it's kind of like saying for Australia, for the population of Australia, you only have access to 25 dermatologists. So if you put it in that perspective, they're definitely lacking the care and the access to specialist treatment. And if you think about it, even leprosy, which is mentioned in the biblical days, but which first presents as a skin condition, is still existing in some parts of the Pacific. Now, so why would Australian dermatologists and nurses help Fiji and the Pacific Islands? Because they can. You know, over the years, there's always been a strong partnership and cooperation between the Fijians as well as the Australians. And over 200,000 Australians claim Pacific Island ancestry. Not to mention the winning rugby league team have many of the Pacific Island descent people playing for them as well. So the main point is they're a part of our community. So something that I wanted to touch on briefly today is the partnership that exists between Fijians as well as Australians within dermatology. So not only is it important to know what our colleagues are doing, but what we're doing together. As I've mentioned, there's a paucity of dermatologists in the Pacific Islands. So what had happened in 2016, spearheaded by Associate Professor Margot Whitfield, who you saw today, a feasibility and needs study was developed for a training program in the field of dermatology. And by 2018, they developed what you call the Pacific Dermatology Training Centre. And that was established in the National Skin Clinic in Tamavui Tumi Hospital in Fiji, Suva. So basically a postgraduate diploma training program of dermatology was created. And this was under the Fijian National University banner in conjunction with the Ministry of Health and in partnership with Pacific Dermatology. So here we have the 4 successful graduates of 2019. So we have Dr. Helena, who was from Samoa, Dr. Tamea, who was from Kiribati, and 2 doctors from Fiji who successfully graduated and in the field of dermatology. Also through this partnership, something that was a big, important step forward was that 3 nurses, so we have Camille here, Krishnil and Vasita, as well as a pharmacist was then trained to be the first specialist to be able to use specialized equipment. And in this case, I don't know if many of you know, but a UV phototherapy equipment was donated by Rob Paver and it was delivered to Fiji. So in addition to this, one of the nurses from the skin hospital, Glenda Newman, was able to then train and be able to certify these nurses to use the phototherapy machine. And here on the corner, we've got a pharmacist who basically learned how to compound special medication as well. This leads me to the next part of what I wanted to discuss with you today. So some of the common and not so common yet interesting and important skin conditions that do present in Fiji. But first of all, how do we know that these skin conditions exist in Fiji? Well, we conducted a retrospective observational audit of the patients who attended a walk-in outpatient skin clinic in Tamavui Tumi Hospital. Now, keep in mind, this is the only referral centre for dermatology for whole of Fiji. And if you have a look at the image here, Fiji is scattered, multiple islands. You've got a major area, the central and the western region, but then also you've got the northern region too and the eastern region. So these people are traveling far and far away to come to this one national skin clinic, and they don't need a referral, it's a walk-in skin clinic. So basically we're collecting this data to see, okay, so who are these people who need dermatological treatment? How old are they? Where are they coming from? What ethnicity are they? What sex are they? And what are they presenting with as well? And this data was collected for basically to provide the Ministry of Health of Fiji to facilitate their resource allocation. So something I just wanted to briefly mention here is that obviously the results are tabulated and you don't need to look at that, it's very small. I don't know if you can see it. But what I found really interesting is that if you look at the majority of presentations, majority of the people who presented were under 10 years of age and between 20 to 29. So if you look at it, they're all quite very young. If you think from your clinical experience as a nurse, people who come into clinic generally here in Australia, they're more the older generation presenting with skin cancers, requiring a biopsy or skin cancer. Here, it's very different. They're quite young. And if you look at the most common presentations representing up to 49%, they're coming with superficial fungal infections. So I thought I'd start the countdown by starting with an image. I don't know if you can appreciate the details in this image with the screen. Any features that you notice that strike anything to you at all? No? Yeah, exactly. So Annette mentioned loss of eyebrows, thickening of the skin. I don't know if you can see, but his nose bridge has collapsed as well. And his ears in this image, you may not be able to see, but his ears, skin has quite thickened as well. So leprosy, which is rarely seen in Australia, still exists in the Pacific. And this is an important skin condition. It's also known as Hansen's disease, and it's a chronic bacterial infection caused by Mycobacterium leprae. It mainly affects the skin as well as the peripheral nerves. So generally, patients come in with initially like hypopigmented patches or red or copper-like plaques that's quite infiltrative. And as you can see, a classic clinical feature is what we call the Leone facies. Now, it's believed to be transmitted via droplets, respiratory droplets from the nose and the mouth during frequent and long contact. And as I've mentioned, it still exists in the Pacific, despite it being eliminated as a public health problem. Now, it's quite rare in Australia, and it does exist in the Indigenous population and migrants from endemic areas as well. Other than skin presentations, they do present with sometimes in the developed stages thickened and painful nerves as well. And it also affects their motor function as well. So when they do present, they can present with what you call foot drop or wrist drop, and even clawing of the hand as well. So just a little trivia for you. So I mentioned Tamavui Tumi Hospital. Well, that Tamavui Tumi Hospital was actually in an island. That's how it first started. And it was actually a leprosarium, and it was managed by the Missionary Sisters of the Society of Mary, which was a nursing missionary. And so for leprosy that exists in the Pacific Islands, early detection is extremely important, and treatment of all cases as well as contacts. And with the introduction of multi-drug therapy in the 1980s, we now have a cure for it as well. Okay, so that's way down on the list. These aren't new presentations. They may have been presentations who existed and came in for a review, but this clinic was generally a walk-in skin clinic who were presenting for the first time. Next. Now, number 5 on the countdown list, Michael Jackson and Winnie Harlow, who's a model. Do you know what they have in common? And I know it's pretty obvious. Exactly, vitiligo. So this is something I wanted to discuss with you today as well. So this is commonly seen in Fiji, as you see it in here in Australia as well. So it's a depigmenting disorder of the skin in which pigment cells, melanocytes, are either lost or destroyed. Now it presents with well-defined patches of white skin, and it's believed to be autoimmune. And associated with this is other autoimmune diseases such as thyroid disease, diabetes, as well as vitamin B12 deficiency known as pernicious anemia. Now, as you can imagine, vitiligo is extremely cosmetically debilitating, and in particular for people with skin of color. Now, recent research basically suggested that people who are younger patients with vitiligo show a high impact on the quality of life, as well as higher levels of depression. Now, it's also important to mention that in 20%, other family members are also may have vitiligo, and it doesn't discriminate between males and females. So I don't know if you recognize the person on the far right, but that is actually in fact Michael Jackson's son, known as Prince, and he's got that depigmented patch in the axillary region as well. Okay. So, you know, it can affect just one patch, and it can affect multiple areas of the skin as well, but they commonly affect commonly exposed sites, whether it be the face, the neck, as well as body folds as well. So as you can see in the first picture to your left, you can appreciate that it's affecting the fold area in the axillary region. And not only do you have the depigmentation of the skin, but you have also white hair as well. So you can lose pigment in your hair as well, and that's known as leukotrichia. Sometimes what you can also have is what you call trichome vitiligo, and that's that's what you use to describe 3 shades of color in vitiligo as well. Now, one of the other things is vitiligo also tends to favor sites that have been injured And in this particular case, this patient has had a surgery in the past. So whether it's surgery or cuts or sunburn, that is what we call the Koebner phenomenon as well. Now, it's usually a clinical diagnosis, and there's no test necessary really to confirm this, but you can use what we call a Wood's light to further accentuate the depigmentation that you can see with vitiligo. So we're moving up in our list here, and as you can see, you've got pigmentary disorders, and they represent 2.2% of the presentations in the skin clinic. One thing I probably should have mentioned is that the data that we collected was from January to July 2019. And during that 6 months, this is a walk-in skin clinic, we saw, well, the doctors saw over 7,000 patients. Now that's enormous. They only had a few registrars, so 3 registrars and 1 specialist dermatologist. So if you think about the number of people that they're reviewing with dermatological conditions, it's extraordinary. Okay, next. Now, this is a condition that many of you may have seen. Any thoughts on this? I might give you a little scenario. So you've got a 4-year-old boy that presents with an itchy rash, and he's had these symptoms about 1 month ago, and it started on his hands, and now it's spreading to the other parts of his body. He's been scratching and really irritable, in particular at nighttime, and crying throughout the day. He's not getting enough sleep. It just so happens that his mother has similar symptoms. Yeah, beautiful, on it. Exactly. So scabies is caused by the mite Sarcoptes scabiei var hominis, and it's a human parasite, so it requires the human to survive. And it burrows into the skin up to the stratum granulosum, and that's where it basically deposits, as gross as it sounds, its feces and lays its eggs. And it looks kind of cute, but geez, it can do some damage, can't it? So it's actually the allergic reaction of the scabies mites and feces that causes you to have that itchy rash. And as you can appreciate in the photo in the bottom corner is that if you look closely, especially under a dermoscopy, you can actually see the burrow in which they've dug under the skin. People generally present quite itchy, and in particular nocturnal itch. And they also may have a positive family history. So as I've mentioned, in this particular case, the mum was also itchy as well. Now it's transmitted via direct contact, although clothing and bedding, contact via clothing and bedding is also possible as well. But in countries like Fiji, scabies is actually endemic. So it's not just about treating the patient and their family close contacts, but they've incorporated what we call mass drug administration, which I'll go into soon. One of the things I want to mention is that the factors that lead to its spread is extremely important because scabies is a neglected tropical disease. It's found in relation to, it's associated with poverty. And not only that, but overcrowding as well. And it's found in hospitals as well as prisons. And that's where it's found here in Australia more commonly. So I thought I'd take a time to mention what we've got here. This is scabies, but it's what we call crusted scabies, also known as Norwegian scabies. And so basically what happens is that this individual has thick crusts of skin infested by thousands of mites living under the surface of the skin. And it's extremely contagious. Sometimes with scabies, what can happen is, the itch basically allows the introduction of bacteria, and so you get an infection. And so people can, in particular, those that are highly at risk are the elderly as well as the children and the immunosuppressed as well. And so they can present secondary complications like cellulitis, impetigo, and on a more serious scale, septicemia and renal failure, and also rheumatic heart disease. So as I don't know if I mentioned this, but management does involve identification as well as treatment of individual patients, but also household contacts as well. Now in Fiji, and this is something that I was hoping that you'd be able to appreciate through some of my slides that I go through, is that what is available here in Australia is very different to what is available in Fiji. And keep in mind that it's a developing country. So in the essentials medicine list, we've got 2 topical creams for the treatment of scabies. So we've got permethrin, which 2 applications, 1 week apart. And then you've got also benzyl benzoate as well. Now, oral ivermectin, which is what you require for treating, for example, Norwegian scabies, is not officially available in Fiji. And the only way that they can actually access this medication is sometimes they pinch it from research studies, and that's the way it's available. Otherwise, it's not on the medicine list. So one of the things I wanted to mention about scabies, and I've mentioned it before, it's called mass drug administration, and it's basically, it's being administered worldwide. But what it is, it's basically distributing medicines to the entire population in a given setting. For example, a village or a district, irrespective of whether they're symptomatic with scabies, for example. So as I've mentioned, scabies in countries like Fiji is actually endemic. So treating one person and their household contact alone isn't enough. And what a landmark research by Romani et al. In the New England Journal of Medicine showed that basically MDA using ivermectin is successful at actually reducing community prevalence of scabies. Now, going on from that, what usually happens with scabies is that ivermectin, it doesn't have any oversight or activity. And what I mean by that is generally they say, okay, take the tablet, repeat it after 7 to 14 days, because then you can actually kill the mites that have now grown. And so what usually happens even in mass drug administration is that not only do they give it once, but they kind of have to give it twice. And when you think about it in the overall scheme of things, when you're delivering it to a really big district or a village, it's extremely hard to administer. So a recent article in the PLOS Medicine by Hardy et al. In 2021 basically showed that one dose of ivermectin-based MDA is non-inferior to 2 doses for reducing scabies prevalence at 12 months. And that's significant because when you want to deliver MDA, ivermectin MDA for scabies, for example, being able to deliver 1 dose as opposed to 2 for a whole community has significant impact. So that was another landmark paper that came out recently. So I wanted to share with you what our neighboring countries are doing and what they're showing basically. So we're moving up into the list, and scabies basically represented 8.8% of presentations to this dermatological condition. Now, my next condition, I'm not sure if you can appreciate this. The reason why I wanted to talk about this in particular was because people with skin of color present lesions a little bit different to, for example, a Caucasian. Now here we've got what you call, 28-year-old presenting to the clinic with a history of skin lesion on her trunk, on her back, occasionally itchy, and it's quite big. It's quite dark, purpley in color, and it's keratotic, well-defined. Any thoughts, anyone? Oh, geez, okay, all right. So that's right. So I put these 2 images together so you can really appreciate the difference in the clinical appearance between a person of skin of color and a Caucasian person. So obviously psoriasis is a chronic inflammatory skin condition characterized by symmetrical, well-defined scaly plaques. And about 1/3 of patients with psoriasis have family members with psoriasis also. Now, there's definitely different various clinical features of psoriasis, but the most common one is chronic plaque psoriasis, and that contributes to 80 to 90% of presentations. Now, as you may know, it's commonly referred to as a pink salmon plaque. But as you can see, there is no salmon colored in this picture to the right at all. So that's why I just wanted to bring that up with you today. So you can just basically appreciate the different types of clinical presentations for the same condition. Here, I've just got 2 photos again, side to side. So we've got guttate psoriasis, which is different type. It's another clinical variant of psoriasis. And here you've got a darker skin. So it's really difficult to appreciate the small red scaly plaques that you see. And on the bottom right-hand corner, you can really see that it's quite symmetrical in presentation as well. And the little corner on the left, I just put in there because you can also get flexural psoriasis as well. So yeah, so various clinical manifestations for the same skin condition. Okay, so the next image again is, I'm not going to go through the management for psoriasis. What I wanted all of us to appreciate in this particular case is you've got a step-ladder approach. Initially, you've got corticosteroids or N-Stilla foam, for example, and then you can work your way up to phototherapy, and then you've got immunosuppressants, and then you've got what amazingly we have access to is biologics. Now, in Fiji, they do have access to certain things, and in particular, I don't know if you can see on the bottom left-hand corner, but they do have access to topical creams as well. But what they don't have is biologics, and we know that biologics is pretty much the golden standard of what you can give for psoriasis. what I wanted to appreciate here is, I've mentioned this photo before, is that we've got the phototherapy machine. Now, if I think about this, there is only one phototherapy machine for the whole of Fiji. And you've seen how scattered Fiji is as well. And as you may know, for phototherapy for psoriasis or whether it's vitiligo, you do need to come in quite frequently, up to 3 times a week. So, and this is the only machine that we've got there. So it's pretty amazing. So yeah, just moving up into the list, we've got psoriasis, hidradenitis suppurativa, and acne representing 5.8% of the presentations there as well. And that's also followed by dermatitis at the top as well. Okay, so counting down, number 2 in the list. Any thoughts on what this might be at all? So we've got scaly edges, slightly annular looking, hyperpigmented in the center. Take a guess, anyone? Sorry, what was that? Someone say tinea? Yeah, exactly. So in this particular situation, that you say that this was a 30-year-old male that presented with itchy skin for the past 2 years, and his GP basically has given him corticosteroid cream without much resolution, and the lesions are still persistent. So superficial fungal infections do present majority of the presentations, and I don't know if you can see it here, but they represent 49.7% of the presentations in Fiji. And this is also including deep fungal infections as well, which I'll tap into briefly as well. So depending on which part of the body is affected, it's given a specific name. And in this particular case, we've got tinea incognita, and that refers to tinea infection, which the clinical appearance has slightly changed because of inappropriate treatment. In this case, you don't normally treat it with corticosteroid cream. One thing I did want to mention is when we're looking at the data, although they represented 49% of the presentations, we didn't do an exact breakdown. But what we noticed was that tinea pedis actually only represented less than about 60% of presentations. And do you have any thoughts on why that might be at all? Some say shoes. Yeah. Oh, beautiful. Exactly. They don't wear shoes. So there you go. Isn't that interesting? Even though tinea represents the majority of the presentations. All righty. Oh, let me go back. Okay, so this is something that's interesting, and I'm not sure if many of you have seen this at all. So I'll give you a little scenario here. We've got a 30-year-old farmer who presents with a 6-year history of skin lesion, and it's on his left wrist. Now he's applied traditional medicine and he's seen a few doctors, and it just hasn't resolved, and it keeps getting bigger. Any thoughts at all? Sorry? Fungal infection? Someone say that? I don't know. Okay, I'll continue. So we have what you call chromomycosis or chromoblastomycosis. And again, this is rarely seen at all in general. So this is actually a chronic deep fungal infection that affects the skin as well as subcutaneous tissue. And it occurs in tropical and subtropical regions. So in this particular case, we had 17 cases that was actually reported as chromoblastomycosis, but generally you do need a formal diagnosis, whether it's through a biopsy or culture. And the reason why I mentioned this is that, prior to this, it wasn't ever mentioned that this existed in Fiji, although Fijians do know that this exists. The clinical appearance, as you can see here, it's like crusted lesions affecting the limbs. But early in the disease, it can start off as a red papule. It's very slow growing, and it turns into this like almost warty hyperkeratotic nodule / plaque. What's important is that this can actually develop into cell carcinoma. So this is something significant and worth mentioning as well. Yeah. So I won't go into the management given the interest of time, but this is something that is seen and has been reported in Fiji, and it's definitely worth mentioning. And the reason why I mention this is because at the moment there's like a hot topic, I consider this a hot topic, but basically in 2016, the World Health Organization Department of Control and Neglected Tropical Diseases wanted to promote a new integrated approach that focuses on diseases that initially manifest through the skin. And in particular, when you think about the Western Pacific region, some of the skin conditions they're going to focus on is the ones that I've mentioned today and the ones that have been reported in VG, and that includes leprosy, scabies, deep fungal infections, as I've mentioned, chromoblastomycosis, although formal diagnosis hasn't been done, as well as filariasis. And what they're doing at the moment, what they're trying to implement is actually a training booklet for healthcare frontline healthcare workers, which majority are nurses as well. And they want to be able to help them detect the signs and symptoms of these skin diseases and start the early management of these skin diseases as well. So I'd just like to take this time to thank a few people, and in particular, Associate Professor Margot Whitfeld, who's played a significant role in this, as well as Dr. Tuitha Cow. So thank you.
Thanks, Janice. Our next speaker is a registered nurse with experience in aged care, immunization, and has been working in dermatology for 7.5 years. For the last 3 years, she has had roles on the committee as secretary, public officer, and education liaison officer. She's recently completed the new graduate certificate in dermatology nursing, the first step in specializing in this profession. Education for nurses in dermatology, so it may become a professional specialty, is her passion. Please welcome Vivian Spears.
Hello, everybody. My name is Vivian Spears.
So I'll just help Vivian.
Yes, please.
Present our panel for today. So we've got Libby from Galderma.
Oh, I can see the names now. Yeah, I can see the names now. Sorry, I didn't know who was coming up. Also, Matthew Munro from Lilly, Tracy Edwards from UCB. Oh, okay. Tim O'Connor from Elliptal, and Kevin Scrimshaw, I think it says. Sorry, Scrimshaw from Dermasensor. Please come on up. Hello. Sitting all nice and close to each other. Hello. Alrighty. Oh, you have to take them off, I think, so that they can lip read. Come on up. I won't bite. You can sit here if you want. Alrighty. All right. Hello, everybody. So I've written a couple of questions for these different people from the different pharma companies. Missing Lily. We are. Is Matthew Munro here? We'll wait for Matthew, I think. Now, is it that button? Big arrow, thank you. All right. Okay, so I'll ask different people different questions, I think, otherwise we'll run out of time. So, Libby, hello.
Hello.
Would you please tell us, what does your role entail?
Yes, so I'm Libby Driffel from Galderma's prescription division. It's lovely to see some familiar faces today. I think I've probably met most of you covering the whole of New South Wales up until most recently. My role involves primarily speaking to dermatologists and dermatology nurses, as well as skin-focused GPs, about the merits of Galderma's vast portfolio, particularly with acne, rosacea and non-melanoma skin cancer. I also help and support clinics with regard to our in-clinic treatment for non-melanoma skin cancer, which is sold directly into clinics. So I help with order placement, as well as providing training and support to clinics on the protocols and replenishing consumables and things like that.
Thank you. So, all right, I'll ask, I can't remember your name, from Dermasensor. Kevin, I haven't actually met you face to face before, so hello.
Nice to meet you.
What are you focused on in ensuring nurses understand your product?
Sure. So Dermasensor is a point-and-click skin cancer detection tool. Sorry. But it's important to understand it's not a diagnostic tool. It is an adjunctive decision-making tool which gives another piece of information to help nurses and doctors to determine whether or not a lesion is likely to be cancerous or not. So part of the role in communicating what our device does to nurses is to really understand what the output of the device means. It has an output of either monitor or further investigate, and if the device gives a further investigate result, it also provides a 1 to 9 spectral match score, which is like a confidence interval, if you like, to determine whether or not a lesion is likely to be cancerous. So yeah, it's important for us to communicate with nurses that it's not a diagnostic tool, it's an adjunctive decision-making tool.
Okay, thank you. Tracy, I'll also ask you that. Why are you focused on ensuring nurses understand your product?
Hi everyone. So I work with UCB Australia, and we have a strong heritage in the rheumatology space, but we're new to dermatology, and so I suppose for us it's a two-way street. We are wanting to meet you to really understand what you'd like from us. So in the rheumatology area, we've worked very closely with the rheumatology nurses to understand patient needs, and we've developed a lot of patient resources, patient support programs based on the feedback that we've received from rheumatology nurses. And UCB have also been very focused on medical education. So I work in the medical affairs department. So medical education specifically designed for rheumatology nurses, which can be different to the medical education for rheumatologists. And so we're new to dermatology, so really wanting to, I guess, come over and meet us at the stand, and we'd like to understand a little bit more about your role and how we can work together as we move into dermatology.
So the question is,
Same question?
different question. Sorry. Does it really matter whether nurses are informed?
Absolutely.
In what way?
I don't know if this is working. Is that working? Yes, it is. How can I answer that? Look, let me give you a little bit of background, if that's okay, of how we started this company. I'm the CEO, Tim O'Connor, the CEO of Ellipdol. We actually started this company because of my daughter. We went to hospital late in life. I had a child, went to hospital, and I thought that anything in the hospital was the best. So I bought bucket loads of this sanitizer, a very well-known brand. And my wife's a journalist, and after about 2 weeks, she was suffering redness, skin problems, and that led to dermatitis. So fast forward a couple of years, I made it a mission to develop something for you guys. I'm not as intelligent or as experienced or qualified as you, but I have tried to develop a product that's best in breed in hand sanitizers. We have the highest efficacy rating globally. We have the safest product on the market, and we have the product that doesn't cause redness or contact dermatitis. So my mission is to try and inform all those nurses and doctors and procurement officers out there that there are other products other than what your procurement officer is telling you to purchase to protect yourself, because if you don't, you know the result, you'll get sick, cause hospital-associated infections to on the increase, and cause patients to also get sick. So yes, it does matter that you're informed. How we get that message to nurses directly from a small company like us is a challenge for us because you have the procurement officer in charge, but it's conferences like these, I believe, will help us get direct contact to all of you to help you do your job and stay in your job on a daily basis. I hope that answered the question.
Thank you. So I'll ask Libby again, what difference can nurses make in patient care? I'll just click it there.
Huge differences. You know, we find it, again, so important that we make sure that nurses have all the information required across our portfolio to really support patients with compliance or maybe performing the protocol itself with regard to the METFIX protocol. So you guys can make such a big difference with supporting the patients, informing them and ensuring that they're compliant with their treatment regimen as well. So, you know, we really highly regard you all, and we love to work with you. And yes, I think that you can make huge differences across, you know, dermatology, and you really are the backbone of most of the clinics.
Okay, thank you very much. And lastly, I will ask Tracy another question. Where do you see nursing changing in the future? It's a loaded question.
Oh, I know.
I did send these out early though, so people could think of something.
Obviously didn't prepare for that one. And I don't have a nursing background. I do have a science background. Where do I see nursing changing in the future? I think
pass if it's too hard, that's okay.
well, I see that you're more recognised as a partner in definitely a partner in patient care. You know, you might be surprised to know that I'm an older person, and so I remember days where you know, there was a matron and the nurses were, you know, doctors were, you know, the key go-to person in terms of patient care, and I think that model has really changed. And you know, that's why we as a company work with, you know, work in partnership with nurses as well as their treating physician, because you're all involved in you know, the best outcomes for patients. I don't know if that's answered the question well. I hope I haven't offended anybody when you.
That's good, thank you. So the reason why I asked these questions was because over the years, sponsors, different reps have come and visited at different clinics, and I think there's been a misunderstanding as to the value of having them come in, and the different education programs that have been offered have sometimes been missed. I think people haven't realised that they were going to learn more about skin diseases and more about different treatments that the doctors are offering, but the nursing side of that. And so I think it's important just to know that you can ask your questions of the different reps, because they have little insights into things, and also they're quite helpful. So I thought that's why I'd ask these questions of the different sponsors today. Okay, thanks.
Thanks, Vivian. Thank you.
Test. Yeah, thank you very much. So our morning tea earlier was sponsored by Sun Pharma, and now we're gonna have our Christmas buffet lunch outside at the Amber Restaurant, sponsored by Prepara. So enjoy. treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatments, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance. You have the warnings on protection, and you have to supplement them inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
You're targeting everything from treatment, and then you have the maintenance, you have the warning, sun protection, and you have to supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the warning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out as well.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
So you're targeting everything from treatment, and then you have the maintenance, you have the morning sun protection, and you have the supplement from inside out.
Yes, sun protection is very important. Looking after the skin barrier every day and helping the body from the inside out by nicotinamide and zinc. That can be a great skin care and supplement and sun care range.
Targeting everything from treatment, and then you have the main.
Okay, we're going to go ahead with our next presentation.
Good afternoon, ladies and gentlemen. Hope you enjoyed your lunch. We're going to start this afternoon by talking about a practical diagnosis and management of dermatological condition. No, we're not. That's the panel discussion we had a little earlier. What's this one? Discussion 1:30. Getting ahead of melanoma, Dr. Tom Silver. So my name is Kevin Scrimshaw from Dermasensor. We are down the back of the room here. Dr. Thomas Campos da Silva, who you can see in the top right-hand corner of the screen there, give us a wave, Tom, thank you, is here to speak on our behalf. Unfortunately, he's based in Queensland, so Anastasia wouldn't let him come down and go back again. But he's going to present for us virtually and talking about differentiating malignancies from benign lesion mimics. So with that said, I'd like to hand over to Dr. Tom Silver, and he will take you from here. Thank you.
Thank you so much, Kevin. Really wish I was there, but unfortunately, due to COVID, I couldn't make it. So this presentation is about differentiating malignancies from benign lesions. My name is Tom Silver, as Kevin said. I'm a GP and I subspecialize in skin cancers. And I used to work as a radiation oncology registrar before. I was a senior trainee, registered my fellowships. So I had a lot of exposure to cancers in my life. And I ended up developing a special interest because I trained as GP in the Northern Rivers in New South Wales, which is barren region. And pretty much everyone has a skin cancer. So let's go ahead with the presentation. It's a big problem. It's a public health crisis. Melanoma is the third most frequently diagnosed cancer in Australia. And it's the leading cause of cancer death in women aged, men and women aged from 25 to 30. Delays in diagnosis lead to poor prognosis, and invasive melanomas increased by 54% in the past decade. The detection rate of skin cancer by primary care physicians is around 54%. So the challenge is identifying skin cancers early. The early diagnosis of skin cancer is crucial for reducing morbidity and mortality for patients, as well as reducing societal health care costs associated with treatment. Many skin lesions share features of malignant skin lesions, making early diagnosis challenging. Recently, a device was approved to help physicians with clinical decision-making related to differentiating between benign and malignant skin lesions. So what are the common warning signs? Spot, lump, or scaly patch on the skin that is growing or looks different from the rest of the skin. Spot on the skin that is growing, bleeding, or changing in any way. A sore that doesn't heal or heals and returns. Sore developing in an old scar. Round growth with raised borders. So now we're going to run a few examples of frequently encountered benign skin lesions mistaken for skin cancers. Now, this is probably one of the most common ones in my practice, sebaceous hyperplasia. They're common, benign, small, well circumscribed. They're often umbilicated, whitish yellow or skin color. Most on the face, particularly forehead, nose, and cheeks. That's where the challenge is, because most of the skin cancers that we see on the face as well. And they represent enlarged sebaceous glands, especially when they are on the enlarging phase, they get quite inflamed, and that's when they resemble basal cell cancers. They're prevalent in post-transplant patients on cyclosporine and prominent in the Moore-Torre syndrome, which is quite rare. The main differential diagnosis includes BCCs, colloid myelin, calcinosis cutis, angiofibroma, xanthoma, molluscum contagious, lipoid proteinosis, and adnexal tumors such as syringoma, trichomoma, and trichotilloma. Another common one as well is fibrous papule. Fibrous papule of the face is common, benign, discrete, firm, dome-shaped, shiny, skin-colored to pink papule, and it represents an angiofibroma. It's mostly located on the nose, less commonly on the cheeks, chin, neck, and rarely on the lip or forehead. Removal of the tumor is not required unless diagnosis and certainty or suspicion for an early skin cancer exists, which often overlaps with the BCC. Differential diagnosis includes monocytic nevi, adnexal tumors, squamous cell cancer, and BCCs. Dermatofibroma. I think all of you would have seen this lots of times. It's a very classic one. It's common, benign, asymptomatic, well circumscribed, solitary firm, skin color to pink or brown gray, cutaneous or subcutaneous papule or nodule. They're frequently on extremities, mostly lower legs of young adults. They may represent reactive traumatic neoplasm. They can be multiple eruptive lesions associated with systemic lupus erythematosus, HIV, and other immune suppressive states. The characteristic is tethering of the overlying epidermis to the underlying skin with lateral compression. It's called the dimple sign used for diagnosis. So pretty much when you press the skin, it straight away dimples and dives in. So it's probably one of the easiest skin conditions to diagnose. Removal of the tumor is not required unless diagnosis and certainty exists. Solar integrals. The common sharply circumscribed, solitary, or multiple. The homogeneous or variegated, tan to brown black, hyperpigmented. They have variable size, surrounded by normal period skin on sun exposed areas, most commonly on the face, arms, dorsal hands, and upper trunk. Older lesions are often darker and coalesce to form larger patches. Multiple solar lintages may be clinical markers of passive use sunburns and identify individuals at higher risk of developing cutaneous malignancies. They're very common in tradies. I see it often in my practice here between 40 and 50, and very common in the 60 to 70-year-old population, which used to suntan hard, really hardcore with baby oil on the skin. Dysplastic melanocytic nevi, a variant of melanocytic nevi with characteristic histological features, and the controversial suggestion that they may represent an intermediate form between conventional nevi and melanoma. This is probably the biggest challenge that we face. They typically represent as flat, irregularly pigmented and shaped macules or papules. They may exhibit fried egg-like appearance with a central papular zone and a surrounding macular area. Patients with large numbers of nevi and familiar with the history of multiple nevi and melanoma have a high risk of developing melanoma and require close clinical monitoring. And often, I think because of the old algorithm that we used to use, ABCD, which was a bit deceiving, it suggested that people present to get a skin check, and they often think that if they have a mole that's elevated, it's a dangerous mole. And 9 out of 10, the dangerous ones are the flat ones with multiple shades that are the dysplastic melanocytic nevi. Seborrheic keratosis. This is the most common mole that we see in practice, and it's what most patients think that can be something malignant, especially the younger patients. They're well circumscribed, waxy, flat or verrucous, skin colored to brown or black, occur on any body side except palms and soles. It's an autosomal dominant inheritance of lesser trellat associated with malignancy. Usually there is an autosomal dominant inheritance of lesser trellat associated with malignancy. It's usually symptomatic unless inflamed. Variants include dermatosis papulosa nigra, stuccokeratosis, and melanoacanthoma. And often they present like small, they often present like dysplastic nevi, and then they grow in size. And the later stage, they become really scaly and peel off. You can actually peel them off the skin. You have melanocytic nevi, which are also, they can also be very similar to dysplastic melanocytic nevi. And they're benign neoplasms composed of melanocytes. This image is of a junctional melanocytic nevi, a brown macule within the conjunctival epithelium. The differential diagnoses are extensive and most commonly include acrocordons, neurofibromas, sepcase, warts, congenital nevi, BCCs, especially the pigmented ones, lentigos, dysplastic nevi, and melanoma. Then we have Spitz nevi. It's a variant of a melanocytic nevi. Typically presents as pink to red or hyperpigmented papules in children. They're characteristically on the head. They may be clinically indistinguishable from conventional nevi. They're heavily pigmented. The heavily pigmented variant is known as reed or pigmented spindle cell nevi. Differential diagnoses include juvenile xanthogranuloma, pyogenic granuloma, hemangioma, melanocytic nevi, blue nevi, dysplastic nevi, and melanoma. I find that the most common differential for Spitz nevi is dysplastic nevi, melanocytic nevi. Then you have the blue nevi, which often people think that it's common when people have injuries that fall on asphalt and that attaches to the skin, or it can be It can also resemble like a tattoo. They're a variant of monocytic nevi with histological features of dermal distribution and spindle morphology. They're typically heavily pigmented, well-circumscribed, homogeneous, symmetric blue to gray or black papules. They vary in size from small to nodular, typically on the distal extremities of the skull, but they can occur on any side of the body. The cellular variant of blue nevi is often larger and more common on the buttocks and sacrococcygeal areas. Differential diagnoses include dermatofibroma, tattoo, monocytic nevi, pigmented spindle cell nevi, and dysplastic nevi melanoma. Acrocordones, they're also known as skin tags, probably 10% of any GP's skin load. They're common, benign. The skin colored are hyperpigmented. They're soft and often pedunculated. They're commonly seen on the neck, axilla, and other skin folds, including the groin, particularly in obese individuals. They're usually asymptomatic, but they may become painful if irritated. The incidence rate of 46% in the general population. Differential diagnoses include neurofibromas, monocytic nevi, fibroepithelial tumors, seborrheic keratosis, and warts. Calcinosis cutis, it's a deposition of calcium salts in the skin, pretty much. The 5 types: dystrophic, metastatic, idiopathic, iatrogenic, means induced by someone, and calciphylaxis. The differential diagnosis includes milia, calciphylaxis, molluscum contagious, xanthomas, verruca, osteoma cutis, gout, tenosynovitis, and cutaneous nodular amyloidosis. I probably would say that it resembles the most in clinical practice to gout. Warts, we all know about this one. Benign proliferation is caused by various human papillomavirus subtypes. They spread by direct or indirect contact. They present as skin-colored hyperkeratotic papules with a rough, irregular surface. They manifest as common warts, genital warts, flat warts, palmoplantar warts, focal epithelial hyperplasia, epidermal dysplasia, vericiformis, and plantar cystic wart. The differential diagnoses include acquired digital fibrokeratoma, actinic keratosis, cutaneous horn, molluscum contagious, seborrheic keratosis, and squamous cell carcinoma. The treatment might be quite difficult with frequent recurrences. Often we treat it with dry ice and it doesn't work well. And the way I treat these lesions is pretty much I diatherm with them. I excise them and then I diatherm the edges. Then you have pyogenic granuloma. It's a benign, rapidly proliferating, solitary, broad-based, pedunculated, polypoid bright red papule and nodule with a distinct rim of keratin. It develops in areas of trauma and it bleeds with little or no trauma. It may also arise in pregnancy, particularly on the gingiva or the gum. The differential diagnoses include atypical fibroxanthoma, bacillary angiomatosis, hemangiomas, glomus tumor, basal cell carcinomas, squamous cell carcinomas, Spitz nevi, metastatic carcinoma of the skin, Kaposi sarcoma, and amelanotic malignant melanoma. And you can get rid of them easily with either dry ice or with diatherm. So BCCs, they're probably the most common skin cancer in Australia and the world. The common characteristics are translucency, ulceration, pigmentation, telangiectasia, rolled or pearlescent borders. And they can be mimicked by subtypes. So you have the nodular subtype, pigmented, morphiform, superficial, and fibroepithelial. Diagnosis of Bowen's disease. Bowen's disease is a precursor of squamous cell carcinoma. It's extremely common as well. It's superficial, it's non-invasive, and it's pretty much a excessive growth of the keratin on the skin. It appears as a sharply well-demarcated scaling or hyperkeratotic macule, papule or plaque, and it's often mistaken for dermatitis, psoriasis, or fungal infection. While as a rule of thumb, melanomas appear disorganized dermoscopically, it is possible for them to present as organized and nevi-like. The difficult to diagnose melanomas include schizoid, verrucous, epidermotrophic metastatic, amelanotic, nodular, desmoplastic, and nevoid. If an organized lesion has one or two distinct patterns, one or two structures, one or four colors, then malignancy should be suspected. The most common algorithm used in Australia was developed by UQ called KSO Cruz, and basically it's this third topic, it's what it's talking about. So these are dermoscopic images of representative melanocytic nevi cases showing non-typical benign dermoscopic patterns. So if you look at A, it's a hyperpigmentation of a nevi. So nevi are often not as dark as this one, but this presents as hyperpigmentation. The same here, you have one aspect that's hyperpigmented, and here you have an elevated nevi. These are dermoscopic images of representative melanoma cases showing non-typical parallel ridge pattern by dermoscopy. These are classic for melanoma. Melanoma with vascular structures, this is not common. Melanoma with dots in blue, whitish veil. Whitish veil is probably one of the most common features, or one of the most pathognomonic features of melanoma. And melanoma with streaks and hyperkeratosis. Streaks are these, almost like as if it was a dot of ink on water. And this is also very, very common in melanomas. So what is dermosensor? Based on this new technology called elastic scattering spectrography and artificial intelligence, dermosensor is an on-the-spot assessment tool, which has demonstrated detection of melanoma with 100% sensitivity and non-melanoma skin cancer with 94% sensitivity in published trials. Dermosensor output has been validated in several large-scale clinical studies using tissue histopathology as a gold standard. It's a decision support tool which aids physicians in medical decision-making at crucial junctures in patient care, such as when deciding whether to biopsy or if a lesion to continue to follow with observation. I just happen to have one here to show you guys if you haven't seen it before. It's a little bit bigger than an iPhone, a bit thicker, quite lightweight, and it's very practical and easy to use. We'll get through that later. So what does dermosensor do different? It looks below the surface. This technology called elastic scattering spectroscopy, it captures cellular and subcellular information. It compares lesion scan with a database of thousands of spectral lesion recordings. So these are spectral curve differences for different lesions, and it's as we said before, it adds on to dermoscopy, which has been the only tool that we've had before. So we have this data on specificity and sensitivity of detection of skin cancers with dermosensor and without dermosensor. That's for primary care physicians. And we're going to go through the output interpretation based on trial data. So the big study that was done with 1,700 benign lesions, 917 malignant lesions. And all of these lesions were studied in the study were biopsy. And the first iteration of dermosensor was pretty much the machine would get the machine, and it would basically you start a lesion, and the result would be either monitor or biopsy. And it was exceptional at ruling out malignancies, but it was picking up a lot of false positives. And the second iteration, which has been absolutely brilliant, gives us basically two outputs. One is we monitor or we don't worry about it. And the second one is further investigate. But the further investigate in the second iteration, it classifies the lesions, it grades them from numbers. So it's pretty much we now have a lot more certainty of what to do when we have further investigate. If it's 1 to 4, it has 7.1% of a positive predictive value of detecting skin cancer. When the score is 5 to 7, it jumps up to 27%, it's almost 1 in 3. And when it goes from 8 to 10, it's more than half, 60%, close to 60%, so it's huge. And even the monitor on the second iteration, which was a little bit higher before, is still very high. It holds 99.5% negative predictive value. Now we're going to go through a few cases and how DermaSensor helps interpret these cases and what's the added value. So we've got a 75-year-old Fitzpatrick 2 female with personal history of skin cancer, present with elevated, rough, light-colored 3 by 4 millimeter lesion on the right cheek, which is reportedly changing. The dermatologist diagnosed it as squamous cell cancer with a low confidence. The DermaSensor output was monitored, and the pathological diagnosis was solid keratosis. So if you look at this lesion here, this is classic 75-year-old. You'd be crazy if you didn't biopsy this. And when you get to that age, you've already been through so many medical treatments, so many investigations, and every time you go to a GP, a skin cancer GP or dermatologist, the last thing you want is a biopsy when things are unsure. So you want a little bit more certainty, and DermaSensor is brilliant for these cases. We got case number 2, a 70-year-old Fitzpatrick 1 male with a family history of skin cancer and presents with a flat, smooth 4 by 5 millimeter lesion on the left posterior auricular sulcus. The dermatologist diagnosed it as a benign ulcer with high confidence. The DermaSensor output was further investigated, and the pathology came back as squamous cell carcinoma. This is another classic presentation in my practice as well. This is an area where people have a lot of dryness in the skin, and often they present with flaky, and it's a quite difficult area to biopsy as well, because you biopsy and you can't put a dressing properly. Dressings never stick there, and it tends to bleed a lot. So when you have something like DermaSensor that can rule out and we don't have to biopsy something like that, it makes our life a lot easier. Case 3, 85-year-old Fitzpatrick 3 female with personal history and family history of skin cancer, presents with a flat, smooth, light-colored 2 by 4 millimeter lesion on the left shin. Dermatologist diagnosed it with a benign lesion. DermaSensor was further investigated. The pathology was basal cell cancer. So,
Tom, we've got about 3 minutes left. If you can move through these cases fairly quickly.
Wonderful. Look, perhaps this can be downloaded, so perhaps I might move on, and we'll flip through them quite quickly so you can just appreciate them. And I want to chat to you guys about my experience with DermaSensor. I started using it about a year ago, and I went through the first iteration and the second iteration as well. And it's an exceptional tool, at least for me, because patients often, I used to work in a high volume skin cancer clinic that we used to do about 30 skin checks a day, 30 to 40 skin checks a day, and I would go from room to room. And often when you're doing these very quick skin checks, patients, it takes about 6 to 7 minutes to do a skin check in a patient with 30 to 40 moles. Most people have a common moles, hemangiomas, seborrheic keratosis, a few solar keratoses here and there, solar lenticles. This is what we see every day. But when we see something slightly different, we appreciate it on dermoscopy, which is, a small tool like that. And sometimes patients are hard to be convinced that they need to be further investigated. And then you add another complicating factor, which is whenever we biopsy lesions as doctors, we receive an extra incentive. So a normal consult, a biopsy would pay as much as a consult for a GP or a dermatologist. So when you start telling patients that they need biopsies and there's a potential, obviously no one should be thinking like that and no one should be doing that, but people can be deceived, and sometimes they can, how can you trust a doctor that you've never seen before and you know that he's going to get extra money if he biopsies you? And DermaSensor comes in to add that extra layer of confidence, and it will standardize the industry once it starts being taken by most of the doctors. And I can't see it not happen. It's artificial technology. It's the only way forward. So when patients would come in and I would show them the monitor output, it's brilliant. I could have reassured them already. Monitor, it's not a big deal. But when the machine shows further investigate, it's hard to debate with the machine. So it adds an extra layer of confidence for the doctor, and it adds an extra layer of confidence for the patient as well, that the doctor is actually doing the right thing. Especially doctors who don't have a lot of experience in dealing with skin cancers, or doctors that work in very isolated areas and they don't have access to other doctors to discuss cases. So that first iteration, which was monitor and further investigate, was very good in ruling out these lesions and getting further biopsies. But then we ran into the trouble of when it said further investigate, the algorithm was so sharp in saying that a lesion is not a cancer that we were starting to pick up a lot of things that weren't cancer as cancer. And I felt it was good for me, but I don't know if it was as good for a lot of doctors who haven't done a lot of skin cancer in their life. And the second iteration was brilliant because it started grading those lesions, and especially lesions that are pigmented, like these ones you see on the screen. The chaos includes algorithms, quite a complex algorithm. It takes a lot of time for you to get your head around it, and a lot of experience seeing those dermoscopic pictures. You don't see melanomas every day. Even seeing 30 to 40 patients a day, when I was doing high volume skin checks, I would probably pick 2 melanomas a week. And we're talking about Queensland, Brisbane area, the Northern Rivers area, which is, the sun is always shining here. People are very exposed to the sun. In places like Victoria or, some country, New South Wales areas, you wouldn't have as much of a frequency. So it's very hard for you to get your head around that chaos includes algorithm and be exposed to these features, these dermoscopic features of melanomas. And the machine accelerates that process for you. It literally starts ruling out things that you don't have to look at. And it starts adding on that value to dermoscopy. It's a brilliant tool.
Thank you, Tom. We need to move on. We really appreciate your time this afternoon, and sorry you couldn't join us here in person. You can probably tell he's got a character larger than life, and you can imagine that when he's here, things can get a little out of hand. So sorry to cut you off there, Tom. But yeah, please, in the next break, if you want to know a little bit more about the device, come and visit my colleague and I up the back there, and we can overwhelm you with statistics and analyses and different cases. And if you want to have a look at some of those cases, we can certainly share them with you. But for now, thank you, Tom, and we'll talk again soon. Cheers.
Thanks everyone for listening. It was a pleasure.
Thank you, Tom and Kevin. Now, our next presenter has worked for Canberra Health Services for 7 years, initially completing the new graduate program before moving into intensive care unit and later becoming a nurse educator.
Her interest in wounds and dermatology came about through the Tissue Viability Program, which has led her to being the first dermatology advanced practice nurse in Canberra Health Services, commencing in July 2019. She was the ACT State Chair for Wounds Australia for 3 years and has completed a graduate certificate in intensive care nursing and the Emerging Nurse Leader program through Australian College of Nursing. She's looking to pursue further postgraduate studies in dermatology nursing. Please welcome Marisa Baker.
Good afternoon, everyone, and thank you for asking me to present at this conference. So I'm very excited to be here, especially from Canberra, which seems to be a small town compared to everywhere else. So my background is a bit of a random one. I was a new graduate and then I did intensive care for 4 years. And then I did a stint in wound care. So I was one of the wound care nurses for my hospital in Canberra, which sparked my interest in dermatology. And then a position came up in the dermatology advanced practice nurse at Canberra Health, which was the first position. So I've been in that position since 2019. So it's been a steep and interesting learning curve. So thank you for asking me to present. So today I'm going to talk about some of the healing process for wounds. It's a little bit different to dermatology, but some of the principles cross over. The rationale for a wound dressing, the ideal wound dressing, and some of the genetic categories of dressings. There are thousands of dressing products on the market. So how do we simplify it for our patient, especially within private practice or the public health system? Aseptic technique, I'll just touch on that briefly just because it's a huge subject in itself. And hopefully we can finish off with some case studies. So I do apologise about going through this presentation quite quickly, just in the interest of time today. So does anyone know the normal wound healing process? So there's four stages of wound healing. So the first stage, obviously, if you do an excision, you want to create hemostasis, and that happens within minutes. So that happens at the time of injuries, and the capillaries contract and the clot forms. We have the inflammation phase, which happens through a 0 to 4 day period. That's where the wound causes vasodilation and of the surrounding tissues, which flood the area with inflammatory cells. So if you get a wound that seems not to be healing, it's usually stuck in this inflammatory phase, and it really struggles to get on the next phase, which is the reconstruction phase, which happens in normal wound healing over a 2 to 24 day period. And this has a release of growth factors, which stimulates new vascular networks and collagen synthesis, and wound contraction happens during this phase. And then you've got the maturation phase, which is the last phase of wound healing, where you've got the reduction in capillaries and collagen, strengthening of scar tissue. So it's really important when you see a wound, what kind of phase it is in, and thinking about if it is stuck in that inflammatory phase, does it have biofilm, which is a whole subject in itself. So how do we assess a wound? It's sometimes quite complex, but the evidence is of that little box from Wounds Australia in the standards of wound prevention and management. And in standard 3, it has standard 3.3, comprehensive and ongoing assessment of an individual's wound. So in this evidence criteria, you've got the initial and ongoing assessment and documentation of the wound. So you've got type, etiology, duration of wounding, and that guides your management process. On anatomical location is important. Wound dimensions, that's important for your collative data in terms of if you got wound healing. So if it's 10 by 10, has it reduced in size since you last reviewed it? The length, width and depth is obviously important. Probing as well can help. The wound area measured in the wound circumference, sometimes you can trace it on a grid and put that in the patient's notes. The exudate volume and the characteristics of a wound bed, and the peri-wound and surrounding skin, which I think we appreciate more in dermatology than other areas, and exudate management and phase of wound healing. So these are just some of the standards in the evidence-based guidelines, but a more simple term that I like to use is the TIME acronym. Put your hands up if anyone's used this to assess wounds. Okay, yeah, so I usually use it by tissue. So tissue, is it healthy tissue or is it unhealthy tissue? So using T, the acronyms, so tissue, you've got epithelializing tissue on the left-hand side, you've got granulating, which is your red tissue. You've got hypergranulating, so that sometimes needs acting upon. Otherwise, you won't get wound healing with that. Necrotic, where it's non-viable tissue. You know, do you need to debride it by surgical debridement, or do you need to autolytic debride through dressing management? And, you know, also understanding, you know, is it a palliative wound as well? Do we need to achieve wound healing, or do we need to make the patient comfortable? Are they in palliative care? And obviously slough, which we get in that inflammation phase, and how do we get rid of it or reduce it? So inflammation or infection, so that stands for I. This is a normal part of wound healing and expected in the acute phase. Knowing the etiology of wound types helps with the expectation and guidelines of increased or prolonged inflammation. So I got some, they look more of a atypical wounds that you might see maybe in private practice or in the hospital. And so help reducing that inflammation, or is it a risk of infection, is quite important. The next, what M stands for is moisture. I think this is one of the most important things to consider when you're considering wound management, because we don't want a wound too wet, otherwise you're going to cause maceration, and you don't want it to be too dry, otherwise you're not going to get those good cells going to the wound. So having that moisture balance of moist wound healing is really important. So if it is too wet, you want to wick that moisture away. You want a super absorbent dressing. And if it is too dry, do we need to add moisture? Some wounds you don't want to add moisture to, but some you do, to help with that wound healing. Edges are really important of the wound as well. Are they indistinct, attached, rolled? You usually get rolled with chronic wounds, and is it undermining as well? And can you probe, and does it need packing as well? So before you dress a wound, wound bed preparation is essential. So the good cells need moisture and a clean wound bed before they migrate across the wound. And we want to clean and debride a wound if necessary. So the solution usually should be warm to body temperature, and sometimes cleaned as firmly as the patient can tolerate to get rid of that slough if there is any. You also want to look after the peri-wound and surrounding skin, and I think we appreciate skin in general with the peri-wound and looking after it, especially with those lower leg wounds, to ensure that they are hydrated and have got emollient on them. And the peri-wound is an extension of the wound, so please take care of it too. So has anyone seen a Debrasoft lolly? Not that I'm associated with any kind of wound care company. So a Debrasoft lolly is like a microfilament pad. I relate it somewhat to an ADNA glove, and then you can sometimes get rid of that slough or biofilm on top of a wound. You also got to consider pain in terms of cleaning a wound. So you want to make sure that the patient has adequate pain relief and it's not too painful. Am I going too fast? No. So some of the cleansing solutions out there that you may see or may not see. So you've got obviously betadine, and that's a good broad spectrum antiseptic. Normal saline that everyone uses, which is an isotonic solution. You've got acetic acid vinegar, so that's really good for assisting if your wound is colonized or has Pseudomonas in it. Sometimes it does sting, so there is a dilution to it that you need to be aware of. Prontosan, that's got PHMB, and that's a antimicrobial agent that can reduce bioburden and is good in assisting with that gram-negative and gram-positive bacteria, fungi, and yeast. And with the Prontosan, you do kind of soak it on for 10 to 15 minutes, and then you clean it with Prontosan afterwards. So I'm not sure if you've seen these products in the public or private practice, but in most public hospitals, you will get a majority of these products. So following your assessment of the wound, consider what does the wound bed need? Depending on the etiology, or if it's too wet, do we want to wick away that moisture? what does the product do? So there's heaps of products out there, but does the product wick away moisture? Does it add moisture? You know, if your query that there's potential local infection or inflammation or high risk of infection, you don't want a product that is occlusive to the wound. What does the patient need as well? Is it comfortable for the patient? What is available? Because everyone has different resources that are available. And what is practical for the patient and the wound? So obviously there are heaps of dressing products out there. And so how do you choose the right one? And the dressing selection is based on the assessment of the wound. And once you have a good understanding of the assessment, the dressing choice becomes very simplified. So I think you've got some dressings on your table. So having a look at them and relating that to a wound category, we can go through that. And we've got some case studies at the end if we have time. So I think one of the companies has, thank you very much, have provided some of those products. So having a look at them and thinking about what category they go into and what that product does. So, and I think you've got some dressings, a dressing pack in there as well. So what are sometimes you can do the functional categories of a wound. So is it atraumatic? So if you've got someone with very fragile skins, potentially a patient that has EB, you don't want a product that has like a film on it or a huge adhesive on it. Otherwise, you're going to strip that good skin away. So something that's atraumatic is something to consider. You know, is it a silicone base? You know, can it be removed without trauma? Is it suitable for fragile skin? Do we want to hydrate the wound? Does your product add or retain moisture? Does it protect your wound? Is it waterproof in the shower as well? Do the patients need to protect it from the shower? Exudate management is really important. Does it absorb and remove the exudate that you need? Do you need something like negative pressure if it's there's significant exudate? Does it autolytically debride or does it remove non-viable tissue or slough? And if you're concerned about infection or there's local infection, does your product, is it an antimicrobial, and what are the antimicrobials out there? And that reduces bioburden, inhibits biofilm formation, and you can get them in numerous products like MediHoney, chlorhexidine based, PHMB based, your silvers or your iodine based products. And looking at the dressing, and is it a 2-day product or can it be on for 7 days? And that's also based on your exudate as well, the wear time. And this all comes from the Carolyn Carville book that I use as a resource within my organisation. So some of the primary dressings, these are just examples of them. So I think you got on your table an example of, what a film-based product is. So you've got your Tegaderms or your IV3000s. I'm just relating to what I use back at the hospital. There are heaps of products out there. Is it a hydrogel? Does it add moisture? So something like Solugel or Intrasite. Is it a calcium alginate? So there's heaps of products out there, but Caldestat is one of them. Is it silver impregnated? And they come in, huge varieties of foams as well. Is it a transparent polyamide, which are your Mepitels? Is it an island dressing as well? So that's like a Primapore kind of dressing. Is it a hydrocolloid or your Comfils or your Duoderms? A hydrofiber, which are your Aquacels, or foams, heaps of foams out there. Mepilex is one of those brands. Charcoal pad, which we don't use that often. It's usually used to reduce odor. Is it a tool? There's heaps of tools out there. You've got your Inadines, your Gelinettes, and they have antimicrobial properties as well. Obviously, absorbent bags, MediHoney, and negative pressure wound therapy. Has anyone used negative pressure wound therapy? Please put your hand up if you have. Yes. So if you've got heaps of exudate or like a big cavity, you can use negative pressure wound therapy. So hydrocolloid, it's impermeable to gas, bacterial, water, vapor. It does create that moist wound healing environment. It does absorb low levels of exudate, so it has to, and it does go into this cloudy base some of them once in contact with a wound, which isn't bad. It's what the dressing does. It is conformable and flexible, and sometimes it does autolytic debride necrotic tissue, but you've got to put it on for a period of time and you've got to take it off. And you know, just be aware on removal, if you've got fragile skins, using an assistant kind of removal wipe to get rid of that. But if it's normal skin, it's usually quite easy to remove. You wouldn't want to put it on infected wounds. You got your film-based dressings. They're widely used. They create a moist wound healing environment. They can be waterproof and they can also secure other dressings. Obviously, you don't want huge levels of exudate because that's not going to, sometimes, especially for your sweaty patients, it's not going to wear very well. And your wear time can be weekly or as needed. Obviously, you don't want to put it on critically colonized or infected wounds or a cavity. And obviously, caution when removal if you do have fragile skin. You got your hydrogel, so that's kind of a wound which you would probably add some moisture to. It's quite dry. So it's designed to hydrate well wounds for cell migration. It does aid in autolytic debridement. It comes in gel sheets or it's impregnated. You do want to frequently change the dressing, otherwise it might get too macerated. And obviously, if you're adding moisture, you don't want to put it on a wound that's got heaps of exudate on it because you're not achieving your moist wound healing environment. And you just got to take care of your peri wounds. You don't want it to get macerated and break down. Otherwise, we're not going to achieve wound healing. And those are just some examples of some products out there. You got your hydrofibers. So they go into a gel once in contact with a wound, and it's a non-woven pad or ribbon that absorbs body fluid and transforms into a soft gel. You can get them in a ribbon. So for your pineidal sinus, they're really good in those little cavities as well. And they can come in antimicrobial properties impregnated with silvers in them. And they assist with autolytic debridement as well. You got your calcium alginate. It's really good for your bleeding wounds or post-operatively. If you're bleeding initially, you can put some Caldestat on it initially and then change it to a different type of dressing. So it is made from seaweed. It promotes in hemostasis. It forms into a non-adherent gel. You don't want to use it for infected wounds as well, and you want to change it quite frequently. And obviously, you do want a secondary dressing for this. You got your super absorbent dressings as well. They're really good for your highly exudating wounds, especially in your lower legs that keep oozing heaps of exudate. The super absorbent dry wicking cellulose pads with a non-stick contact surface. I think you've got an example on your table as well. And you want to fixate that with a secondary device as well. You got your foams. There's different foams out there. And they're non-adherent, so atraumatic. They're highly absorbent as well. They conform to different body surfaces, and they come in numerous shapes and sizes as well. So, and they come with antimicrobial properties as well. So what are your antimicrobials? You've got your silvers, medihoney, chlorhexidine impregnated, BHMB impregnated, and your iodine-based products. So they're good for localized wound infections or systemic infections. So if you've got an infected wound and someone's on antibiotics, it's good to add a topical antimicrobial. And just as antibiotics, you do a 2 to 3 week wound challenge. So if you don't see a difference in 2 to 3 weeks, do you need to change to another antimicrobial dressing, or do you need to assess it, or does it need something else? So not continuing this kind of treatment for a couple of months. So indications for antimicrobial dressings, you want prevention of infection in patients with increased risk of wound infections. So people that have, diabetes are at increased risk, or people with perfusion issues and you've got the lower leg. Treatment of localized wound infection, and using it for 2 to 3 weeks and to reassess after that. So some of the common wound types that I see in the hospital and as previous tissue viability nurse, not as often as I see in dermatology now, is a pressure injury. So you can get device-related pressure injuries or pressure injuries from other areas. So you got the heel and above the ear from potentially the nasal prongs. So it is a localized injury to the skin and underlying tissue, usually over a bony prominence as a result of pressure or pressure in combination with shear and friction. And you've got your evidence-based guidelines on how to manage that, your international pressure injury guidelines, which were recently launched in 2019. You got your skin tears and different categories of skin tears, which were created by the International Skin Tear Advisory Panel. And that's by a wound caused by shear and friction or a blunt force, resulting in the separation of skin layers. You see this really common in elderly patients, especially when they knock themselves. Or so knowing the different types, where you've got type 1, type 2, and 3, and you want to put a dressing that's atraumatic on that, and plus or minus an antimicrobial if there's risk of inflammation or infection. Whoops. Arterial or venous mixed leg ulcers. So you've got venous leg ulcers, arterial leg ulcers, neuropathic diabetes, diabetic leg ulcers or pressure ulcers. And you've got the evidence-based guidelines on the prevention and management of venous leg ulcers done over there. Some of the resources, the atypical wounds document is pretty much got dermatology conditions in it and is a very good resource to look at with those atypical wounds that you might get. Obviously with the surgical incisions that you might see in public and private, wound infection is something to consider post-operatively. So looking at the best-based principles and evidence-based practice on that is a very good resource to manage those skin conditions. Some more resources in wound assessment and management. You've got the wound care manual, which I use quite regularly, by Carolyn Carville. Standards of wound care, prevention and management. So the national body of wounds is Wounds Australia, and some other resources, wound healing and skin integrity documents. So those are some resources to consider. Aseptic technique, I'm sorry I can't go to too much detail about this. It is a whole national healthcare quality standard in itself, and it's under the standard 3 in preventing and controlling healthcare associated infections. So in aseptic technique is the application of infection control principles to prevent the contamination of key parts and key sites by microorganisms that cause healthcare associated infections in patients. And it's something that the government really looks upon closely. And that data from the hospitals, it goes to the National Healthcare Quality Standards. So it's a little bit confusing, but you want to promote, it's promoted by identifying and then protecting key parts and key sites by the application of hand hygiene, hand asepsis and non-touch technique using sterilized equipment, just like the dressing pack on your table, and cleaning and existing key parts to a standard that renders them aseptic prior to use. So key parts is the critical parts of the procedure equipment or the medical devices that come into direct or indirect contact with other aseptic key parts. Any liquid or key sites which are then contaminated have the potential to transfer infectious microorganisms to the patient, for example, like an intravenous needle port, a needle tip, sterilized swab for wound care, a patient interface of a sterile dressing, and key sites is any portal of entry on a patient, such as an open wound, a catheter insertion site, a skin puncture site, like a bone marrow biopsy site, or a cannula to the wound. So there's some cool, I got some pictures from Royal Melbourne. And so there's a picture of your key sites, which are the medical device access sites or an open wound. And then the key parts down the bottom, which is the most critical parts of any procedural equipment. They're likely to cause infection if contaminated. So just considering those when you're doing the dressing is important. And they had quite a nice diagram and a flow chart in terms of a pre-procedural guide. So, you know, do we need a standard aseptic technique or do we need a surgical technique? Consider the environmental factors and key parts, key sites. You know, how big this procedure is it going to take longer than 20 minutes? So obviously hand hygiene is critical as well. So just using, and there's heaps of information out there on key parts and key sites and aseptic technique. So I'm just gonna, how long do I have? 2 minutes, so I'm gonna finish off with one case study. Oh, and if you wanna open your dressing pack just to have a look at the key parts and key sites, that would, no, okay. We'll just go through a case study then. So 6-year-old female with pyoderma gangrenosum, something that you might see in your practice. So understanding the etiology and wound type, is it gonna be acute or chronic? Asking the patient how long they've had this wound. Obviously with pyoderma gangrenosum, you're gonna have significant pain. So having good analgesia prior to the dressing change is really important. Location, so this is how I would document location. Dimensions of the wound, is it approximately 10 by 10 or 10 by 5? You know, is it superficial or deep? What does the tissue look like? So can anyone describe the tissue that they're seeing here? So I would describe that as there's some granulation tissue there, but there's quite a significant amount of slough there. So, and looking at that peri wound as well. So there's obviously lots of inflammation. How much exudate is coming out of that? So looking at also the previous dressings, you know, did they hold the wear time? Are they too wet or are they too dry? What does this wound need? So considering, you know, does this patient need an antimicrobial dressing or a bacterial binding dressing? Obviously, you want this dressing to be atraumatic because the patient's going to have significant pain and protecting the edge of the wound. I just thought I'd quickly touch on this other case study, which I thought was interesting because you can't heal all wounds. So I looked after a patient who had meningococcal sepsis. So this is when I was a tissue viability nurse. So looking after this patient pre-terminalization of digits, are we going to achieve wound healing with this case? No. Do we want to add moisture to this wound? If you're going to add moisture, we're breaking down obviously that necrotic tissue, which is bad for that patient. We want to just prevent infection and we want to keep that wound dry. So, and basically we're leaving that wound bed intact till obviously the demarcation process happens. So you're probably using just an antiseptic every day. So in terms of this patient, I just use a betadine paint every day as an antiseptic and kept that wound dry, and being aware that I did not want to add moisture and I wanted to prevent infection to the point where this person could have surgery and terminalization of the digits. And post-terminalization of the digits, obviously with those exposed areas were significant pain, but just being aware that not all wounds can be healed. So what is our treatment objective for that patient? Thank you. Any questions? Or I don't think we have time for questions. Oh, just one. I think it's, yeah, I'm pretty sure it's a, oh, we'll just grab my, is it dual fiber? I don't believe it is. I think it's under the banner of hydrofiber, but I can't confirm that. If you sometimes, if you go to the wound rep over there, the packet will usually state underneath what category it fits under. So there should be a foam there, and it specifically states a foam. It should state potentially hydrofiber. So I would put that under the hydrofiber dressing. So, so that, and if you put, I'm not sure, you can ask the company, but if you put it in water, does it go to a gel? So, and so obviously that's quite nice when you remove it. Thank you.
Thank you, Marisa. That was a nice presentation. Now, I just want to make sure that all the attendees have raffle tickets because we are going to draw our first winner. So for our first raffle prize, sponsored by Galderma, let me call Libby to present it. Libby, come up the stage, please. Thanks. Okay.
Oh, do I choose it as well?
Yes,
no
please.
pressure. Oh, goodness. Oh, Antonia Kim. Yay!
Antonia Kim, congratulations.
Oh, come this way.
Nice to see you. Okay, please enjoy your afternoon tea sponsored by Pierre Fab, and let's carry on with our trade exhibition.
New South Wales, and I'm very excited to introduce to you all Luigi.
Hi everyone, my name is Luigi and I'm your new medical manager for New South Wales South.
Now, we represent the two brands La Roche-Posay as well as CeraVe. So if you want any information regarding these two brands, please feel free to reach out to us via email or our phone numbers. Now, if you're a bit unfamiliar with our products, basically we offer things for sun protection, acne, atopic dermatitis, sensitive skin, rosacea, as well as anti-aging. Now, Luigi, in terms of our actual support that we're offering for the nurses, what are we providing?
So like everyone, we have had to adapt to these very difficult times. It doesn't mean we've stopped our support for our healthcare professionals. So we are still doing in-clinic trainings if that is appropriate. However, we have had to adapt and we also offer our online trainings as well. In terms of samples, we are still very happy to provide that to your clinics to give out to your patients. And as a personal thank you from La Roche-Posay and CeraVe as well, we are also providing you guys with our solidarity packs, which come with products to help maintain your healthy skin barrier during these times.
Make sure you reach out to us for your solidarity pack. We're more than happy to provide you with those. And in terms of what's new from both of the brands, I'm very excited to introduce to you the Anthelios Invisible. Now, this is a renovation on our beloved product Anthelios Ultralight Fluid. Basically, it has new netlock technology within there to really help with the spreadability and the efficacy of the actual sun protection. Now, in terms of CeraVe, Luigi, what do we have?
I'm very excited to introduce you guys to our new CeraVe SA Smoothing Cream and Cleansers, specifically for your patients who are suffering from keratosis pilaris to help smooth out that rough and bumpy skin on your patients.
Now, we're going to wrap up. You're all going away with a gift bag from us today, and you have our information, contact details in there. Feel free to reach out to us then, and hopefully we'll see you all at ADNA in April next year.
Bye, everyone.
Bye.
Yeah, so we're just checking. This is clockwork. No, we did not.
Yep, that's fine.
That's fine. We're just trying to work out this, you know. Does this thing work? No, we were trying to, but because we didn't have the pipes, you know, the plucker. No, we don't want to do it. So we want to do this to do us as a dialogue. So you put one mic to go. Okay. And this you're driving this, you know, so this just moves on. This is for forward, this is for back. And this is a pointer, I think. But we won't need a pointer, I think.
No, I don't think so.
This thing works. Does this come on? The countdown thing, does this come on? That might be. Yes, it should be. So let's click the next.
At Janssen, we are called to rise each morning
and achieve today what last night seemed unimaginable. We are called to blaze paths where others fear to go, to unravel and repair the very code of life, to treat, intercept, prevent, and cure. We are called to open our doors to collaboration and our arms to the needs of each patient, so that what works in our labs also works in their lives. We are called to advance how medicines are made and made accessible around the world. We are Janssen, the pharmaceutical companies of Johnson & Johnson, and we are heeding the call, bravely and boldly, fighting sickness with science, improving access with ingenuity, and healing hopelessness with heart, until the world's most daunting diseases are found only in the pages of history books. At Janssen, we're creating a future where disease is a thing of the past. At Janssen, we are called to rise each morning and achieve today what last night seemed unimaginable. We are called to blaze paths where others fear to go, to unravel and repair the very code of life, to treat, intercept, prevent, and cure. We are called to open our doors to collaboration and our arms to the needs of each patient, so that what works in our labs also works in their lives. We are called to advance how medicines are made and made accessible around the world. We are Janssen, the pharmaceutical companies of Johnson & Johnson, and we are heeding the call, bravely and boldly, fighting sickness with science, improving access with ingenuity, and healing hopelessness with heart, until the world's most daunting diseases are found only in the pages of history books. At Janssen, we're creating a future where disease is a thing of the past. At Janssen, we are called to rise each morning and achieve today what last night seemed.
With DermaSense's easy-to-use point-and-click device, you and your team members can evaluate suspicious skin lesions for cancer risks in under 30 seconds. This innovative, non-invasive technology means cancer checks are easier than ever to integrate into your appointment workflow. Not only could it help you avoid benign excisions with poor reimbursement rates and unnecessary morbidity, but it may also help you drive both cancer detection and greater confidence in your clinical decision-making. To learn more about how our groundbreaking device may help you detect more of your patient's skin cancer, visit dermasensor.com today.
Acne vulgaris affects 85% of the population at some point in their life, compromising their psychological well-being and sometimes leading to scarring. Facial acne is the most common presentation of the disease, but at least 50% of patients also suffer from truncal acne. To date, truncal acne has received little attention in clinical studies, creating a gap in treatments for patients with facial and truncal acne. Acne skin exhibits increased sebum secretion and hyperkeratinization in hair follicles, which contribute to comedo formation and creates the perfect environment for the growth of Cutibacterium acnes. Inflammation is key in the progression of acne. Subclinical inflammation precedes the formation of microcomedones, and inflammatory lesions may arise from clinically normal skin. Retinoids are the foundation for acne therapy because they inhibit the development of microcomedones and have anti-inflammatory properties. Triferritine cream, a new innovation by Galderma, was designed specifically for the treatment of moderate facial and truncal acne. It regulates epithelial cell differentiation and has strong anti-comedogenic and anti-inflammatory properties. Triferritine was designed to selectively bind to retinoic acid receptor gamma, RAR gamma, and induce DNA transcription. RAR gamma is the most prevalent receptor subtype expressed in the skin and recognized as important in acne. This fourth-generation retinoid is characterized by low systemic absorption, even under maximal use, making it ideal to treat acne on large body surface areas, such as the trunk. Triferritine's efficacy in facial and truncal acne is proven in 2 identical, multi-center randomized clinical trials with more than 2,400 patients across 10 different countries. As with other retinoids, most local adverse events were mild and included skin dryness, erythema, scaling, stinging, and burning. They peaked during the first weeks of treatment, subsiding thereafter. Galderma is a leader in the development of scientifically defined and medically proven solutions for the skin and is committed to help millions of patients whose lives are impacted by acne.
Okay, for our next presentation, Dr. Gupta is a dermatologist with nearly 30 years of international experience in the specialty. She set up Australia's first pigmentary disorders clinic and manages a psoriasis biologics clinic in chronic eczema clinic at the Skin Hospital. She's the head of phototherapy at DSH, spearheading policies and protocols and driving teaching in the area. Dr. Gupta is the director of dermatology at Liverpool Hospital, which is one of the largest dermatology departments in New South Wales. Her primary private practice is in Luma near Campbelltown, and she enjoys the challenge of working with different demographics across the city. Along with her is Glenda Newham, who has been a registered nurse for over 30 years and has worked in several specialties such as medical, surgical, pediatrics, and day surgery. In those years, she has developed a keen interest in dermatology, working in biologics, eczema, and psoriasis clinic at the Children's Hospital Westmead, then joining the Skin and Cancer Foundation, now known as the Skin Hospital. Please welcome Glenda Newham and Dr. Manisha Gupta.
Good afternoon. Thanks everybody for coming. Our presentation is going to be a day in the life at a dermatology hospital, phototherapy clinic. Just going to put our next slide on.
Hi, good afternoon, everyone. Thanks for the opportunity to speak at this forum. We are going to take you through a working day at the Skin Hospital together. With Glenda, as you know, is the RN at the Skin Hospital, and I run a pigmentary disorders clinic with eczema and psoriasis. So we're going to talk to you about phototherapy as we do it at the Skin Hospital. But before we start, Glenda's going to just revise. Glenda's going to revise the basics of phototherapy for you. Thanks.
Okay, this slide's basically talking about UV and the skin. So we're going to be talking about there's three types of the UVB, UVC, UVB, and UVA. So the UVC just pretty much gets thrown straight back into the ozone layer. It doesn't come down to harm us. UVB, B for burning, comes down through the epidermis, and you've got UVA for aging, comes down into the dermis area. Now the photo on my right-hand side is talking about sunlight and phototherapy. When we talk about phototherapy, we're talking about 308 nanometers to 312 nanometers, which is quite a targeted therapy. It's quite safe and it's effective and works quite well in treating a lot of skin diseases. Okay, and one of the determining factors for working out our UVB dosages is going on the Fitzpatrick skin type. Now, it goes from 1 to 6. Skin type being 1, pale, burns very easily, going to skin type 6, which tans very easily, burns minimally, but does burn. That's one of the things that we wanted to stress. I'm a skin type 2 and I don't tan, I burn, whereas Manisha is a skin type 4 who would probably tan more than burn. Okay, some of the phototherapy devices we've got, you've got your body cabinet, which is a 360-degree cabinet, which has got a base of about 6 to 7 banks of lights around it. You've got various hand and foot machines to treat skin diseases on the hand and feet.
So, Glenda, can you remind the nurses if all phototherapy cabinets are the same?
No, all phototherapy are not the same. Sub-cabinets are a lot stronger and some are a lot less, depending on the globe. So you've really got to get to know your phototherapy cabinet when you're treating your patients, because the one that's ours at Skin Hospital's got 42 lights, but some cabinets can have up to 56. So you've just really got to know your machines. Okay, now we're going to be talking about targeted phototherapy devices. And for this, I mean targeted for smaller areas of skin disease. You're talking about the eczema, which is akin to a laser, but does use phototherapy lights. It is controlled by a handheld device, and it's got 6 to 7 different templates used for different areas of skin that you wish to treat. One of our other targeted phototherapies is also home-based phototherapy, and that's used for patients for the convenience in their own home. If they can't travel into a booth setting, they can do home-based phototherapy. It's quite safe, it's quite effective. It's also for targeted areas of home-based phototherapy, and we've got quite a large cohort of patients that are having home-based phototherapy. We're also going to be doing a research project on phototherapy use in Australia.
So just a reminder that all these phototherapy devices that we've spoken about are all using the wavelength between 308 to 3112.
Okay, common indications are also your eczema, hand dermatitis is quite common. Our other one is our psoriasis, gut-aid psoriasis, as well as plaque psoriasis. And we've also got vitiligo. So they're the most common indications that we tend to use for phototherapy, but there are other skin disorders that are used for phototherapy as well. Now we're going to be talking about dosing. And it's one of the most important things when you're doing phototherapy is getting your dosing right. And one of the questions is, how do you start? So I'm going to defer to Manisha for that one.
So starting dose for phototherapy is based on the patient's Fitzpatrick skin type. So fair skin patients, so given the risk for burning and tanning is how we decide on the dose. So rough starting dose for patients with skin type 1 and 2 is about 100 millijoules. 3 and 4 is about 200 to 300 millijoules. And the maximum dose we often use, starting dose, is about 300 millijoules for most of our patients. I'm aware that a lot of sites and centers use very timid dosing where starting dose is like about 30 or 50. But at our site, we are confident about using this because there's good recommendation to support that practice of Fitzpatrick-based phototherapy. And if you had any questions, you could always contact Glenda or Antoinette or anyone at the Skin Hospital to access our protocols for phototherapy that we use because we do get good results.
Another question is, how do you titrate your doses for phototherapy?
So titration, upping the doses is, again, different sites different practices will have different protocols. We have a percentage-based protocol, some practices. So we use about 10 to 15% for patients with eczema. Eczema patients, because they've got a sensitive skin, we use about 10%. Patients with psoriasis and vitiligo, we can use 15 and even up to 20% with patients with vitiligo of escalations from the starting dose. And there's a lot of maths. I know the nurses are always there with a calculator. So to simplify that, at some places we used an absolute increase. So sometimes we might say that some practices will increase by 50 millijoules every visit. So there's nothing wrong or right about it. Whatever works for you, whatever protocol you're familiar with, as long as you get there, whichever route you take is fine.
And how often do we treat our patients?
So most patients are treated 3 days a week during the active treatment phase on non-consecutive days. So mostly we use Monday, Wednesday, Friday. Yes, Annette, you have a question? Okay, so Annette's question is, what if the patient came 2 days in a row, say a patient arrives on Monday and Tuesday? What would you do, Glenda?
Yes, you can have your patients come in 2 days, consecutive days. You can come in on a Monday, as long as it's in the morning, and then come in on the following Monday, the Tuesday, the following morning. As long as there's a 24-hour gap in between, you can treat your patients on consecutive days, yes.
And you don't increase the dose?
Don't increase the dose.
So you can do that, but our protocol is usually this, yeah. And in the maintenance phase, we often treat patients twice a week. Anything less than that is not effective.
And when to stop the treatment?
So as long as the treatment is working for a given disease, given patient, it's okay to treat. Mostly for patients with psoriasis and eczema, they should notice significant improvement after 20 to 30 sessions. If it's not working, then this is not the right treatment for them, and that treatment ought to be changed. For patients with vitiligo, often about 60 to 75 sessions is when we bail out, and if it's not working, we'll stop. However, if for patients with vitiligo, there's no gap treatment. So we have patients who have been using phototherapy for vitiligo for over a year. So we have patients who, so as long as it keeps working for them, we keep treating them. It's safe to do so because we're using UVB. UVB is different from UVA. So you would remember about, for older nurses, you would remember about UVA and cap doses at 250 and things. With UVB, there's no capping. It's a very safe method.
This is one of our phototherapy charts that we use as a prescription chart.
So for instance here, this is really complex, and I'm really grateful for the nurses who do all this complex phototherapy that I recommend for my patients. So for the face, I would recommend a starting dose of head and neck for 250 millijoules. We're talking millijoules, you can convert to joules if you use that. For the body, it'll be the same starting dose, but the maximum dose for the face is going to be only 500 millijoules. And that's because the face in Australia, head and neck, gets a lot of incidental sunlight from just being up and about, while the maximum dose for the body is going to be 2,500. So it's about 10 times. And the effective dose is about halfway between starting dose and maximum dose approximately. While I'd say plus 250. That means the patient is going to go into the hand and foot machine, and the nurses are going to give extra 250 to hands and feet. And why we are doing that is because the skin on the hands and feet is very thick. It's slow to respond. So it's, and the maximum dose would be 5,000 millijoules. In this patient's case, the feet were not for treatment. So this is my recommendation for starting would look like.
And our next one's going to be talking about the patient has had a maximum dose of treatments, but they were treated in the face, hands and body. But now because they've successfully started to repigment, Dr. Gupta has now maintained that they can cover the face and they can go to a maintenance phase, which is now twice a week.
Yes. So for maintenance dosing, we can do twice a week when a patient has achieved good response. The face has likely responded completely after 150 sessions. This is likely a patient flowchart for a patient with vitiligo. So we need to titrate to the patient's needs. This is important. Phototherapy, there's a science and an art to phototherapy. Yeah, millijoules, yeah. Yeah, we would start a patient.
Which is 0.25 of a joule.
Yeah, so a patient with my color would start at 250 millijoules. 200 to 250, yeah.
But my skin type would probably start on a lot lower millijoules.
Yeah.
This is another one of our charts talking about the patient was originally maximum dose of 2,500 millijoules, but because they're not quite responding, we have upped the dose to 3,000 millijoules.
Yeah, so maximum dose on the flow chart is an indicator. Maximum dose is like maximum speed. You don't have to drive on the maximum speed. You are permitted to if you need to and conditions permit. If you've got a rainy day, a slippery road, or your vehicle is not up to the mark, you've got worn out tires, you will not be driving at maximum speed. Similarly, the aim of treatment is to get pinkness at whatever dose you get pinkness. So until the patient sees me, I will give you the maximum permissible dose that I want you to treat the patient with. And if you don't need to get there, it's fine, as long as you're delivering the results. So you've got to be objective-based rather than protocol-based therapy is what I would like to empower the nurses with. If you are getting the result, you don't have to follow a protocol. You are the experts in this. You need to be able to do those things. So you have the permission to go up to that dose, but if you don't have to, it's fine. If you're getting the response, it's fine.
And listen to your patients when they're telling you how they're going and how their response is going and whether you will put them up to the maximum dose or will you just hold on that dose depending on how they're going in their treatment.
Yeah, we'll talk about that in a minute when we come to, we're doing because during COVID times, we're getting the patients to use face masks. So we'll talk about that in a minute. Thanks for that question, Priscilla.
Okay, talking about phototherapy review. So when should the patient see the doctor? Generally, we don't use weeks, we prefer sessions. And the reason why we don't do weeks is because people have had a break, they have illness, the machine gets serviced, there are issues. So we prefer to use sessions. So for someone with eczema and psoriasis, they'll probably be going for 20 to 30 sessions. For someone with vitiligo, maybe to 40 to 50 sessions before they get reviewed by the doctor. And they're the reasons why we prefer the sessions rather than going by the weeks. Because we know a little thing called life gets in the way with the patient's treatment. They can't always come 2 times a week. Incidents and issues happen. So we prefer it to go by weeks rather than sessions. Sessions rather than weeks, sorry.
And it costs patients money to see the doctor, the dermatologist. So we do not want them to be consulted before they have achieved effective treatment sessions for assessment.
Missed breaks, missed appointments and restarting after a break. So Merry Christmas and Happy New Year, everyone. We at the Skin Hospital will be closed for 2 weeks. What would you do if a patient had to restart after that break?
So patients always will complain to me that after a break, the nurses, as per protocol, went right back to the starting dose, and they feel they're wasting their time and money. It's a huge commitment for time too, for them to be coming there 3 times a week. So my recommendation is, you know the patient, you know the skin. So you do not have to start right from the bottom, like the initial starting dose. It's okay to start halfway between and escalate rapidly, because you know how they behave, how the skin behaves, and get to the effective dose. Because the starting dose and the maximum dose, the effective dose sits somewhere in between. So you can do that, and that's my recommendation, and patients are grateful for that because they understand their treatment quite well. Remember that. So as for instance, I use all these colored marker pens, on my note so that they know that it's a different note. So I've said that restart, although the starting dose was 200, you start at 500 after the Christmas break and escalate rapidly, which means that like don't go timid 10%, be bold and go there 40, 20%, 30%, 50 joules, 60 joules, millijoules, sorry. Yeah.
Okay, we're going to be talking about modifications and combinations. So there are different doses to different parts of the body. So we're talking about split dosing, extra dosing, different devices. It's talking about either vitiligo or eczema or home-based phototherapy.
Yeah. So the commonest combination, we use a lot of combinations at the skin hospital and a lot of modifications, and patients understand how we are practicing this as an art, So as I said, split dosing, 500 millijoules to the face, a maximum, different dose to the body, different dose to the hands and feet. And we can see, even the registrars are quite surprised when they sit in the clinic to say, oh, I thought vitiligo on the hands could not be repigmented, but then they are quite flabbergasted or encouraged to see that it can if you use it properly. As I said, we do extra dosing. The commonest combination that we use is the cabinet and the hand and foot phototherapy machine, which you would be used to using too. The other thing that we often use is eczema. So patient goes into the cabinet for a whole body, and then they've got a targeted area which needs further boosting of the dose. Or during COVID times, we've been using home-based phototherapy for a lot of our patients, where they come into the cabinet only twice a week because of the number of sessions. We've got to reduce the appointments for phototherapy, then they'll do home-based phototherapy.
And the reason being is to improve efficacy, to reduce the cumulative UVB dose, and to minimize the long-term side effects of UVB.
So that's just an example about the commonest combination, as we said, the body and the cabinet booth and the hand and foot machine. Yeah.
Okay, now next slide is going to be really interesting. Talking about phototherapy burn, causes of pinkness. So we're talking about the treatment itself. We know that the treatment in itself is designed to create pinkness, to create that erythema, which is what we want, but it's learning to know the difference between the erythema and a burn. Has a patient got incidental extra sunlight? Have they been out and about and forgot to put sunscreen on? Did they go to the beach and forget to put sunscreen on, and they've come in and had treatment and they've ended up with a burn? Dilated blood vessels can also be a cause of pinkness.
Yeah, so nurses will sometimes come to me and say, Dr. Gupta, this patient's getting burnt, but we are only on about 200 millijoules, 250 millijoules. Why is this patient getting burnt? And when I look at it, the patient has had dilated blood vessels from previous use of topical steroids. So just have a background pinkness, and you can use a dermatoscope to look at that. And the patient's not sore, just pink.
Positioning also, making sure that your patients are standing on your foot plates or your, we've got 2 little red lines where you can place your feet in our machine so patients know where to stand, making sure they're not slouching, they are standing up straight in the machine and following what they're supposed to be doing. And also the undergarments, wearing the same undergarments every time you come in for the treatment. As you can see with this photo, someone's obviously worn higher underwear and then thought, oh, I'll just wear the normal underwear I've got and come in to have treatment, and obviously sustained a burn because the area that was covered is now uncovered. So they've actually ended up sustaining a burn. And the goal of treatment is to achieve persistent asymptomatic mild erythema. And you also being aware if your patients are obese, if they have got, if they are large-breasted women, or if they are pregnant, that you may find that some areas you will get more burning rather than pinkness in that area.
Yes, the body shape. whenever we change our machine at Liverpool, for instance, I'm going to get a bariatric machine because our patients are so big.
Being aware the size of your patients as well is very
So yeah,
important.
we have bariatric beds and we've got bariatric chairs in Southwest Sydney. I think we need a bariatric phototherapy machine too.
And the little photo with the flowers is just that healthy carnation pink is what we want your skin to be. Now, the next couple of slides, obviously with the little feet, is to do with positioning. You can see this gentleman's got burnt in the middle, and that was positioning due to him slouching in the machine. His back was further back, too close to the lights, instead of he was slouching. This other lady's just got positional where she's obviously had a bra and it's moved up. And just general checking your patients that they're standing in the machine at the right position and making sure they're not getting burnt.
So, Glenda, how would patients know where to stand? It's a big machine. There's a lot of room to move around.
We actually tell them, plant your feet about hip width apart, and there's usually markers on the floor. Some people have red tape. We have red tape where we are, or you can have footprints, and people can stand on those footprints knowing that's where they need to stand and where they need to stay. Instead of standing too much to the left or too much to the right or too forward or too back, they need to stand right in the middle of the machine to get the maximum benefit from the lights.
No, that's burn.
That's a burn. Because you can see the slight blistering. She's starting to get everything. She's starting to get the blistering. That's a burn. Okay, next up is going to be what we call our phototherapy burn protocol. But basically, if you take anything away from this, the three things that I want you to remember when you take away from this is basically asking the patient, is the area sore? Is the area tender? Are there any blisters present? Are you okay? Do you feel nauseous? Do you feel like you're feverish? If this is the case, if they are blistered and they are feeling very, very symptomatic and very unwell, I would recommend that they go to their nearest emergency department and be treated for that. But if they're not, they may use cold packs. They may take Panadol, simple analgesia, maybe Nurofen or some non-steroidal anti-inflammatory to help with that sort of pain. And we request that they do take photos so that we can actually upload them into their file so that we can record that they've actually had a burn. And we're also going to contact their treating dermatologist to let them know that they've had a burn. And if they are able to come in and have a review, we advise that they do come in and have a review so that they are seen, so that the doctor can do any more prescriptions if are needed.
Yeah. So nurses are a very important part of burn management. And anytime I've had a patient experience a burn, they've never complained about having a burn. It's because I did not speak with them when they sustained a burn. And that was often because I was not made aware of that. So making the treating doctor aware, it's a potentially a medical legal situation. And the patient, we've had an adverse effect from an intended treatment. It is important that we offer support and we apologize to the patient. What caused the error can be sorted out later. It may be the patient went to the beach or the patient had started a new medication. That's immaterial. At this stage, the first thing that we need to do is manage the burn. So obviously interrupt treatment and a photo would help, because the patients may later tell me that, oh, and I was so sore and it was so widespread and this happened. A photo speaks 1,000 words. So photo documentation, anyone can take a photo on their own phone. They can keep it on the phone idly. They can send it forward to us on an email. Otherwise, they can keep that photo and we can review that whenever they are able to see us.
Okay, next up, one of the commonly asked questions is, does phototherapy cause skin cancer? Now, the case study of a 50-year-old woman who was newly migrated to, next slide, newly migrated to Australia, and it was quite aware of the melanoma campaign and skin cancer awareness and being using SunSense protection. Now, one of the things that we want to know from Dr. Gupta is...
I'd like to throw that open to the room. What would you do if you had this patient who is undergoing phototherapy for vitiligo, is type 4, and is speaking with you before they come to me? They'll say, oh, I've had it for 6 months now, and I'm really worried. Now it's Australian summer and we see all these scary campaigns on what is my risk for developing a skin cancer? What would you say?
sun protection? If they're still using the phototherapy during summer?
But what is their actual risk? Yes.
Oh.
We are monitoring you closely. We are giving you all the protocols to follow beforehand. I'm sure you do that. And
Would you not confidently say that there is really no risk? Because there is no risk. No, there is no risk. There is no risk. There are good studies, thousands of cases, where we have looked at it, and the studies supporting that there is no risk for increased skin cancer of any sort from UVB phototherapy. The problem is the waters have been muddied from use of the UVA in the past, and UVA carried a high risk for skin cancers of all sorts. So I tell patients that there is no evidence to say that phototherapy increases your risk for skin cancer. The risk is the same as your background risk. You grow up in Australia, you have a risk for skin cancer. That's the same risk. You have the same risk. Like if a person of your skin type grew up in Australia and had, so phototherapy is not increasing your risks.
Dr. Gupta, I just wanted to know, with vitiligo, isn't there a situation where with vitiligo patients that peculiarly the white patches don't tend to get skin cancer as much anyway?
Yeah, so that's a good question, Annette. Patients with vitiligo have, and that's the paper that I'm alluding to, is that patients with vitiligo have no increased risk for skin cancer. And why might that be? Because skin cancers are a function of immune function of your body. Patients with vitiligo have an overactive immune function and overactive immune surveillance. Their risk for skin cancer is no different from the background population, whether from having the disease or having the treatment. Patients with psoriasis may have an increased risk for skin cancer if they've had cyclosporin in the past or have had UVA. There is a generation of patients. So those would increase the risk for skin cancers, or TNF alphas will increase the risk for cancers. Patients with vitiligo have no. So please be confident in reassuring your patients in saying that, look, we've looked at the evidence, there's no evidence. Be confident in reassuring your patients that the phototherapy that you're using for your patients is UVB. It is only part of the sun's solar spectrum, and it is very safe to use.
And what we do for our patients is after 150 sessions of UVB treatment, they do come in and they have to have a regular skin check.
And why would we do that? We do it not because we think UVB is causing the skin cancer, because anyone growing up in Australia has a risk for skin cancer. And we do it as an opportunistic check. Okay? And we don't know what they've had in the past, you know. They may have been on an immune modulator or an immunosuppressive medication. So we do an opportunistic check for our patients after 150 sessions.
And also if they've found a lesion or they think is suspicious looking, that they've noticed is changing color, or they've just noticed it, you can always refer them to the dermatologist and get them to have a look at it and give them reassurance that, okay, we'll get this checked out. It may be totally unrelated to them having UVB, which it highly is unlikely that it is caused by UVB, but if there are any concerns of the lesions, you just get the doctor to have a look at them.
Yeah, most will become darker. So you're fine. We're happy to assess them as required. You can take a photo of the mole of concern so that you can add it to the file, and we remember to address that when we see the patient next.
Okay, up next is going to be a case study for targeted phototherapy of a little 9-year-old girl who was having cabinet photo-based therapy, and her parents weren't working, so they were able to bring her in 3 times a week. But then their circumstances changed and the parents were going back to work and she was going back to school. Now, this little girl had vitiligo around her periorbital area, as you can see here.
So initially she had vitiligo all over the body. By this, after a few sessions of 6 months of treatment, her vitiligo was limited to the periorbital area and around the chin. Eczema would have been a good option, but that would still involve bringing the child over to the clinic. So we offered the family home-based phototherapy, and the parents were really committed. We had a really good result from that.
Again, on her neck.
And complete repigmentation. She's got a patch too. I only saw her yesterday, I think, and she had 2 patches on the knees, which are repigmenting quite well. These are thicker skin, so just explaining the dosing, you know. So we have a service where any dermatologist can refer a patient to the home-based phototherapy clinic, doing a referral to say, dear phototherapy nurse, please instruct this patient or educate this patient on home-based phototherapy at a cost of $55. The nurse can do Skype consult or a face-to-face consult. The patient is not owned by me. The patient continues to see their treating doctor, but the education is provided by a skin hospital nurse.
Okay, now knowing that we've been into COVID for nearly 2 years, how does that affect phototherapy?
Okay, so we have not had to interrupt phototherapy at any of the sites except at the hospital, Liverpool Hospital, and that too because our nurses were going to COVID wards. Our dermatology nurses were deputed to COVID wards, and I have to really appreciate that they did that without a whinge. So we've been complying with healthcare orders. So any patient who wants to continue phototherapy during COVID, we've encouraged. In fact, some of them were at home and they were finding it more convenient to attend, and they were more regular with treatment. We've had fewer sessions. We've spreading out their appointments because we can't have a room full of patients waiting. So that has restricted the appointments. We're spacing out appointments for our patients. We are getting them to keep the mask on because that's what the public health order is, for people to use masks when indoors. And as Priscilla asked, so what happens if a patient has disease on the face and they want their face to be treated? So our recommendation is heliotherapy, which is sunlight exposure. Because if they don't remove the mask, they'll get a face tan from being treated in the booth. So we get them to cover the face, and heliotherapy means shut their eyes, raise the face to the sun, exposed to off-peak sun exposure before 10 or after 3 for 15 to 20 minutes. And cloudy days is fine, I tell them, because enough UV radiation penetrates the cloud cover. So we might be doing them cabinet in the body, the body in the cabinet, hands and feet extra in the cabinet, but the face may be treated with heliotherapy. And then what we're doing is we are minimizing eczema. We're not doing large areas or multiple areas because we are minimizing the time, not more than 15 minutes of intimate contact with a patient in a closed environment by the nurse. So yes, as I said, we are using combinations. We've actually used, we've got over 50 patients on home-based phototherapy now because of the COVID restrictions, where people are unwilling to come, unable to come, or coming infrequently. So we are now doing a study on home-based phototherapy. We hope to be able to share those results in the next ASM in April, May.
Okay, one of the other things that we do and where we are at the Skin Hospital is also camouflage. Now, we had a 48-year-old woman who came in with areas of vitiligo around her periorbital area again. She was very, very distressed and very upset about this, wore glasses all the time because she felt that it distracted from having to look at the vitiligo. She was refusing to go to her niece's wedding because she felt that this was just so disfiguring for her, so she declined the invite. So she came to the camouflage clinic.
Yeah. So when any treatment that we offer to our patient is going to take a few months to start working. And the patient walked in distress looking for an immediate answer because we are like a tertiary or quaternary referral clinic. So we are it, the buck stops there. So we have a camouflage service. And what we offered her was, yes, creams to apply, phototherapy, but we also, I think she chose eczema from memory because it's going to be quickest, but it's going to take a few weeks still. So the niece's wedding was imminent, and she had a consultation with one of our nurses at the camouflage clinic and walked out smiling because she was taught how to use a product. So we use a variety of products, we color match them, and our nurses are quite skilled in doing this. And we did a satisfaction survey, and our patients have been very satisfied with the camouflage consultation. Again, that service is not limited to our patients. Anyone can be referred at a small cost for a camouflage consultation, whether it's a patient with acne or eczema or a birthmark, and of course, vitiligo or melasma, they can have a consultation in the camouflage clinic.
Okay, and our last slide, but not least, we're talking about vitiligo surgery. If you have exhausted all the other options, you've tried eczema, you've tried home-based phototherapy, you've tried phototherapy in the booth, and or nothing else working, nothing else is responding to any UVB light therapy, then you may be referred for vitiligo surgery, and that's non-cultured melanocyte transfers.
Yeah, Thanks for that, Glenda. So for patients who have maximized medical treatment options, and if you notice carefully, this patient's got white hair. We call that leukotrichia. Once a patient has leukotrichia, response to treatment is less likely to occur, which means they've got burnt out vitiligo. And I try to explain to patients that we have this concept of dead and dying melanocytes. We can revive them if they're dying, but if they're dead, we don't have a chance of reviving those melanocytes. The hair is the reservoir of melanocytes. When you do administer phototherapy, you notice that these are little dots that first appear around the hair follicle. So that cannot happen in this patient, and they've got a large patch. So pigment cannot migrate from the edges. So we are offering surgery to our patients if the disease has been stable for at least 1 year. If they're adults, we are only doing adults at this stage, and if they're able to afford treatment. But fortunately, because of our trial, we've received funding from one of our registrars as once a scholarship, and we are doing a research trial for this. This is a relatively subsidized treatment for our patients, and we hope to share results from the surgical options hopefully in a year or so.
We'll actually be doing a patient next Thursday.
Yeah, we've done over a dozen patients already, but we're going to be doing a series now as part of our research trial.
And the results are very encouraging. Some of our patients have repigmented on the smaller spots they've had surgery for.
Yeah.
Okay, last one is comments and questions. Anybody got any questions?
Any questions? Anything that comes to your mind? Feedback, comments, anything?
I know it's 4 o'clock in the afternoon and you all just want to go home now. There's one more speaker after us, so come on, pipe up.
Yes, please.
The light, you had a slide up there. It said that it increased the incidences of actinic keratosis, but not basal cell carcinoma. So the UVB does affect the skin and burns it?
Yes, it causes photoaging. It does. We burns, but we're using it in a controlled manner. We hope to not burn the patient. UVB burns ages because A penetrates deeper. So there will be a degree of photoaging for a patient, and that's why the skin becomes dry. It also becomes darker. And that's another thing to remind darker skin patients is that they're going to become darker. They don't like the tan.
So if the incidences of AKs go up, won't other non-melanoma skin cancers
No, we're
go
not
up?
causing enough damage, remember? So for hundreds of actinic keratosis that our average patient has on a skin check, not everyone will have, they say that like 95% of Australians of Caucasian heritage will have at least one actinic keratosis by 50 years of age. But not everyone will have a skin cancer. So the damage we're causing is of a lower grade and is more controlled.
I was curious about the non-cultured transplanting that you're doing. Are you allowed to say a little more on that? Is it to do with punches or is it to do
No,
with...
not punches. So in principle, what happens is that what brings color to your skin is melanocytes. Shall we have time? Can I keep going? Yeah. So what brings color to the skin is melanocytes. They are the cells, but keratinocytes do have a role to play in pigmentation. What we do is so we've got, if you have the opportunity, look up a study we did, the Skin Hospital Protocol for Vitiligo Surgery. So we have modified it significantly to make it very simple. And what we do is we will take a small, I will harvest a small thin split graft from the patient's bottom mostly. We'll put it through a chemical process, we incubate it, and through a chemical process, we separate out the dermis from the epidermis. We collect the epidermal cells, we prepare a suspension of that. So we've got a liquid there, a thick liquid, and then we prepare the recipient site where we want the pigment to be restored. We prepare it with a special technique with hyfrigation, not lasers, not dermabrasion. And this is something I modified. That was my modification. And then once we prepared the we basically just take off the epidermal cells gently. We place the suspension on the prepared site, apply a dressing, send the patient home. And to date, we've done over a dozen cases. And the first few were not very good because we were using a manufactured device and that limited the amount of material we could, an area we could do, but now we've modified it. We use our own chemicals. And we've had in the past 5 or 6 patients, we've had really good results. No. That's old fashioned. I mean, I would do it. I have done it for over a dozen patients in Australia, but that's.
You're making me feel old.
That's.
I was involved in that.
Yes,
right
I know,
early on,
but
years ago.
there is a risk for cobblestoning, and you're giving excess tissue. It's a bit the difference of putting a full thickness graft versus a split thickness graft. What is the tissue you need? All you need is melanocytes. So this results in a very good textural match, and it's not a paintbrush benefit, but the punch grafting, I do it on the limbs, smaller areas. If the patient's got just one small area, because you can apply good pressure.
Gotcha.
So I will do that. Yeah, I still do that. It can be done in combination, but yes. No, I'm really glad that I have an engaged audience. Thank you. As long as time permits, yeah.
I was just wondering what the downtime would be. I remember Pat Fager talked a little bit about something like that, and it was like a week that these people had.
It is, the dressings are
dresses
left on for a week, and same for the grafting on the hip. And then they come back after a week, we take down, we have a look at the change of dressing on the skin graft site, and then we're also going to take that dressing off because it's occlusive, but we don't want it to stick to the wound, but we want melanocyte suspension to actually stay on the skin and not to ooze out. So they're very restrictive in their movements, particularly if they're on their face and they've got to bend their head forwards. They've got to rest, really take it really, really easy, because we don't want this suspension to move, to leak, to be knocked or bumped.
Yeah.
So the downtime is a week.
Yeah, it's about a week only, but the color is not immediate. They won't see the color when we remove the dressing. The color comes back in about 6 to 12 weeks. You can read that paper, that's got photos. And if you have interest, you can look at the DermNet article on vitiligo surgery, and the punch grafting is one of my patients there. We wrote up the article there.
Any more questions?
Questions anymore?
All right.
Thank you, everyone. Thanks
Thank
for
you.
your engagement. Bye.
Okay. Thank you very much for that lovely presentation. Our next presenter is a fellow of the Australasian College of Dermatologists. After completing his dermatology specialist training in New South Wales as the inaugural Dean's Fellow in Dermatology, a joint initiative with the University of Sydney. He underwent world-class research and dermatology training at St. Vincent's Hospital, Royal Prince Alfred Hospital, Liverpool, and Westmead Hospitals. He also completed his PhD in advanced biomedical imaging and skin immunology at Centenary Institute during this time. Dr. Tong has lectured nationally and internationally on all aspects of skin. He is passionate about education and provides workshops and facilitates online learning modules for GPs, nurses, and pharmacists. He is a VMO at St. Vincent's Hospital in Sydney, as well as Deputy Director of Research at the Skin Hospital in Sydney. He is a member of the All About Acne expert panel and is in the private practice in Bondi Junction, Sydney. Please welcome Dr. Philip Tong.
Feel very tall on this stage. I'm not sure whether that's intended or not. How's everyone's day been? Excellent. What a fabulous line of speakers, and it's really a hard act to follow after Dr. Gupta's fantastic talk. So I'll do my very best to close the day, but I understand you've got some fun with raffles after this talk, so something to look forward to. So before I talk about my disclosures, I thought I'd just give an overview of what to expect of today's talk. I was asked to speak about trends in acne, and you could talk about acne for hours just because of how many people it affects and how everyone has an opinion on acne. But today I'd like to present to you some of the, certainly some of the recent conferences that have been happening virtually this year. And I just pick out some of the highlights that I felt will be relevant for this audience, being predominantly nurses. And then finish off by my own personal experience with my acne patients and essentially a word on the street with some of my patients and what I've seen in these patients. So without further ado, as I said, as I was introduced, I'm one of the panelists for All About Acne. That's a not-for-profit organisation raising the profile of acne education. So if there's ever a resource that you're looking for particularly for your patients, I would certainly go there, and there's some really good information for your patients and also some educational material. Certainly, Kurt Gebauer, Joanne C, and myself are very excited to be part of this and to spearhead the panel across Australia. These are some of my previous speaking engagements, and they've been very kind to invite me on previous occasions, as well as some consultancy work. So most recently, the International Congress of Dermatology went by, or it was originally planned for Melbourne, and it unfortunately ended up being a virtual congress. And one of the talks that came out of that was Dr. Seth Orlow from the United States, and he presented quite a thrilling abstract on the role of diet and acne. And what do we know about diet and acne? Well, from observational studies, it certainly has been found in Western diets, an increase in the amount of acne in Western diet, and associated with that, those of wealthier countries. And interestingly, the flip side is also true. So it's not found in populations with predominantly a plant-based diet and lacking dairy as well. So these are some of the initial clues to point out, is there a dietary influence in acne? And so far, it's always been fairly controversial, but there's some emerging evidence to say there is a role to play, and this may inform you when you're counselling patients and seeing acne patients within your various practices. And what about acne and glycemic index? Well, acne is certainly found in patients who have a high glycemic index diet compared to normal controls. What do I mean by glycemic index? Or those foods that, or high glycemic index is those foods that put up your blood sugar level. Whilst low GI diets in randomized control trials have been shown to decrease acne lesions. So there is a role to play in terms of counseling patients in terms of their dietary influences on their acne. So when a patient comes to see me and says, Doctor, what can I do with relation to my diet? Well, I think there's actually early evidence to say there is an influential role of diet there. Unfortunately, further studies are required in this area because there are conflicting studies saying the opposite. And even diet seems to have an effect on treatment as well. So those treated with isotretinoin and have a low glycemic index appears to be more sensitive to the effects of isotretinoin, whereas those treated with 2.5% benzoyl peroxide appears to have no influence on diet and the response to 2.5% benzoyl peroxide. What about dairy and acne? Well, a self-reported study, in fact, this was actually performed in nurses, demonstrated that milk and skim milk consumption resulted in an increased amount of acne lesions. And further prospective studies further demonstrated that in women, acne was more prevalent across all milk types. So that's half fat, skim, full fat milk, half and half, all those various United States variations of milk. But not found in non-milk dairy, chocolate or pizza. So you can go to town with the chocolate and pizza, and that would be okay. But it's actually the whey and casein within milk that actually causes the acne and the kind of insulin growth factor 1 response. A lot of my patients, particularly the blokes, you can tell if they're bodybuilding. I do ask them whether they're taking whey, and indeed whey has been shown to increase insulin and can increase IGF-1 as well. So if you see a bloke, particularly with truncal acne, it's worthwhile asking them, are they on whey supplementation? Moving on to acne scars, some of you may or may not be doing microneedling within your practices. As you all know, it's a controlled skin injury which stimulates dermal wound healing. resulting in neovascularization and neocollagenesis. So it's a very good treatment for the treatment of acne scars. It's a fairly low-tech treatment, and compared to lasers, fairly inexpensive as well. It's important to select the appropriate patient, so those with atrophic or shallow scars with or without post-inflammatory hyperpigmentation. So the reason why microneedling is particularly useful is it works across all skin types, which is particularly relevant when treating Asian patients who are prone to post-inflammatory hyperpigmentation. It's really important to note that these patients shouldn't have active lesions at the time of treatment, and that aspirin, vitamin E, ginkgo biloba, and other these kind of blood thinning medications should be stopped 3 days prior. This was the advice of key opinion leader Jasri Sharhad at the International Congress. She practices in Mumbai, India. In terms of the post-procedure care, those who are familiar with it, it's post-procedure care, make sure the area stays clean, and afterwards apply, they do controversially say apply a thin smear of topical antibiotic to the treatment area. She recommends systemic antibiotic cover, and certainly you can understand why, and to avoid sun exposure and any harsh scrubs to the skin as well. She goes on to talk about in her presentation the use of PRP, both injected and topically. I'm not sure about the evidence of PRP, but there's certainly a lot of investigation with relation to the use of this PRP in this setting. So I think the jury's out there. In terms of tricks in darker skin types, she mentions use of pigment stabilizers as well as skin lightening agents, particularly the preceding 4 weeks prior to treatment is very useful. And then combining with different modalities, for example, depending on whether you or not these patients have post-inflammatory hyperpigmentation or not, to combine it with other modalities such as energy-based radiofrequency, chemical peels, or even non-ablative fractionated lasers as well. It's really important that these patients avoid skin trauma 1 week prior as well as 1 week after. So no hot waxing or needling or anything like that prior to the microneedling treatment. So moving on to the recent EADV Congress in September, Maurice Adato, who is a dermatologist, I believe, in Switzerland, presented what we were talking about before was acne scars. This is now the use of energy-based devices in active acne, so inflammatory acne. And this was quite a surprise to me, because as a medical dermatologist, I thought the only mainstay of treatment is topical and oral medicines. However, I think particularly in the United States, whereby the use of isotretinoin is potentially quite limited because of the I-pledge and the requirement for monthly pregnancy tests, the use of energy-based devices could be potentially, could play a role in inflammatory acne. So the mode of action would be to target the sebaceous glands or the oil-producing glands with wavelengths in the mid-infrared range, such as in the millisecond lasers, and there are some lasers listed there, as well as in the microsecond lasers as well. He also mentioned other energy-based devices, which you maybe have some experience with in your practice with RF and RF with or without microneedles. The aim, of course, with some of these treatments is to also suppress Cutibacterium acnes as well as reduce sebum excretion rate. He then went on to present a number of previous studies that have shown the use of these lasers to reduce active acne with quite a nice reduction, 73% reduction in active acne at 2 years. Furthermore, he talks about this 1340 ND YAP, non-ablative fractional subdermal laser, to be useful with active acne as well. The alternative would be to use a 1064 ND YAG. There is a setting on those machines available. I don't use it, but thought to be less painful than the millisecond lasers. Looking at the energy-based devices, fractionated microneedling RF and nanofractionated RF are two types of energy-based devices that has been shown to have some effect in active acne. He also went on to present an interesting abstract on the use of nanogo particles that have been selectively topically applied onto the skin prior to the use of a diode laser, and those nanogo particles was activated with the diode laser in order to reduce the active lesion counts in patients. So the summary was 76% of patients achieved greater than 40% improvement in the acne lesion counts. So what about acne scars? No doubt some of you may be involved in counselling or even treatment of patients with acne scars, and undoubtedly patients are very keen to ask, when will my scars improve? Will they improve on their own? Will my medical treatment improve my acne scars? Well, it's not an easy question to ask. However, as in general, acne scars are defined as a loss of tissue due to acne-related inflammation. And in general, we know that the more severe the inflammation, the more severe the acne scarring. However, the take-home message from this slide is that even in mild acne, 28% also exhibit acne scarring as well. So just because someone has mild acne doesn't mean they can't scar. The natural history of scars in patients with moderate acne is that 36 resolve within 6 months. So sometimes it's really important to let patients know that even though they have scarring that you can visibly see, it might be worthwhile just to wait it out. And a third of these acne lesion scars may actually improve with time. So, and then you come across as a hero. And then in terms of the rest of the scars, unfortunately, only 20% resolve at the 2-year follow-up. He Vincenzo concluded his talk by advising that it's important to minimize risk factors, treat early and avoid manipulation, and then went on to discuss the use of even topical preparations to reduce acne scarring. I'll cover physical therapies a little bit later, but the approach is otherwise to define the type of scar that you're looking at, focus on the obvious ones and the ones that the most concern the patient. A combination of treatment options is often best, and consider the patient's skin type, as in the previous abstract that we presented on microneedling, as well as the patient's previous experience. And do counsel and do inquire about a patient's expectations, whether there's an associated body dysmorphic disorder that you may run into trouble with. So always speak to your patients, speak about their previous experience, and take a stepwise approach is my best advice here. So I know this was quite a long time ago, but this was the college meeting earlier this year in April, again, a virtual meeting. And I thought it would be quite relevant to discuss the concept of the skin-gut axis. If you think about the human body as a donut, we have essentially the outside of the donut is the skin. But if you think about the inside of the donut, that's really the gut, right? So, and everything in between. And if you think about the immune system, the immune system and what the gut is exposed to can potentially educate the immune system, which informs responses in the skin as well. This journal summarizes that acne patients have a distinct gut microbiome as opposed to those that don't have acne. Certainly those that have a reduced diversity and low abundance of certain these microbes. The use of probiotics in acne is inconclusive, and there's due to probably poor study design and variation in terms of the intervention. Going back onto dietary influences, saturated fats and high glycemic index load certainly do play a role in acne, and these are some of the mechanisms behind the cause of that. Ultimately, it results in increase in fatty acids and triglycerides in serum and stimulates the growth of Cutibacterium acnes. What about emerging therapeutics? Well, this is now finished phase 2 trials and go into phase 3. So undoubtedly, many of you may be required to discuss this with your patients in terms of the counselling and side effects of this, but at least be aware of it, that there are new and novel topical applications in acne. And this is the first-in-class topical androgen receptor inhibitor. It can be used in both men and women, and it blocks the locally produced and circulating testosterone on the effect of the oil glands. And it also inhibits the synthesis of these inflammatory molecules that results in the active acne lesions as well. So yes, it's gone through phase 2 studies. Unfortunately, there was some abnormal alterations in the HPA axis, but these returned back to normal in 4 weeks. Otherwise, it was well tolerated. In terms of the adverse events, like with most topical agents, these patients experience pain, irritation, and sensitivity. It's thought to be a comparative study was performed with topical tretinoin at 0.05%. There was a trend, but did not reach significance. Onto isotretinoin. Not that many of you will be prescribing isotretinoin, but certainly involved in the counselling of isotretinoin. This abstract talks about the use of biotin on improving the skin changes that are associated with isotretinoin use. This study measured the effect of isotretinoin on hair loss, transepidermal water loss, and skin hydration at baseline and at the 4th month, with and without biotin. And it was felt that skin hydration was maintained. They had a decreased telogen hair ratio and an increased anagen hair ratio, thereby assisting with the hair loss. However, it's only a very small study, but the preliminary results are promising. There is a caution, if you like, of blanketly recommending biotin because it can affect blood test results in patients on thyroid hormone replacement. So just speak to your dermatologist if there's any concerns about recommending biotin, but overall it's quite well tolerated. So concluding the talk would be kind of my take on what's word on the street. So no doubt many of you would have come across a lot of acne during this COVID pandemic period, and that's been, there's a term called maskne being coined during the COVID pandemic, and it's essentially a variation of acne mechanica. The triggers are obviously often due to the disposable nature of these masks, causing a follicular occlusion and mechanical stress, resulting in the inflamed acne. There's also a dysbiosis, so affecting the skin microbiome, causing changes in heat, pH, and moisture. Certainly, wearing the mask can also flare up other conditions such as rosacea and periorificial dermatitis. How do we manage this? So certainly simple measures are best: cleansers, moisturizers, niacinamide, azelaic acid, and retinoid. Minimize makeup. The little diagram on the right is just a tease, just because not everything you see on social media, even if it's reported by a dermatologist, is factually correct. She recommended spraying the inside of the mask with her product in order to prevent maskne. I just wonder about the how useful that is long term, particularly the actual function of the mask if you actually spray in the inside of the mask. Nevertheless, there's also new developments on biofunctional textiles, for example, those that contain antioxidants and have anti-aging products, and those that are biocidal. This is an emerging space, very exciting, very interesting, because I think a lot of us will be wearing masks moving forward. Bakuchiol, this was turned a plant-based retinol alternative. No doubt many of you may have some experience with this ingredient. It's found in a number of over-the-counter preparations. It's thought to improve wrinkles and help with skin firmness and pores, and thought to be less irritating than the traditional retinols. This abstract talks about the potential role in acne, particularly in mild to moderate acne, as well as acne and skin of color. So watch this space. Potentially quite an interesting ingredient that could be recommended to patients who have that increased sensitivity to topical retinoids, whether it's prescribed or over the counter. Fat ingredients, why is your patient not improving on treatment? Well, they could be using a lot of other things that you might not be aware of, and it's really important to either, you'd be surprised actually, if you actually get them to bring what they use on their skin. They might bring their entire medicine cupboard, and then it might cover your entire desk, and you spend the next 5 to 10 minutes telling them what not to use. And they're so surprised because you've just saved them so much money from the amount of products that they don't have to use, and you know, not to go all out on those Black Friday sales. Vitamin C can be an irritation, has an effect on reactive oxygen species and dysbiosis. Whether or not it truly has an effect on acne remains to be seen. Niacinamide could be an irritant at high concentrations, worse when combined with alpha hydroxy acids and BHAs, but certainly do play a role in skincare. It's one of the few, I would say, ingredients found in over-the-counter products that I would recommend just because of its anti-inflammatory effects on skin. Witch hazel and tea tree oil cleansers, I'm very dubious of this, and I often give a very shocked look when patients are using even neat tea tree oil on their acne pimples. But it's not the worst thing I've heard. There's other things like, I don't know, toothpaste, which is often talked about in social media, but certainly I think most people have moved beyond that. My last slide is acne patches. These are hydrocolloid based. I think they were really popular overseas, particularly in the East Asian countries like Japan and Korea. They work by preventing picking. So there's that haptic feedback. So, oh my gosh, there's a patch there, I better not pick it. So that's one of the ways that these patches work. And because of the hydrocolloid based dressing, they promote moist wound healing. Moving forward, there are these developments in these acne patches that contain tea tree oil as well as salicylic acid. It remains to be seen whether or not they're truly effective, but everyone wants to try to innovate in this space and treat acne their own way. But I hope you found that useful, and happy to take any questions if there's time for questions. And thank you again for your attention and for having me here today.
When you said with the acne patches, is there any antimicrobial or anything in the patches, or is it just a little hydrocolloid dressing you put on it to stop the picking?
Yeah, good question. So from my understanding, the available patches are just a hydrocolloid dressing, but there's a lot of innovations in this space to potentially modulate the microbiome as well as deliver drugs. These patches now have what can be considered microneedles that deliver tiny amounts of these active ingredients through the patches. Whether or not they actually truly have a clinical benefit remains to be seen, but it's just another innovation.
Philip, hi. Hi. Two points. Isotretinoin, is there a reason why GPs aren't allowed to prescribe it? And do you think there will come a time when they are allowed to prescribe it?
Yeah, that's a really good question. And I think that's been recently debated in an MJA article written by a general practitioner. Certainly in New Zealand, my understanding is that general practitioners can prescribe isotretinoin. Here in Australia, certainly that's not the case. It's prescribed by dermatologists, and in certain states even, you need a special number, I believe, either in Victoria or Queensland, in addition to your prescriber number, in order to prescribe isotretinoin. I think if you were to look at the literature, there's been some work done out of Westmead demonstrating the number of complications arising from inadvertent isotretinoin prescription by non-dermatologists in this space, and you'll be quite shocked about some of the catastrophic events that can happen when isotretinoin is prescribed by non-dermatologists. Again, I think this is an area of continual debate, and certainly happy to discuss it with you a bit more after today. That's not a problem.
Any other questions? I think that's it. Thank you very much. Now let's move on to the raffle. Yeah. So we have 2 more prizes to give away.
Hello, everybody. I just wanted to get us all to say thank you to Shelley for such a professional day. Thank you very much. And thank you to her helpers. Also, thank you to all the sponsors. You are very generous, and it's been a really great day. Another thing. Oh, remember the ADNA conference next year. I can't remember whether it's April or May, but it's joined with the ACD again, as we normally were doing. And it's in Adelaide. And lastly, if you haven't actually signed in, please could you sign in? I've got the papers with me just up the back of the room. So before you leave, if you could sign in just so that we can do the certificates and things for today. And you will be getting an email as well, just to put your preferences and the things that you liked or didn't like, so we can collate it like Shelley said. So we'll do the raffle.
Okay, so let's call on Amy from Bioderma. To be honest.
Vivian Spears.
You want to give that away? Okay, let's redraw.
Leslie Rhodes.
Thank you. Now let's call on Min from Ego. Last but not the least. Just one.
Just one. You're all stuck together.
Yun C. Oh, yay. Congratulations.
Congratulations. Welcome.
You want to do that honor? Yeah. Yes. So the last one, apparently there's one more, which is the member draw, and you will win $500 to go to the conference next year.
If I'd call a number, and if I call a name and you're not yet a member, you can either quickly join or just let me know and I'll redraw. Okay. All right then. So this is, oh, I know this person, Glenda Newham.
Or just, yeah, come on over.
So Narelle and Karen are watching from Victoria, and so they can have a note that Glenda has the $500 prize. Hello.
I would like to thank everyone for coming today. Thank you to all our sponsors. I would also like to thank our volunteers for the day. Andrea Tan, just raise your hand there, Andrea. Thank you. Round of applause for Andrea. Kyle Yu. Allison Ridge. Thank you, Inga. And Viv, of course, yeah. Again, just a roll up, thank you to all our sponsors, Ego, Propera, PearFab, Sun Pharma, Medologic, UCB, Galderma, Lilly, Dermasensa, Sanofi, Bioderma, La Roche-Posay, Ellipto. Did I miss anything? Oh, it's on the screen, of course, L'Oreal and AbbVie. Thank you so much, everyone, and see you all next year. And there's a phone left in here as well. Whose phone is this? Oh, okay. I'll give it back to you.